Team, can you please stop sharing? Thank you. Good morning, ma'am.
Yeah, good morning. Hello, Mr. K. How are you?
Yeah, fine, ma'am. Good morning, Yasmin, ma'am.
So are we waiting for others to join? I can stop my video, or you want to see the screen share?
You can try, ma'am, once.
एक बार करें?
Ma'am.
Okay. Can you see this?
Yeah.
Okay, I'll start from the beginning. So anybody is going to introduce?
Yes, ma'am.
Okay. So you can see my first slide, right? I don't have a video. So it will just go like that.
Okay. Ma'am, 20 minutes is your session.
I know. I'll just see to that I'm in time.
Perfect.
Okay, should I stop the screen share?
Yes, ma'am. Yes, ma'am.
Okay, just a moment. Go to the first slide and then stop.
You joined from clinic?
Sorry?
Joined from clinic?
Yes, there was no internet at home in the morning. It was a big shock to me. I had to run to the clinic. Although my clinic is working on Sundays, I don't work on Sunday. So I'm here. Yeah.
Yes, ma'am. Good morning.
Good morning. Okay, shall I share my screen?
Yes, madam. Yes, madam.
Good morning.
Good
Good morning,
morning.
ma'am.
So it's visible?
Yes,
Is my
ma'am.
screen visible?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Yeah, perfect.
Good one. Right.
Can I see my presentation?
Yes, ma'am.
Yes.
Savita, ma'am. Good morning.
Good morning. Is it visible now?
Yes, ma'am.
Yes.
Is it full screen or?
No, ma'am. It's not full screen.
Not it.
Now is it fine now?
No, ma'am. Not full screen yet, ma'am.
Is the last cursor. Last.
Next one. No, no. After that, ma'am.
After that.
No,
Cup
not
shape. Cup shape.
Slide sorter or reading view?
Next,
reading
ma'am.
you. There's one more
Okay,
thing.
okay.
Yeah.
Slide show.
Yeah.
Yes.
Is it fine now?
Yeah, perfect.
Yes.
Yeah, perfect, ma'am. No issue. Savita, ma'am, you can do one.
Yes, I'll share.
Yeah, ma'am.
Thank you.
Seen, right?
Yes, ma'am.
Yeah.
Thank you. People flash the CV once. And it is your CV. I made the changes.
Yes.
Both the changes are made.
The previous slide, it's not changed. Here.
Okay. Yes.
Hello,
Yes.
Dr. Savita.
Hello, ma'am.
Hello.
How are you?
Fine, ma'am.
Hello,
Yeah,
ma'am.
good morning, sir.
Namaste.
Good morning, sir. Good morning, Kirti, sir.
Yeah.
So we'll start exactly at 10, right, sir?
11.
11.
11, sorry, sir.
Yeah, good morning, everyone.
Good morning.
Morning, ma'am.
So directly we'll give the countdown and then Rashmi ma'am can start with the opening remarks.
No, first Dr. Sunil will welcome, then hand over to Dr. Rashmi.
Okay, so he will hand over to Dr. Rashmi and then Dr. Rashmi will introduce.
Yeah. Ma'am, Rashmi ma'am, just will take you through the proceedings now. First, Dr. Sunil will start from Dr. Reddy's Medical.
Yeah.
He will welcome all the delegate attendees. Then he will welcome and introduce you, ma'am, as a course coordinator. Then in return, you can do context setting. Then you can welcome and introduce moderator Dr. Sonali Langar, madam.
Sorry, what was the last line?
Ma'am, after you can welcome and introduce Dr. Sonali, madam.
Okay. So you have a slide, no?
Yeah, I'm showing it.
You have an introduction slide?
Yes, ma'am.
Good morning,
Okay.
ma'am.
Good morning. What is this publications presentation? Acha. Okay.
Good morning, ma'am.
Good morning.
Good morning, ma'am.
Yeah, good morning, Sonali.
So Dr.
Good
Sonali.
morning, Kavita, Yasmin,
Good morning, ma'am.
Savita, Aman.
Good morning, ma'am.
Morning. Whoever I can see. Trying to do that.
Then Sonali ma'am will introduce Dr. Atota Kavita madam first. Then Dr. Aman Dua. Then Savita ma'am. Then Dr. Yasmin.
So it's the International Women's Day Trichology CME, isn't
Yes,
it?
Yes, ma'am.
In association with Dr. Reddy's, right?
Yes, madam. Yes, madam.
That's how we go about it. Okay.
We are in the first page itself. We are written like that.
And the second one,
ma'am.
the second one starts at what time? 3 o'clock?
3 o'clock.
2 o'clock.
3 o'clock. 3 to 5. So this is all about the.
I may not really be there because I have a lot of other things, but this one I'll be there.
If possible, you could join at 2:55 and you can log out by 3:15.
I'll try, but there are a lot of things going on actually. That's why I don't want to promise.
Okay.
There's too much work to finish.
Yes, ma'am.
So how many people have joined? Any idea?
Ma'am, people will join at 11 o'clock. Now it is still 10 minutes. There.
Sure. Whenever. So do tell us then.
Yeah.
So I'll also say that this is a part of the hair forum activities which IWDA had planned to do with this thing, Dr. Reddy's. We had planned to do a hair forum activities.
Yeah.
So Sonali, you're looking very intellectual.
That I was also about to say the same thing.
Sonal madam, Rashmi madam will introduce you as a
Yes, yes, I
moderator.
got everything.
Yeah,
Thank
you saw that, na?
Yeah.
Then
There
after
is
that,
no way that I can't introduce her, you know. She's my neighbor, you know. So
it's a neighbor. Okay, then you can introduce one by one. Madam. Means first Dr. Atota madam, then she will do her presentation, something like of that.
yes, Sonali will do the rest actually.
Yeah.
I have a lot of ID will work to catch up and other things also.
Mhm.
You have the IWDA backdrop, Sonali, so I was trying to use mine.
Ma'am, I have that Vodicon one. Should I use that on
मैं
it?
तो वही कर रही हूँ IWDA का लोगो तो दिख रहा है ना.
Okay, ma'am.
उसको अब हटा भी देना है ना कि वैसे IWDA का बना देंगे.
जी ma'am.
Somebody can take down keynote messages also for this. Kavita, you could do that, Kavita or somebody.
Okay, ma'am.
And some points you can write down from each lecture. Later on, it will be handy.
Okay, ma'am.
Ma'am, Dr. Sunil Kumar from Dr. Reddy's will start the meeting.
Do we have the flyers here with the thing I can post in the other groups?
Shall I? Here. I can WhatsApp you, ma'am, once again.
I'm sending it to them.
Yes. Slides will be, Dr. Sunil Kumar will share the slides.
हमारे यहाँ से शेयर करें सर.
नहीं मेरे पास है ना. Dr. Sunil Kumar will share it.
Okay sir.
डॉक्टर सुनील आपको मिल गया ना स्लाइड?
हाँ मिल गया, मैं शेयर कर रहा हूँ.
वेट 1 more minute. Brijesh and Desh, tell us when to start. 1 more minute to go. Technical team.
So, Aman, you're in Ludhiana or are you in Jalandhar?
Yes, ma'am, I'm in Ludhiana. We have our clinics in
I'm actually aware of you. Like, which part of Ludhiana are you in?
Ma'am, Saravanagar.
Okay, because I've studied from Ludhiana. No?
Really?
I'm from DMC Ludhiana.
Yeah,
yes.
I'm a graduate and postgraduate of DMC, ma'am.
Okay.
Yeah.
You passed out in which year?
94 batch. MBBS.
That is 94. For MD.
MD 2000.
MD 2000. Who was the head that time?
Dr. Alka Dogra.
Okay.
Ma'am, can we start? You're live.
Can you start?
Yeah.
Hello and welcome all to this scientific session. I am Dr. Sunil, and on behalf of Dr. Reddy's laboratory, I welcome you all for this scientific session. As you all well aware, like International Women's Day was on the corner, and with the theme we are conducting this scientific session, and this meeting is conducted by Indian Women's Dermatologic Association, IWDA, with the theme of the International Women's Day, and the topic for today is Trichology CMEs. It gives me immense pleasure to welcome you all on this occasion of this prestigious event by IWDA on the theme of International Women's Day Trichology CME, and also to introduce our course coordinator, Dr. Rashmi Sarkar, MD, PGI, FAMS, Director, Professor of Dermatology, Lady Hadrich Medical College, Delhi. And she is the President IADBL 2022, President IADBL Delhi State Branch 2018, President Pigmentary Disorders Society PDS, and Indian Women's Dermatologic Association IWDA, Editor-in-Chief Pigment International, and co-editor Asian Journal of Ped Dermatology. Coming to her achievements, she has edited 15 books, including Melasma, a monograph, 196 articles, and 75 chapters to her credit. She is the editorial board of 5 national journals and 5 international journals. She has held various international positions like Vice President, International Society of Dermatology, ISD, Chair, International Mentorship Committee, ISD, Board of Directors, Asian SOC, Pediatric Dermatology, Women's Derm Society 2011 to 14, 17 to 18, and Skin of Color Societies 2012 to 15. Ma'am has several awards and orations to her credit, like Dr. B.M. Ambadi Oration 2019, Dr. K.C. Khandari Award, IADBL Delhi State Branch 2020, Economic Times Inspiring Dermatologist Award 2019. She has received Member Making a Difference Award from IAAD 2014 and 2015. Her special areas of interest are pediatric dermatology and pigmented disorders. With this small introduction, I would like to hand over the session to our course coordinator, Dr. Rashmi Sarkar, to take the proceeding forward. Over to you, ma'am.
So, good morning, everyone. Very warm namaste. And it's always a pleasure to start the activities of the Indian Women's Dermatologic Association, or the IWDA, as you know. And what better way to start it than on the occasion of International Women's Day. You could rather say that these celebrations occur over the entire week to make it really a wonderful week, the International Women's Day in week. And as you've seen, there has been a whole lot of activities all around the week, whether it's been from IADVL, whether it is from Indian Women's Dermatologic Association. But one thing I'm happy to say that the IWDA has always been a forerunner. It has shown the way. What it has done 3 years before, I think other societies are now following. You know, it's been a torchbearer. Well, this year, as you know, for the International Women's Day, the theme has been, you know, break the bias. And when we talk about what is breaking the bias, definitely I'd like to say that what do we look forward to more? We look forward actually to a world which has less diversities, and it is more equitable and more gender balanced. On one hand, we do look as if we are gender balanced because when we look at each other, we probably represent the 10% of the Indian population that is living in the metros or tier 2 or tier 3 cities. Most of us having a good upbringing and we've been able to carry on our activities and professions. But it will become equitable when it reaches each and every woman all across the country. We know that we are a country of different regions with lots and lots of disparities. I think we agree to that. So it has to reach every area, whether it's the rural area, whether it is the smallest area, and make both education as well as having a profession besides a personal life also a priority for women all over the world. It's important to do that. We definitely need to work shoulder to shoulder with the men as well. So it's not just an International Women's Day. It's basically a day for the whole family because we need the men to work with us. We also need the children to make sure that their mothers do very well also. So this is also a message to the children that just as you know your mothers look after you and make sure you're the best, make sure that your mothers are also the best. With those few words, I'd like to say we've always held wonderful activities on International Women's Day. This year also, on this day, we had distributed posters all across the country on skin health for all. As you know, we are the first to do that across all age groups, whether it is the adolescent, the middle-aged woman, or the elderly woman. Everybody needs general tips for skincare, and that has been done all over the country. All of us also held skin health camps, whether they were in orphanages or in women sheltered homes, because IWDA partners with the Women's Dermatologic Society in the Global Shelter Project. We are the first to have a very robust social work program. So please do continue, please do send pictures so that Dr. Saloni can take them down, you know, for our bulletin. Well, Dr. Reddy's Labs has always partnered with us to have a series of CMEs on the International Women's Day. This time we are having a standalone, very large CME today, and that is the International Women's Day, Indian Women's Derm Association, Dr. Reddy's collaborating with us to have a trichology CME for the whole day. That is what is going to be important. It is broken into 2 sessions. The first is going to be now from 11 to 1. The rest will be from, I think it's at 3 o'clock.
3 to 5.
3 p.m. Yes, 3 to 5. So enjoy these very state-of-the-art lectures because they'll talk right about, you know, hair loss to hair therapy, different modalities, whether it is PRP, the newest surgical modalities, and whatever we can do for the hair, because for women, yes, even for men, but for women, it's more important because it's longer hair for women. I'm excluding the men with the longer hair also. But out here, I think, you know, that's what we are going to do and focus. And it's going to be a very proud moment for me. Before I introduce the moderator for this session 1, that is Dr. Sonali Langar, I would also invite you all become members of the Indian Women's Derm Association, whether you are women or whether you are men, because We also have a very robust IWDA L'Oreal leadership program, which has done very well. It has shown way to a lot, and it is now being also emulated in the IATVL. So with that, can I have the slide of Dr. Sonali Langar, please? So Dr. Sonali Langar is a consultant dermatologist at Skin Remedies Clinic, Noida and Saibabad. She has a few chapters in books on chemical peels and injectables and aesthetics. She's been a faculty at various national conferences. She's a vice president at the Ghaziabad Dermatologic Forum and also the joint secretary of our very own Indian Women's Dermatologic Association. She's an organizing secretary at the various Vodecons or the National Conference of Women's Dermatologic Association, Vodecon, whether it was in 2019, whether it was in 2021. She's also got the Indubala Memorial Award for Best Paper published in IJDVL on contract dermatitis and is a member of IJDVL SIG Aesthetics. Her areas of interest are chemical peels, injectables, MNRF, and laser devices. She's been a very value-added person, for our Indian Women's Dermatologic Association. And currently, she's also the convener of the Industry Liaison Cell of IDWL, which is again a first time for a woman doing that. Before I hand over the session to you, Sonali, I'd also like to thank DRL or Dr. Reddy's lab for coming forward and always, making us do very unique things with you. Thank you very much. We look forward to your continued support. Over to you, Sonali.
Thank you, ma'am, for the kind words. Good morning, everyone. And I again take an opportunity of welcoming you all to the IWDA International Women's Day Trichology CME. I hope we all have happy learning and we take some brilliant take-home points. Now, starting with the first presentation, Dr. Atotha Kavitha will be speaking on telogen effluvium in women and how to manage it. Can I have the CV of Dr. Atotha Kavitha? Ma'am is a well-known name. She is consultant dermatologist at Dr. Paruchuri Rajaram Memorial Skin and Laser Center, Guntur, Andhra Pradesh. She is the convener and member of SIG Female Genital Dermatosis and also has been the IDVL AP State Secretary 2014-15 and the organizing convener Dermazone 2015. She has many chapters and publications in IDVL textbook and is a regular speaker at various state and national conferences. I will not like the audience to wait more, and I invite ma'am to take up her presentation.
Thank you very much for the nice introduction, Dr. Sonali. At the beginning, I sincerely thank our President and Professor Dr. Rashmi Sarkar ma'am for giving me, and the team of IWDA for giving me this opportunity to participate as a speaker in this prestigious CME. And also I thank Dr. Reddy Labs. And I directly start away with my topic today of telogen effluvium in women and how to manage it. And in our daily practice, this is a common thing which we daily come across. I feel that almost 30 to 40% of our OPD is filled with hair loss. And amongst them, telogen effluvium is the most common cause of diffuse non-scarring hair loss. And this is the main cause of anxiety, frustration among the patients presenting to us. And mostly the hair loss being common for both men and women, most of the women present frequently, and this is mainly a cosmetic concern also. And coming to the telogen effluvium, usually it is graded into acute and chronic telogen effluvium. In acute form, generally we can see the patient presenting as with severe anxiety. So a confident diagnosis is necessary before starting the treatment. Excessive shedding of the hair is the with the triggering event which happened 2 or 3 months before is a common presenting symptom. And telogen effluvium is the name first coined by Kligman. Previously, it is known as diffuse cyclical hair loss. And abnormality of the hair cycling occurring as a reaction pattern to the mental stress is seen. And regarding the management part of it, establishing the cause of telogen effluvium requires elicitation of the proper history, and then coming across the lab investigations which are related to endocrine, nutritional, and other autoimmune disorders, because it is one of the diagnoses which can also be made by exclusion of other pathological entities in hair loss. And acute telogen effluvium usually can occur within 2 weeks of a trigger point, and it peaks after 4 to 6 weeks. It is likely to be related to a specific event which commonly has a cause, and the objective features may not be present, or they can be a diffuse hair loss pattern seen. The typical symptoms may not be there, and the common presenting symptom which we usually ignore is trichodynia. Hair pain in the part of the hair that is commonly lost is also a presenting feature. And usually the patients come bringing bags and bags of hair with them, otherwise bringing the hair that is lost in that day, or few patients also bring a cover of hair showing each day hair also. And clinically, though it's easy to diagnose, in some cases it is overlapped with female pattern hair loss, even alopecia areata. So differential diagnosis to make it as telogen effluvium is also necessary. And the common clinical finding which we see are the short frontal hairs and bitemporal thinning, which are an important sign to make clinically without going to the investigations and the trichoscopic part of it. And the other part is chronic telogen effluvium, which is mostly seen in middle-aged women. And differentiating from the classical acute telogen effluvium is by its long and fluctuating course. And the other common differentiation feature is the female pattern of androgenetic alopecia, which can be differentiated by the clinical and the histological findings. And the mechanism involved in the chronic telogen effluvium is the shortening of the anagen, which we see commonly. And the insidious onset and the fluctuating course of it is the clinical part of it. And as I said, even in acute telogen effluvium, bitemporal recession is a common feature. And the central parting, which we commonly see as a presenting feature, is mostly in favor of female pattern hair loss. And even miniaturization of the hair follicles is, both of the features are more typical of female pattern hair loss. And the recent pathogenesis which is involved in chronic telogen effluvium is the immediate telogen release, which leads to the cycle synchronization. And coming to the causes of acute telogen effluvium, the commonest cause which we are coming across is post-COVID. Previously, usually telogen effluvium, as we thought about, it may take 2 or 3 months time from the triggering factor. But in post-COVID cases, the presentation is starting from 4 weeks, they are coming with the hair loss. And even after the second and third wave, there are a number of patients with the hair loss in post-COVID, and that is commonly acute telogen effluvium. And this is viewed sometimes unmasking the female pattern hair loss also in some cases. And the postpartum thing which is more common in coming to the females, the heavy menstrual bleeding is one cause, and the second thing is the postpartum bleeding. Almost 1/3 to half of the female patients present with the postpartum hair loss. And the main other factor is stress-induced hair loss. Commonly we see after examinations and after any severe incidents happening in there, that is another factor. And after major surgeries, because there will be a huge amount of bleed, which leads to iron deficiency, and which in turn cause, mostly this is in favor of chronic telogen effluvium, but sometimes major surgeries may even cause acute telogen effluvium. And in the history, we should elicit any febrile illnesses, because all viral fevers, even the chickenpox, typhoid, and jaundice, all these things should be elicited in the history. And crash dieting, because so many are when you're doing the crash dieting, we're completely stopping the diet and taking only on liquid food. And recently we came across the keto diet, which is followed by hundreds and hundreds of people, which led to the telogen effluvium. And seasonal variation also should be kept in mind. Mostly the telogen effluvium can be seen from in between the July to October, where there will be more hair loss. And the sunlight and UV light induced actinic telogen effluvium can lead to this. And the other one is hair dye induced telogen effluvium. When you rule out all the above causes, we can ask the history of the hair dyes they are using, and that may be the cause of telogen effluvium. And 33% of the acute telogen effluvium is idiopathic. And coming to the chronic telogen effluvium, the common thing we see is iron deficiency anemia, though it is uncommon in higher societies. In the rural areas and lower socioeconomic status, this is the common thing. And the thyroid disorders, both hypo and hyperthyroid disorders, cause chronic telogen effluvium. And starvation, hypoproteinemia, and metabolic disorders, chronic liver diseases, cause telogen effluvium. And autoimmune diseases, SLE and dermatomyositis are more etiologically related. And malignancies, all the malignancies and after chemotherapy, this is more common. And the drugs causing telogen effluvium, our dermatological drugs are isotretinoin, acetretin, and ditretinate. And while you're keeping the patient on isotretinoin, you have to take after they come for follow-up, you have to ask regarding the history of any hair loss. Then we can stop isotretinoin, because this is a reversible process here. And the acetretin also is supposed to cause telogen effluvium. And topical minoxidil, already if they are using minoxidil, the telogen effluvium due to minoxidil is short-lived, because here the pathogenesis is immediate telogen release. And withdrawal of minoxidil also causes telogen. And in women, oral contraceptive should be regularly, definitely asked to rule out the other causes. And anticonvulsants, anticoagulants, antithyroid drugs are a cause. Antihypertensives, mostly AC inhibitors cause telogen. And HPV vaccination also causes telogen effluvium. And this is a girl of 19 years, came to me with telogen effluvium, and history of COVID is there. She had COVID in January, and hair fall started now. And here the mean age is duration of the telogen effluvium is just 1.5 months history of COVID. And the intensity of effluvium in these cases is most often related to the severity of the COVID. The longer the duration of ICU stay, the longer the medication they have taken is also being the part of the cause of telogen effluvium. And the other conditions which we should differentiate while ruling out this is alopecia areata incognito. Here the hair loss is acute and there is diffuse hair shedding without the typical alopecia patches. And the only thing which we can differentiate is by trichoscopy. And color transition sign is more in favor of alopecia areata incognito. And the autoimmune telogen effluvium shares many features in common with the above condition, but 60% of this autoimmune telogen effluvium is associated with Hashimoto's thyroiditis and also antithyroperoxidase antibodies. And again here trichodynia is a characteristic feature. When the patient comes with a complaint of pain in the hair, usually we shouldn't neglect it, because it is seen, trichodynia is seen in this autoimmune telogen effluvium, and even when it is a clue to indicate that it is ferritin deficiency also, usually the patient's presents with trichodynia. And now how to come to the diagnosis is first the clinical examination, where the objective signs can be less, but short frontal hair and the thinning of the side locks is the common thing seen. And you can confirm your diagnosis by first the hair pull test. Usually 40 to 60 hair are grasped and pulled out. And usually the patient, before doing this test, the patient had to not to shampoo for 24 hours, then the hair pull test can be performed. But because pulling 40 to 60 hair, patient will not be ready for that, because already they'll be frustrated, not feasible. And daily hair count, this is also a cumbersome procedure. And wash test can be performed, and this is the best and easy method. Patient to wash the hair, asked to wash the hair after last shampoo. They should wait for 5 days after they shampoo, and then they are asked to wash in a sink with the drain covered. So the hair entrapped in the sink can be counted. And this is a better procedure compared to the hair pull test and all. And the other one is hair combing test. And this is also patient after 5 days of regular shampooing, the patient is asked to comb their hair. And then the hair in the comb can be counted. That can be one part. And Phototrichogram. Usually patients bring with phototrichogram after reaching all the cosmetic and hair centers where this is commonly performed, and they will show us the pictures of phototrichogram. We can analyze the anagen telogen ratio in that. And commonly what we perform is trichoscopy, which is an easy and handy procedure once we master that. And finally, the biopsy to rule out other inflammatory conditions which may lead to scarring alopecia and even the other conditions of non-scarring alopecia when we are still in doubt, though biopsy has not a major role in telogen effluvium. And trichoscopy is done in 3 areas: the frontal, occipital, and above the ears. And in telogen effluvium, the common thing we see is the empty follicles and the absence of variability of the hair shaft diameter, and short, upright, regrowing hair of normal thickness, and occasionally peripilar sign. But this is seen in other features also. Though I am not a master of trichoscopy, where Yasmin madam is a master, and we can hear more up from her. And presence of less than 20% of the hair diameter variability is essential to differentiate between chronic telogen effluvium and the female pattern hair loss. And this is the patient came with a history of hair loss since 3 months, and on doing a dermoscopy, we can see the empty hair follicles area and the sparse hair can be seen. And this is a case of telogen effluvium. And coming to this case, actually she came with the reports of showing very low ferritin of almost 2 micrograms, and D3 is also less than 10. Thought of telogen effluvium, but on seeing the trichoscopy, we can see the miniaturized follicle variability of the hair pattern and the small minute pig hair follicles, which are seen even in other conditions of hair loss. And this condition is more in favor of female pattern hair loss than and few cases we can see both together, both telogen effluvium and female pattern hair loss together. And this is another case where the features are more in favor of female pattern hair loss, though she came with the complaint of hair loss since 6 months. We can see the central parting of hair, which is more in favor of female pattern hair loss in this case. And coming to the investigation, so after doing a trichoscopy, unless we master it, that is not so easy to come to a conclusion. So the other investigations which could give us a clue about the diagnosis are the complete blood count and the routine urine examination. And an expert consensus is statement given on the management of telogen effluvium, Dr. Mysore Venkatram sir and Anchal Parthasarathy sir in the International Journal of Trichology, who recommend us the basic investigations. So multiple investigations are there, the minimal requirement to come to a conclusion are. And the most important thing among them is serum ferritin levels. Usually serum ferritin levels of 40 micrograms is considered as needed one, and this is the more sensitive and specific test to come to the diagnosis of telogen effluvium. And serum ferritin is an acute phase reactant, and it's increased in even anemia of chronic diseases also. In some cases it is increased. And the thyroid function test to rule out the hyper and hypothyroid states, and the serum iron binding and total iron binding capacity are needed. And when the patient can afford, these tests can be done, but the basic thing which I do when they cannot afford at least serum, complete blood picture, serum ferritin and vitamin D levels. And the serum ferritin levels are the hair follicle matrix cells are very sensitive to iron levels. So this serum iron level comes into account. And the other things are serum calcium and vitamin B12, hormonal assays, and serum anti-Mullerian hormone and testosterone to see any associated polycystic ovaries and insulin resistant conditions, and anti-dsDNA to rule out the autoimmune disorders. And coming to the biopsy, to establish a diagnosis of telogen effluvium, biopsy is not necessary, but to rule out other conditions, this may be a useful tool. And in acute forms, histology is non-specific and it resembles the normal hair pattern. What things we can see is increased density of catagen or telogen follicles, decreased density of the anagen follicle, and reversal of the anagen telogen ratio. And the resolving telogen effluvium shows regeneration of the anagen follicles. And we all love to have a long hair. This is in my medical college when I am 19 years old, and with my friend who are both of us having long hair, which I love to have, but almost after 30 years, 30% of my hair is lost. Coming to the treatment aspect. The major part of the treatment is inhibition of catagen, induction of anagen in the telogen follicles, and inhibition of exogen or the hair follicle shedding. Though we don't have any FDA approved catagen inhibitors or anagen induction drugs are not available till now, counseling plays a major part in the treatment of telogen effluvium. The patients are very frustrated, and almost few patients are brought in depression, and we have to psychological counseling may be necessary, and few patients need referral to a psychiatrist also, and counseling may plays a major part. We should affirm the patients that this is not a permanent thing, and there usually in acute telogen effluvium, we are sure to get back stop the process and sure to get back the hair, and we should ascertain the patients that only 1 centimeter per month is the normal growth of hair, and so we should tell them that they should not expect results within 1 week or 2 weeks when you're going to give the supplements and all. So counseling plays a major part in the treatment. And apart from that, identification and treatment of the underlying cause, and reassurance that telogen effluvium represents excessive hair shedding rather than the actual hair loss. And the thing we should ascertain them is it doesn't lead to baldness. And the unresolved telogen effluvium with hair shedding for more than 6 months, we should reevaluate further to rule out any other internal causes. And nutrition plays a major part, and balanced diet is more important. And you should tell them the healthier food habits to stop the junk foods, and nutrients are given in a cyclical manner. We have few of the packets like having 2 days of iron, 2 days of biotin, 2 days of supplements. Cyclical manner drugs are available now. Amino acids, vitamin B complex, zinc, and protein supplements plays a major part. Protein supplements are helpful when there is really a protein energy malnutrition, and animal protein is more better than a vegetable protein. And usually the vegetarian protein has almost half of it, half of the less content of iron also is there. So supplements is more necessary in vegetarian people. And zinc plays a major part in the hair. Apart from acrodermatitis, even the acquired zinc deficiency also can lead to hair loss. And many studies are available on zinc supplementation. And amino acids, sulfur containing amino acids are more useful in the hair loss. And iron supplementation is done. Oral ferrous sulfate of 300 milligrams 3 to 4 times a day, amounting to 60 milligrams of elemental iron is supplemented. And antioxidants are given in plenty, but their role is not yet proven. And green tea extracts are given, and they are also role is not proven, and sufficient evidence is not there for that. And omega-3 fatty acids and soya proteins, all these supplements are recommended, though they have not yet a proven role. And coming to the biotin, which almost all of us supplement with biotin, but coming to this study published in Jabin, suggests that oral supplements for hair loss is prevalent, and the study is made where almost in 600 patients, 112 patients were taking supplements, though it is not proved. The most frequent diagnosis of this subset of patients include female pattern hair loss and telogen effluvium. And of them, 75% are supplemented with biotin. And the FDA has recently received reports that high doses of biotin can falsely lower the cardiac troponin levels, and this leads to a misdiagnosis of myocardial infarction. And additionally, reports indicate that biotin supplementation, even at doses of high doses, can falsely elevate the thyroid function test. So while supplementing biotin for months, 10 months, you should keep this in mind. And the other adjuvant therapies which we come across are usually patients ask about the hair oil application. Usually they doesn't help as a growth factor, but application of oils should be done only to the shafts, not to the hair roots. And just it acts as a good pre-wash conditioner. In the shampoos, they don't have any role for the hair growth, but vigorous application should be avoided as it prevents that, and it may cause damage to the hair. and use of a mild shampoo without sodium lauryl sulfate is advised. Topical peptides and all the things which we prescribe now, the Capexil, Eminex, Procapil, all these help to a minimal extent. Usually I start my treatment with topical peptides because initially at least they stop the hair shedding, and for 1 or 2 months the patient, and in this COVID era, almost all the patients after supplementing with the biotin or iron and topicals also within 1 month, most of them are coming saying that their hair fall has stopped to almost 50 to 60%. So these help to some extent, at least to stop the hair fall. And next thing is PRP. Usually it promotes rejuvenation of hair follicles due to the presence of growth factor. Acute telogen effluvium has no benefit with PRP, but once the patient insists you, and if we can do confidently, we can go for PRP. And definitely chronic telogen effluvium has a benefit with PRP. And as Dr. Amandua is going to talk about it, I'll avoid it. And the other novel cosmetic treatments which are proposed are, and this is from the literature from in the IJDVL by Dr. Chandragore and Ananta Kurana, the review article on telogen effluvium. The caffeine, niacinamide, panthenol, dimethicone, and acrylate polymer CNPDA is a very good leave-on technology combination that significantly increases the diameter of the hair by 2 to 3 micrometers, and it is studied in a huge large population study has proven that. And even this CNPDA has the ability to withstand the force without breaking the follicle. And the recent advances in telogen effluvium are topical valproic acid. Actually, the oral valproic acid is one of the cause for telogen effluvium, but topical valproic acid is found to be useful in telogen effluvium. And low-level laser therapy is already practiced in other forms in androgenic alopecia and all, but it is proved to be useful in even in telogen effluvium. And once daily oral minoxidil appears to reduce the hair shedding in studies shown by E. Pereira. And these are the recent advances. And coming to the topical minoxidil, it shortens the telogen phase of the hair cycle, and it extends the anagen phase and increases the size of the hair follicle. Though it is never recommended in acute telogen effluvium, combination with peptides could produce better results. As we see, most of the conditions are overlap conditions of telogen effluvium and female pattern hair loss. What I do is usually I prescribe the protein lotions and available peptide lotions in the initial 1 or 2 months. And once their hair fall is reduced, then I go for I go for topical minoxidil, because initially if we prescribe minoxidil, they come running back saying that the hair fall is more now. So combination with peptides is also proved to be more useful. And in summary, it is the commonest cause of diffuse hair loss, and acute telogen effluvium is a self-limiting condition. Chronic telogen effluvium is diagnosed only when other causes of hair fall are ruled out. So coming to the diagnosis of the patient is more important. Counseling is important, and trichoscopy plays the major part in the diagnosis. Thank you very much for your patient listening.
Thank you so much, Dr. Kavita. It was a most informative and lucid presentation on telogen effluvium. You have made us all wiser. Thank you so much, ma'am. Now, coming on to the second presentation, we have Dr. Aman Dua.
Ma'am, yeah, ma'am, we have a question in the chat box.
Question answer will be done after we are over with the presentation.
Okay.
Question answers are not going to be done now. They will be taken at the end of the presentation. Okay. Who's that? Yeah, who's that?
Is Dr. Sunil.
Yeah, so they are not going to be taken over now. Okay. They're taken over in the end.
Can I have the CV of Dr. Aman Dua? Dr. Aman would be speaking on PRP versus mesotherapy in hair loss, the differences and how to choose between the two. Dr. Aman is a renowned name in hair transplant. She's the chief dermatologist at AK Clinics with 16 years of experience. She's a prominent faculty in national and international conferences and has delivered multiple lectures on hair transplant and dermatology. She's board of governor of Association of Hair Restoration Surgeons India member, and she's also the member of fellow International Society of Hair Restoration Surgeons. Welcome, Dr. Aman. Kindly deliver your lecture.
Thank you, Dr. Sonali, for a very kind introduction. And I'm going to share my screen now. Hope everybody can see this. I would like to thank Dr. Rashmi Sarkar, our President, IWDA and IWDA Association, and Dr. Reddy for giving me the opportunity to present my lecture. This is a little controversial topic, and I'm sure each one of you is going to have lots of questions on the end, and I would be happy to take them and discuss. So PRP versus mesotherapy. Let's have a little look at PRP. This little dot at the end of the tube is an autologous blood product containing high concentration of platelets. Almost everyone is using PRP these days. There are different ways of preparing PRP, each to his own. And but all we know is that, okay, it's a sample of autologous blood with concentration of platelets above the baseline value. So something like 7 times, some say 10 times the normal value in the blood. The concept and description of PRP started in the field of hematology and is being extensively used in other fields of medicine as well. And PRP in hair loss. Just a moment. Yeah, so we have a lot of studies on PRP. One of the first study regarding the use of PRP in hair diseases and patients undergoing hair transplant surgeries was done by Ubel et al. PRP is also used as storage media for grafts during transplant. Improvement of hair growth and an increase in follicular density was noted, and the growth factors could act upon dermal papilla, leading to intense neovascularization and progression of new hair to anagen phase. So since then, it has started to be considered a potential therapeutic tool for promoting hair growth, although the precise mechanism by which PRP promotes hair growth is not exactly, fully understood. Let's look at the indications. Androgenetic alopecia, both male and female, it is used in Telogen Effluvium, like ma'am said, and both in acute and chronic, although I have my certain reservations about where to use in Telogen Effluvium. I'll talk about it later. To promote graft survival in hair transplantation, post-hair transplant in alopecia stable areata or long-standing alopecia areata, which has a limited data, cicatricial alopecias, LPP, FFA, CCAs, and we have limited data of where to use and how. So it is practically being used in almost all indications of hair loss. So mechanism of PRP in hair loss, we know it has high concentration of over 20 growth factors. So this is the theory about different growth factors, PDGF, TGFs, VGFs. So all of these, they mediate regeneration, tissue organization, generation of new follicles, and reduces the inflammation. So they regulate cell migration, attachment, proliferation, differentiation. It promotes hair regrowth by binding to respective receptors. And these growth factors stimulate the protein kinases and stimulate signaling, so by different pathways. And it may also, like I said, reduce inflammation by reducing local cells and to a non-inflammatory type of phenotype. So let's come to protocols. There are no consensus, right? Everybody's using PRP as their own way. There are a lot of kits available. People are using it like, we are using, some using open methods, some use a closed systems, some doing it at monthly intervals. I've also seen doctors doing it at 2 weeks. Average 3 to 6 sessions in a go are recommended. And so different protocols in different clinics. I'll share what we do in our clinic. So this is roughly kind of results that we see before and normally in 3 sessions of PRP. Although this is not a monotherapy, we are in a private practice. We use all kinds of armamentarium. So we use topicals, oral medication and procedures and low-level laser therapy at times, and sometimes only PRP as well. So different modifications in PRP are now available. People are using GFCs, growth factor concentrates. They're using the latest fad is the PRF, platelet-rich fibrin. So there's a lack of regulation in the PRP processing methods and final composition of the injected product. So PPRP, LPRP. So PPRP has very few WBCs, that is pure platelet-rich plasma. L is leukocyte and platelet-rich plasma. and PRF is pure platelet-rich fibrin. So let's look at the contraindications. Platelet dysfunction, thrombocytopenia. Obviously, if there are low platelets, there'll be low growth factors, so no point giving PRPs. I recently had a patient who had von Willebrand disease, so I just refused to do this. And there are certain coagulation disorders, anticoagulant therapy. So anything that can reduce the platelet count is a contraindication. Hepatitis, hemodynamic instability, local infection. Sometimes you plan to do a PRP, the patient comes up and you see extensive seborrheic dermatitis or a lot of inflammation, folliculitis. So that is a relative contraindication. You can wait. Patients who are prone to keloid formation, it's not absolute contraindication, but make sure that nothing on the scalp is there. Sometimes scalp is relatively spared. You see more on the body, but it can happen. Let's talk about mesotherapy. So mesotherapy is a term derived from Greek word meso, which means middle. That is, we aim to deliver the pharmaceutical agents or non-pharmaceutical substances on the middle layer of the skin, that is the mesoderm. Despite the lack of sufficient data as to the value of using mesotherapy for treatment of hair loss, this procedure is widespread and very popular. There is very little scientific evidence, I guess, not many studies we have regarding mesotherapy, but it's very, very popular as it is considered to be very safe. We are not injecting a lot of things into the scalp. There is no blood, there is no, anesthesia or anything. So it is a relatively easy procedure. It aids in the penetration of large size molecules into superficial layers of the skin. Due to slow clearance of superficially delivered drugs by the general circulation, the results are there for more longer action. So longer duration of action, decreased dosing, faster outcomes, improved microcirculation, tissue remodeling due to multiple pricks. So this is a confounding factor. We are also giving multiple pricks. So some say that it is just, stimulation of collagen. The solutions don't have any role to play, but both of them are there. So minimal downtime and pain. Let's look at techniques of mesotherapy. So a lot of people are using intradermal needles, that is the meso needle, meso gun, microneedling, electroporation. So let's talk about meso needles. They are of varying lengths, 4 millimeter to 13 millimeter, from 27 gauge to 34 gauge. So you're trying to make them as small as possible, as thin as possible, hypodermic, so they can be employed for different indications. The short needles, 4 mm and 6 mm, are available for mesotherapy in Europe and other parts of the world. However, they're not readily available in the Indian subcontinent. The standard 31 gauge BD insulin syringe for injections may be used as preferred alternative due to small needle size and ease of availability. A lot of people are using meso gun or a meso pistol. I've used that too and discarded. It's a syringe infusion pump which injects a desired amount of product, keeping the needle at constant desired depth. The dose and speed of injection can be modified. So how you want it, in a patch technique or microdose or continuous. It's a fast and convenient procedure, accuracy and delivery of the product. However, the gun can appear bulky for treating by the treating physician and intimidating for the patient, especially on the face. So injection techniques, point by point, where 0.02 to 0.05 ml of drug solution perpendicular to the skin is given, 4 millimeter deep, about 1 to 2 centimeter apart, almost same as PRP. Nappage is more superficial, 2 millimeter deep infiltration, almost 45-degree angle. Epidermic, you can go more superficial, 1 millimeter, but it will be soon wearing off. The papule technique is injection at the dermoepidermal junction, and you can raise a small papule used for wrinkles, alopecia, like we give mesobotox on the face. So a lot of people are doing mesotherapy for face, also called as mesofacials and all. And you can do microneedling. You use a derma roller, 0.5 to 1 mm. 0.5 is a little less. We're using 1 mm. It is minimally painful, preferred in those who are reluctant or phobic to needles, and may be followed by electroporation. You can electroporate the solutions after doing the microneedle. The drugs and ingredients used for mesotherapy of hair loss are minoxidil, dutasteride, biotin, dexanol. You see a whole variety. Every new company coming up, you'll see a whole new list, and you're so confused as to what works and what does not. Should you shift, or should you try a new solution and see the results for yourself? And nanopeptides, cocktails, so everything is available. The recent interest has been in use of dutasteride in the treatment of AGA. Various studies have shown good effect. Intradermal injections worldwide, they're very popular in Australia and Europe. And it's interesting that they do a 1 session treatment every 3 months. I mean, we do mesotherapy quite frequently. I mean, not every 3 months, but versus placebo, another study shows weekly for 4 consecutive weeks, 0, 1, 2, 3, followed by injection every 2 weeks. So there are certain results that are there, and they've shown to be very good. I don't think it is available in India as yet, dutasteride. And in female pattern hair loss, there's been a study that dutasteride containing preparation, there was a significantly effective result in female pattern hair loss rather than compared to 0.9% saline. So reappearance of cuticles. And when we combine dutasteride with vitamins, meso solutions like D-panthenol, biotin, paradoxin, so again, the results are said to be better. Intradermal minoxidil has been very popular. It's surprising that, and also I've come across many clinics, even not approved clinics, so-called, who are using the normal topical minoxidil to be injected into the scalp as a mesotherapy, and patients had reactions. But people have been doing it, and but I don't think that's the way to go. You need to have a proper meso solution, and you cannot inject a topical minoxidil into the scalp. So injected by point-to-point technique, 0.1 cc every 2 centimeter, and by mesogun once weekly for 4 weeks. Great results have been documented. A lot of cocktails, ingredients, meso solutions are available, and most of the meso solutions have a principal or a major ingredient. Along with it, there are complementary or minor ingredients. And cocktail, the mixture should contain at least 2 or 3 principal agents to be effective. And a lot of them also have procaine, lidocaine, or sodium chloride, along with vitamins, vasoactive herbal remedies, depending upon the indication to be treated. So finasteride has also been used along with minoxidil, and in South America. And this is the kind of results that have been shown before treatment, after 10 sessions, after 20 sessions at 10 months. And this is how it is injected. Various mesotherapy cocktail solutions, I'm sure everybody knows about these. They have different names and active ingredients, biomimetic peptides, vitamins, amino acids, minerals, coenzymes, nucleic acids, antioxidants. But I've found out that caffeine works pretty much good. If you have caffeine, if you have collagen, and you have certain vitamins, it does work. And certain extracts also do. We are using mesotherapy in our clinic, and we're using hydrolyzed collagen as well, and certain fruit oils. And these are the other available formulations. I'm sure the list is endless. And so let's talk about the indications of mesotherapy in hair loss. We use in acute telogen effluvium, chronic telogen effluvium, female androgenetic alopecia in women. I prefer to use it in chronic telogen effluvium and female pattern hair loss once the acute shedding phase has kind of stabilized. So what is the evidence? Currently, no adequate peer-reviewed clinical trials critically evaluate the efficacy of mesotherapy. There are insufficient data regarding the safety of the technique and pharmacology of the combinations. The mechanism of action of many of the products is either doubtful or unknown. There's no clear guidelines on the dose and efficacy of the products. Even in our city in Ludhiana, there has been a man, working since ages, almost like 25, 30 years that I know. He just sits under a roof outside the railway station, and he uses an iron comb over the scalp to increase the hair growth, and applies certain onion juice kind of a thing. So I'm sure even that is a kind of mesotherapy. But then we are having more scientific and cleaner and sanitized solutions, so-called. So few comparative studies of intradermal mesotherapy with versus placebo topical minoxidil have been published, and there was a randomized control trial by Azam et al. Found efficacy of topical minoxidil inferior to combination with mesotherapy. And a promising result was seen with multivitamins and cocktails in French studies. So in Europe, it is pretty much popular. So biocanin, tetrapeptide. Regarding protocols, no consensus guidelines. Prior intradermal allergy testing with meso solution should be performed. You can develop an allergy to a meso solution weekly for 1 month, followed by fortnightly for 2nd month in most of the studies, and then monthly for 2 months. That is how we do that in our clinic. We are doing every week, 7 to 10 days, we're calling the patient for mesotherapy. So PRP has no place in the management of acute telogen effluvium. That is how we have made our protocols because there is a lot of shedding, and sometimes PRP, when you do in acute telogen effluvium, it can exacerbate more shedding, but maybe of some use in chronic telogen effluvium, albeit the unnecessary use of PRP should be avoided in patients with telogen effluvium, considered the results are variable. So no needle mesotherapy or microneedling PRP has been found to be a better or preferred alternative in patients with acute hair loss. In our clinical experience, initial mesotherapy combined with low-level laser therapy sessions for acute hair loss proved effective. As the hair loss is controlled, further PRP sessions may be added to achieve better results. So this is our own patient, and you can see that after 4 sessions of mesotherapy with meso cocktails, yes, we did give the oral, supplementation and topical applications of minoxidil also in this patient, but we also added meso cocktails. And this is a typical kind of a result with 4 sessions. I'm myself surprised at times with the results of mesotherapy. They do come up well. And we are using microneedles around 1 mm needle-based device. And meso cocktail solutions we are using, followed by electroporation. Microneedle, that is a derma roller, and followed by electroporation. Up to 4 to 6 weekly mesotherapy sessions we give for 1 month, and followed by fortnightly or monthly. And we combine it with low-level laser therapy for synergistic effect. Although it's considered to be very safe, but a lot of side effects have been reported: bruising, skin necrosis, atypical mycobacteria. You have to be very clean. Make sure you use a fresh derma roller every time. Allergic reactions, lichenoid reactions, post-inflammatory hyperpigmentation, infections, patchy alopecia, multifocal scalp abscesses, subcutaneous fat necrosis. Contraindication is a contradictory hair loss at injection sites or scarring alopecias. And it is not recommended for autoimmune disease processes like alopecia areata, FFAs, or other insulin-dependent diabetes, stroke, cancer, thromboembolic phenomena. There was a report where even after PRP, a patient had thromboembolism. So we have to be very careful at the point of injection and the depth of injection. The patients on anticoagulant medications and unrealistic expectation, pregnancy, lactation, psoriasis, LP because of Cobnus phenomena, and decreased libido erectile dysfunction for dutasteride or finasteride mesotherapy. So when we compare PRP with mesotherapy, PRP obviously scores it as autologous blood product. It still has more backing than mesotherapy. And the mechanism is growth factors, your own growth factors going into use. So it has a big advantage which patients see. And mesotherapy is variable mechanism depending on the agent used: DHT modulation, anti-inflammatory stimulation of ECM, tissue remodeling. There's high level of evidence at present for PRP, and it's very limited for mesotherapy. Indications are almost the same, although in acute hair loss, we don't recommend PRP. The modes are intradermal injections, microneedling, and in meso, you can use a mesogun, electroporation, microneedling, intradermal. Number of sessions, 3 to 4 in PRP, you can go up to 6 in one go. And more number of sessions, more frequent sessions. So patient has to keep visiting you more frequently, which could be a hassle. Mild to moderate pain in PRP, and depends how you use it. You use blocks or what do you do? Mesotherapy, minimal pain, efficacy and safety. It is proven efficacy by literature and very limited data for mesotherapy. And where do you use mesotherapy over PRP? Like I said, acute telogen effluvium, unresponsive to PRP, you want to change the schedule, you want to add on something and see whether it works. And sometimes patients are really reluctant to needle-based therapies. So this is a conclusion. PRP is an effective adjunct with well-proven clinical efficacy, safety. However, patient selection for PRP is at most important. Despite the limited control published study for mesotherapy, using all these agents, they are used in the treatment of alopecia. No needle mesotherapy may be effective for patients with acute hair fall, and patient mesotherapy for hair loss may be combined with low-level laser therapy, PRP, or recombinant human growth factors, or GFCs, or same or different sessions to achieve optimal results. I really want to thank Dr. Priyanka Sharma. She's a consultant dermatologist in AK Clinics, Delhi, who helped me prepare these slides. Thank you so much for patient listening and hearing.
Thank you so much, Dr. Aman. That was an extensive research done on mesotherapy. Now, I'll be inviting Dr. Savita S. Can I have her CV, please? Dr. Savita A.S. She will be speaking on principles of hair transplantation, low-level light therapy, and components of expert scalp micropigmentation. Dr. Savita is professor at Saptagiri Institute of Medical Sciences and Research Institute, Bangalore, and she is also the consultant dermatologist at Roots Institute of Dermatology, Bangalore. She is the Honorary Secretary General IDVL Karnataka 2019-21. She is the Treasurer of National IDVL, the Academic Convener ACSI 2019, and the co-editor of IDVL Textbook of Dermatology 5th edition. She has numerous publications to her credit. I invite you, Dr. Savita, to start with your presentation.
Thank you, Dr. Sonali. Is the screen visible?
Yes, it is.
Thank you. Good afternoon, everyone. So in the next 20 minutes, I'll be covering briefly the principles of hair transplantation, specifically in women, and very, very briefly about low-level laser therapy and scalp micropigmentation. So in today's scenario, we know that hair loss in women, especially, they don't accept it very well. And they have become more conscious, especially after people have started taking selfies. So this is my friend, until she took a selfie, she did not actually realize that she's having hair loss. So we are seeing many patients off late who come to us after realization of hair loss after seeing the selfies. So how is hair loss in females different, and what are the specific points in hair transplantation which is different in females? In women, the psychological effects of hair loss are often much more severe than in men. And women typically have more options for compensating their hair loss through different styling and coloring. And this is one of the reasons why they tend to seek medical advice at a much later date. So this is a patient with female pattern hair loss. So very nicely, there's no minoxidil, there's no medical line of therapy. With just coloring the hair and another technique which I'll be covering later, a very good camouflage is done. For the sake of transplantation or surgical restoration, female pattern hair loss is classified into 5 different types, which I'll be dealing in the next few slides. The most common pattern is the type 1, which is the Ludwig pattern described by Ludwig. There are several grades depending on the severity here. This typical pattern is different how, in the sense, usually women maintain the hairline. So you can see that the hairline is retained and there is a central sparse hair. Used to be said to be postmenopausal, but we are seeing many younger women also with this. This can be associated with global scalp thinning also. Coming to the type 2 type of hair loss, here there is global thinning present throughout the scalp. They do not have a specific area of hair loss. And moreover, these type of patients, these are not ideal candidates for a transplantation because the donor area also will show relative thinning. Then we have the Norwood-Hamilton pattern, which is described mainly for men, the type 3 hair loss. Like in men, they have temporal recession. The anterior hairline is receding, sparse temples. Women normally have a rounded temple. So this recession gives a masculine appearance, which they don't like. This is the Christmas tree pattern. See, we can see like here, this widening is more, and then as we go posteriorly, it becomes narrower. The last type of hair loss, which is surgically correctable, is the cicatricial alopecia. Here, permanent hair loss has happened because of some alteration. It may be due to a trauma, it could be a surgical trauma or any other thing, or any manipulative process or any inflammatory process like lichen planus or DLE, which has resulted in cicatricial alopecia. The last type of hair loss, the type 5 hair loss, this type of hair loss is not amenable to surgical hair restoration. So the most common cause in this category is the chronic telogen effluvium, the active type, where this persistent telogen increased shedding of telogen hair. So these patients should be identified. They should not be ideally taken up for any surgical process because there can be further shedding. The alopecia can be exacerbated. Let's move on to the other differences what we see. In men, the donor area composed of what we know is the safe area, the androgen non-dependent area, the occipital area. Other than that, we can also get the grafts from the beard, which is not an option in women, or body hair transplant, again, which is not an option in women. So when we're doing transplant in women, our area of donor area is very limited. Other differences are because we are not getting donor area from other places, the overall scalp density of the scalp is not increased. So if the patient says she has a volume loss and she wants to feel an increase in the size of her hair or a ponytail, that is not possible in female transplantation. This transplantation in females is mainly for the camouflage of the baldness. So when to consider hair transplant? When the patient is on medications and not getting adequate response, adequate treatment with minoxidil and probably finasterides and topical peptides. And when you have excluded patients in whom the surgery is not an option. Let's see the list of contraindications. When a patient has a hair loss, which is not amenable for surgery. Example, some few female patients present to us, the impetus is the sudden hair loss which happens to them. And this could actually be a recent telogen effluvium, which is overlapping on female pattern hair loss. So in such patients, we need to wait for about 5 to 6 months till the telogen effluvium settles down and then take the patient for procedure. The next is an active pathological condition. It could be frontal fibrosing alopecia or lichen planopilaris. In frontal fibrosing alopecia, patients are usually not aware that it's a pathological condition. They think it's general hairline receding which is happening or hair loss which is happening. So we will have to identify this, check if the disease is quiescent or not, and then take up the patient for procedure. Another condition is alopecia areata incognito. This is a little difficult to diagnose, especially when it is overlapping with female pattern hair loss. A proper history where the patient gives a sudden onset of loss of hair. They already have hair loss, and in that there's a sudden onset of loss of hair. And we should have a high degree of suspicion. Now we also have the dermatoscope, which will give us a clue. Alopecia areata incognito may be missed on biopsy also. So from history examination, we will need to identify if it is alopecia areata incognito. Other things we need to check is the quality of the donor area. And most important is the expectations of the patient. So normally it's not very easy to please women. Women have slightly higher expectations from these procedures and they're very easily influenced. So they listen to their neighbors, their friends, their family members. So all their comments also matter to them. So we have to make sure we spend adequate time counseling and tell them what they can expect from this procedure. So the goal of procedure here in hair transplant is mainly to increase the density without damaging the existing hair. Unlike men, women do not have complete baldness. There's always thinning. There is some amount of vellus hair. So while during the transplantation, we should make sure that we are not damaging the existing hair. We should tell patients that they're not going to get hair what they had when they were 15 or 20 years of age. Their main complaint will be scalp is visible. Even post-transplant, some amount of scalp may be visible, but to a lesser degree. Pre-procedure workup is pretty much as we do for in men, except that a more in-depth history, because in women, we have more other medical causes and hormonal causes which is causing alopecia. So some changes, like if the patient has polycystic ovarian syndrome, if there's any change in the medications like OCPs, if the patient is perimenopausal or menopausal, if it is postpartum, thyroid abnormalities, pituitary abnormalities. So we need to work up all these things. Coming to the hairline. The hairline is determined mainly by the genetics, by the hormones, the hairstyling and the habits of the patient, as well as the age. It may be a low hairline where it is close to the eyebrows, the patient has a small forehead, or it may be a high hairline where it is upmost in the crown area or a median hairline. Shape also matters. They can be straight, they can have a widow's peak where there's a protrusion in the middle. It can be smooth, bell-shaped, M-shaped, triangular, or uneven. So when we talk about hairline, the areas we consider are the frontal area, which includes the widow's peak, the frontotemporal recess, this is the area, then the temporal peak, which has come here, the infratemporal area. This area, when filled, it gives a illusion of small face, a slimmer face, and then the sideburn. Patients who undergo rhytidectomy or facelifts sometimes ask for a sideburn reconstruction post-procedure. In the Hamilton-Ludwig pattern, the usually hairline is maintained. So here it is pretty straightforward. We just have to fill in the gap which is needed, so we don't have to create a hairline. Other areas, thin vellus hair is there. Try and maintain the natural hairline and draw the hairline. Same thing here for frontotemporal recession. Do not make it very pointed. Do not make the angle very sharp. It should be very round. Female hairline is slightly smooth and round. So this formula, this is called the Dr. Farger's triangular concept, where it's explained how much of grafts are needed to calculate the area required when we're filling a temporal recession. From the frontal point to the peak of the temporal area, a line is drawn. And this is the apex of the frontotemporal recession. So a triangle is made from these 3 points and the area is calculated to calculate the number of grafts which can be placed there. So here in this patient, this is not a widow's peak. She did not have a widow's peak earlier. Following recession, there's an appearance of a widow's peak because hairline is maintained here, which she did not want. So this was the hairline reconstruction which was done for her. Now we come to the donor area. Anesthesia for the donor area is as same thing as we do. The method of extraction of grafts is same. We use smaller size punches, 0.8 to 0.9. First, we need to check for few qualities in the graft. Follicular unit density. A good candidate will have an average density of 2 to 3 head per unit, follicular unit. Interfollicular distance to be seen, hair shaft diameter, and the color, the texture of the hair, the wave of hair. See, we know that coarse hair and wavy hair with a larger caliber will give you an illusion of a better scalp coverage, giving a thicker result and a more camouflage compared to straight hair. So patients who have wavy hair will have better results, will perceive to have better results. Coming to donor area during the extraction process, most of the women will not agree for complete trimming of the occipital area like men do. So it's quite difficult to convince them. So what we do is window trimming. So in window trimming, part of the hair only is trimmed so that the hair which is there above can be used to camouflage this area. So the area is here, the area of hair is left without trimming. So this long hair will cover and camouflage the extraction area. The window size is planned depending on how many grafts we want, what are the type of grafts available, how much of area to be covered. So based on this, the area of extraction is planned. Implantation. What is the problem we face in implantation? There is, again, you don't have a smooth scalp. The hair is not trimmed. We have to do implantation amidst existing hair. So pre-made slits may become difficult at times to visualize. So stick and place method or using implanters become more convenient. I make slits and then use implanters to implant. This causes minimum graft handling and minimum resistance during implantation. So the method of implantation is purely your choice and the expertise. So whichever method we are comfortable or we are good at, we can practice that. To make slits, we use 21 gauge needle because the small microblades cause more inflammation, and probably there are reports where this causes more post-telogen effluvium, post-surgery telogen effluvium. We have limited grafts and we should make the slits, or our area of planning should be very strategic. Area where the patient wants hair. So either the partition or in the frontal area or the temporal recession, just plan where the patient wants density, and the idea is to increase the density in that area. Because we are doing a transplantation in between existing hair or non-trimmed hair, higher magnification loops will be required. That makes it more convenient. So you can see here that slits are made in the frontal area. The patient has a hairline, so that is retained, and in between the existing head, slits are made. If you're planning only temporal area reconstruction, so the normal irregularities have to be maintained. The hairline, thin single vellus hair are used for the hairline. For the transition zone, it's a single hair, 2 grafts for the second zone, and thicker grafts, which are 3 and 4 for the area which is closer to the hair. Post-transplant instructions and procedure remains almost the same. The hair starts growing back very soon, and in the donor area, they're not going to have so much of discomfort, or there's not much difference compared to males in the management. So when do we expect results? So we can counsel the patient. It takes about 8 months to 1 year. And if we are not seeing shock loss or that telogen effluvium is not there, sometimes even as early as 6 months. So this is a patient following transplant, the crusting which is seen. So here you can see that the scalp is still visible, but good camouflage from the combing technique. This is post-transplant. Hairline construction. Here, this picture I had shown earlier, where the patient didn't want the widow's peak and only wanted the hairline. And temporal recession, slits are made, and this is 8 months after transplant. Complications are more or less similar to those seen in men. Expectation in women is slightly higher than those of women, and the potential for dissatisfaction is also higher. Post-operative telogen shedding usually starts 2 to 4 weeks after the transplantation. That is the shedding of the existing hair around the transplanted area. This lasts for about 2 to 3 months, by which time the hair gradually regrows. And this is a temporary process, but it can be highly troublesome to a patient who already has sparse hair. So counseling is one thing which will make the patients be ready for this. So to summarize, hair transplant in women can be as successful as in men. A good preoperative patient selection, evaluation, spending adequate time in counseling, planning the procedure, and placing the grafts in cosmetically concerned sites will give good results. Now we move on to briefly about low-level laser therapy. Low-level laser therapy, also called as light laser therapy, red light therapy, soft laser therapy. Low-level laser is known to stimulate the cellular activity. The first US FDA approved unit is the HairMax laser comb. It has got approval for both female pattern hair loss and male pattern hair loss. This has a very interesting history. In the late 1960s, a Hungarian physician, he began a series of experiments to check the carcinogenic potential of lasers by using low-power ruby laser on mice. So the back of the mice was shaved and then laser beams were given. This laser did not cause cancer, but they noticed that it caused improved hair growth around the shaved area on the animal's back. So this was the first demonstration of photobiostimulation. After that, we have seen paradoxical hypertrichosis. That is, there's increase in hair, the coarseness of the hair, the density and the color in and around areas treated with laser. This is termed as paradoxical hypertrichosis. It is seen about 0.6 to 10% is the incidence. Another known fact is low fluence diode laser treatment. It caused terminalization of the vellus hair follicles. So these were the indications that low level laser actually is causing hair growth. The basic pathomechanisms here. Laser therapy stimulates the anagen re-entry in the telogen hair follicles. It's known to prolong the duration of the anagen phase. It increases the rate of proliferation in the active anagen hair follicles, and it prevents premature catagen development. So from all these mechanisms, ultimately clinical responses, hair loss decreases and there is increased hair growth and thickening of the hair. At a molecular level, it acts on the mitochondria, altering the cell metabolism through photodissociation of inhibitory nitric oxide. So this results in vasodilation, which is very similar to the mechanism what we see in minoxidil. Adverse events. The laser has been used for more than 50 years now for various indications. And in spite of that, the incidence of adverse effects are very, very low. When used specifically for hair, there are reports of temporary onset of telogen effluvium in the first 1 to 2 months, which subsides. It's temporary, so it subsides. One concern is the presence of dysplastic or malignant lesions on the scalp, which may be stimulated by the proliferative effects of low-level laser therapy. Applications are mainly to improve a variety of non-scarring alopecia, female pattern hair loss, AGA, alopecia areata, and chemotherapy-induced alopecia. So based on the studies and by knowing low-level laser therapy's effect on promoting hair growth, it has a potential in use in the immediate period post-hair transplant surgery to facilitate the healing process and improve hair growth. The wavelengths are of varying wavelengths from 635 to 1000 nanometer is used. Many studies, there is no specific protocol as how should be the frequency, for how long it has to be used. There are studies which are used daily, twice a week, thrice a week, or even weekly, and even for varied duration. Coming to the last topic on scalp micropigmentation. So in scalp micropigmentation, it's a permanent concealer. It's a camouflage technique where microdots are basically tattoos. These are placed to mimic the hair follicles to appear or give an appearance like they're cut very close to the scalp. By doing this, the normal contrast which is there between the pale scalp and the hair is reduced, which gives the illusion of presence of hair. The size of the microdots is less than 1 millimeter. We can do it either manually, and we have otherwise scalp micropigmentation machines with 1 needle to 3 needles. The dye is placed through the epidermis. It has to be placed ideally in the upper dermis. This procedure does not require anesthesia. The scalp is cleansed with betadine lotion. The area is marked. The depth of the needle varies from 0.3 to 1.2 millimeter. In cicatricial alopecia, we go a little deeper. And this is paper by Dr. Rachita Durat, where they have said that the speed of the rotor, when between 5,500 to 6,000 cycles per minute, it gives optimal results. The dots have to be placed very, very randomly to give a natural look. If placed linearly, it gives an unnatural look, and plain black dye is better. So this is a patient. I had shown it earlier how camouflage techniques can be used in women. So here, other than coloring the hair, I've done also scalp micropigmentation. Another male patient, this is the immediate results, immediately on the table after the procedure. Thank you.
Thank you, Dr. Savita. A very lucid, clear presentation and a very interesting one indeed. Now, I will invite Dr. Yasmin Jabin Bhatt to deliver her lecture on the approach and management of cicatricial alopecia in women. Dr. Yasmin is a dear friend and is my batchmate as well. She is the Associate Professor of the Department of Dermatology, Government Medical College, Srinagar. She has multiple publications and presentations to her credit and has authored multiple chapters. She is also the recipient of multiple awards, the IWDA Presidential Award, the WDC Scholarship, and the latest Dr. B.M. Ambadi Oration in 2022. She has many fellowships to her credit. She is the International Dermoscopy Society board member and is the coordinator of SIG Dermoscopy. Presently, she is Associate Editor, IDVL Dermoscopy Atlas, and the second edition of IDVL Recent Advances Textbook. She is the Section Editor, IJDVL, the editorial board member of multiple journals, and also the reviewer of many journals. Her special area of interest are dermoscopy, trichology, lasers, and skin cancer. I welcome you, Dr. Yasmin, to deliver your presentation.
Thank you, Dr. Sonali, for the kind introduction. It's always good to hear from a dear friend. Okay, can we just... am I able to... Can you please stop sharing?
The technical team, please help Dr. Yasmin.
Is my screen visible now? Just a second.
No, it is not.
No, ma'am.
Dr. Sonali, can you please, I can see you are,
Dr. Yasmin, I'm not sharing anything. Kirti, may you please help, ma'am?
Just a minute.
It is now visible, Dr. Yasmin.
Okay, it's visible now, right?
Yes.
Ma'am, please make it full screen.
Yeah.
Perfect, ma'am.
Sorry.
You're visible, audible, and the screen is also visible.
Okay, thank you. So till now, we have heard from other speakers speaking on the common causes of hair loss and various treatment options. So I'll be speaking on the approach and management of scarcial alopecias in women. Scarcial alopecias, we all know, are a heterogeneous group of disorders leading to irreversible destruction of the hair follicle. So the patient presents with these manifestations, and it is actually the permanent damage to the hair follicle stem cells, which leads to the subsequent scarring and is very difficult and frustrating for the patient as well as the physicians most of the time. So we have two types of scarcial alopecia, depending upon whether the inflammation is the primary cause or some other causes there. So we divide into primary scarcial alopecia. So the inflammatory inflame directly targets the stem cells in the bulge area, leading to permanent destruction. And they are further classified as per the North American Hair Research Society into 4 groups, depending upon the predominant inflammatory cell infiltrate, like into the Group 1 mainly has a lymphocytic infiltrate, Group 2 has a lymphocytic infiltrate, Group 3 the mixed cell, and Group 4 the non-specific. So these are the common ones here, which have been mentioned, which we see in our day-to-day practice. Then the secondary scarcial alopecia, here the inflammatory process causes a mechanical damage to the surrounding tissue, and with the result, it subsequently also affects the hair follicles so that they don't grow. So we have again a whole list of conditions like trauma, radiation, malignant and benign tumors, infections, various inflammatory disorders, autoimmune diseases, and deposition disorders, which ultimately lead to secondary scarcial alopecia. So there are a lot of factors which lead to the pathogen, which are involved in the pathogenesis of scarcial alopecia, like varying from genetic to environmental factors, and a lot of inflammatory mediators like cytokines, abnormal apoptosis, neurogenic skin inflammation. But ultimately, all of those have an effect on the bulge area of the stem cells. So there is a damage to this area. So the result, this is actually the site where this bulge area is located containing the stem cells. So if this is lost, if this is destroyed, the hair cannot regenerate. So we have a bald area where there is absence of the hair follicle. This is in comparison to the other inflammatory conditions like alopecia areata, where there's an inflammation in the bulb area. So this area is spared so the hair can regrow. So that's how we have the pathogenesis in case of scarcial alopecias. So in women, it's very frustrating once they have a scarcial alopecia, and we all know that it's very difficult to manage, because only in the acute phase sometimes we can diagnose this when there are a lot of inflammatory changes, but most of the time it is just subclinical, where patient doesn't have much symptoms and the loss is so slow that patient is not able to appreciate it, and the diagnosis is really challenging for the dermatologist as well. So it is a therapeutic challenge as well, because we initially were not having much of the treatment options, and it is a protracted course. And once the patient is put on treatment again, it's very difficult to assess a therapeutic success, as the subacute activity often persists or recurs in these patients. So what should be the approach to diagnose and to treat these patients? It's basically we should start from the basic history, then a thorough examination of the scalp and body sites, followed by trichoscopy and the skin biopsy. So we have to take a proper history regarding the chief complaints of the patient, where it's how the thinning has actually started, is it localized or diffuse, what's the total duration, whether there is any regrowth or not, what was the actual age of onset, is it recurrent or it's the first episode, is the hair loss diffuse or local, what previous treatments the patient has used, and that plays a very important role in the exact diagnosis. So always ask for the associated symptoms like itching, pain, dysesthesias, burning, eruptions, like especially pustular ones, the oozing and crusting. In case of females, it's very important to elicit the gynecological history, like the whether the patient is postmenopausal, whether she's taking any medications, especially hormones, so that have to be taken care of. Then other medical conditions have to be ruled out, like we have an association with the lupus erythematosus or lichen planus or sarcoidosis, ectodermal dysplasia, and certain tumors. Then cosmetic and hairstyling habits are very important. We should ask about the history of these. Many females use a lot of this cosmetics for the hair. So chemical or physical straightening procedures like in centrifugal alopecia, then traction of occupational recreation, headgear and helmet, etc. Sunscreen, lotions, and leave-in products, they are very important causes for the frontal fibrosing alopecia. So this should be followed by the scalp examination. So on an inspection, we should look for the area as well as all the signs of inflammation. Then we should do a thorough palpation regarding the tenderness, follicular papules, pustules, the Jacquard sign, where there is a smooth bald patch and it is atrophic, by looking at the wrinkling and other things. Then we should photo document these lesions, because once the treatment is given, so accordingly we can see how the response treatment is there. Lab and microbiological tests are to be carried out. Lab workup is mainly required for those patients who have other conditions like in lupus and other conditions or sarcoidosis, but at the same time bacterial and fungal cultures can be done in some of the cases where we suspect some infections. So this is just an algorithm of how to approach. Like in case of females, we should look for we have mostly the patients in the mid-adulthood or the post-menopausal and late adulthood. So we should look for the area of the involvement with the frontal, that's mainly the frontal fibrosing alopecia, whether it is knuckle, actical, or knuckle, which is very rare in females. But in case of, and in postmenopausal, we can have maybe the frontal fibrosing or pustular dermatosis of the scalp. When there is a central involvement, we should look for whether it is non-inflammatory, like in pseudopelloid rock or again centrifugal alopecia. And if we have inflammatory changes there, we should look whether there is a peripheral inflammation that's common for LPP and folliculitis decalvans. And if it's across the whole lesion, it's common for the discoid lupus erythematosus, alopecia mucinosa, and acne necroticum. So after this, we should do a routine trichoscopy of these patients. Trichoscopy, both handheld or USB dermoscopes can be done. So it has a very important role to play in the diagnosis of the scattershell alopecias. And we should not, in every patient of hair loss, we should go for it, because sometimes patients may simply have apparently non-scattershell, but once we use the trichoscope, we can pick up certain inflammatory changes and it can be a patient of scattershell alopecia. So the common findings which we see in the trichoscopy are more of the inflammatory nature, like we have the perifollicular scaling, we have the vascular patterns, which indicate either in the form of erythema or vessels, which may be short, linear, or comma shaped. Then loss of white dots, that's the absence of the fair follicles, is very important to see, like we can see here. Then white atrophic areas, which are the fibrotic areas or the scarred areas at the place of the follicles, which we can see. Then changes in the pigmentary pattern can also be seen. And obviously there are not much hair shaft changes compared to that of the non-scattershell alopecias, where we see more of the hair shaft changes. So trichoscopy, besides the diagnosis, also helps in the taking a proper biopsy, because we can see which area is more involved or inflamed, and accordingly it can give us a better yield of the biopsy. Then we can use it for sequential trichoscopy once a patient is put on treatment and see how much response has occurred. Or dynamic trichoscopy, like we have to give intralesional injections, then we can do that under the trichoscope. And in some cases of the fungal infections, ultraviolet enhanced trichoscopy can be tried. Then scalp biopsy, which is that forms the gold standard for the diagnosis of the scattershell alopecias. Ideal way is to take 2 samples, and we should take it from the most active site. In one chunk, we should do a horizontal section for the histopathology, and in the other one, we should do a vertical section. One half should be taken for H&E stain, and the other half for immunofluorescence, if we suspect such cases where it is needed. So then we have to stain it mainly for H&E stain, but sometimes we can also do mucin staining, or we can do the elastin staining to rule out some other conditions. Now, treatment of scattershell alopecias is very difficult, but we have to treat such patients, and we should keep a therapeutic goal before we give options for the treatment to the patient. So we should have a goal of stopping or at least delaying the inflammatory destruction, because we know that it is most of the times progressive, and we should elevate the subjective symptoms of the patient to improve the compliance, because most of the times patients feel that they are not getting a proper response, so they just discontinue the treatment. So our aim should be to improve the compliance. For that, we have to give certain treatment options to the patients. We should tell them about the side effects and the therapeutic goals, and ultimately the choice of treatment depends upon the type of the inflammatory infiltrate, the disease extent, and the activity. So in every, as before other speakers have also talked of the counseling, but counseling forms a very important part in the management of the patients with scapular alopecia, because it's something which you have to explain to the patient that they may not get a very good result, but they have to cope with it. So we have to give emphasis on the coping strategies in everyday life, develop a treatment plan which should be customized to compliance. We should sometimes offer the psychological support to such patients, because especially females, once they have the hair loss which is not growing, they are very much upset, and some cosmetic tips on the use of camouflaging techniques can also be given. So we should try to treat this, because it's a saying that invest in your hair, it's a crown you never take off. So obviously it means something for the patients once you treat them for the scapular alopecia. So the treatment varies from medical, surgical, adjuvant therapies, and cosmetic concealment. Now we have very common condition of the lichen planopilaris. So this is how dermoscopy helps in by the diagnosis by the presence of these target-like areas of the bluish pigmentation, as well as the peripilar scales and other inflammatory changes. So we know that topical steroids in various forms form the main treatment options for this. We should give potent topical steroids and sometimes intralesional also. And systemic steroids and other immunosuppressants are very important for the treatment, depending upon the severity. Recently, we have seen that JAK inhibitors like tofacitinib have a very important role to play, as well as retinoids, thalidomide, and pioglitazone, which has a mechanism of peroxisome proliferative activity receptor gamma agonist. So it may help in the patients of lichen planopilaris. Then we have the frontal fibrozine alopecia. Some consider it's a variant of LPP, but others consider it as a different. So again, the treatment is with the help of anti-inflammatory drugs, but at the same time, 5-alpha reductase inhibitors have been seen to have a very good role. Lasers and hair grafts have also been tried, in hair transplantation. Then trials of oral apremilast and topical gabapentin as well as PRP have seen to have a good response in these patients. We have another entity that's the fibrozine alopecia pattern distribution, which very closely mimics the female pattern hair loss. Rather, it coexists with it. It's some people consider it's a variant of LPP coexisting with female pattern hair loss. So we should treat both the conditions together. We should treat it with the anti-inflammatory agents as well as the topical minoxidil. And recently, some cases have been reported post-COVID also. Then riscoid lupus erythematosus, which can be easily picked up with the help of trichoscopy, with the presence of these follicular plugs in the form of yellow dots, and a lot of this inflammatory changes in the form of arborizing vessels. So again, we give a lot of immunosuppressants for these patients, depending upon the severity and other involvement. Dissecting cellulites of the scalp is another condition which coexists with other as a form of follicular occlusion pride or something. So here it's very important to aspirate the pus as well as do the immunomodulators, and then combination of dapsone and isotretinoin has been seen to have a good response, but laser depilation can be tried in those patients who are not responding to the systemic treatment. Folliculitis decalvans is another condition where there is a bunch of hairs coming from what we call as a polytrichia, and there are other peritubular casts can be seen with a lot of inflammatory changes, and we know that it's mainly because of the persistent Staph aureus infection. So we should give systemic antibiotics, usually rifampicin in combination with other antibiotics for a very long duration, or sometimes we may even need to ablate the follicle. Then centrifugal scapular alopecia, which is commonly seen in the Black women, and it has been seen to be associated with uterine fibroids and type 2 diabetes mellitus. The emphasis should be on the minimal trauma to the hair and avoid hair chemicals, and anti-seborrheic shampoos and other calcium inhibitors and minoxidil can be tried. But recently, topical metformin 10% compounded in lipoderm produced notable hair growth in 6 months. In the case of elderly females, usually after 60, they have been seen to have this erosive pustular dermatosis of the scalp, which presents as non-healing ulcers on the scalp, which may be misdiagnosed as malignancy in most of the cases. So again, here we need to give some anti-inflammatory drugs, or sometimes photodynamic therapy has been tried, and even surgical procedures have been done for excision. Traction alopecia, which is usually reversible in initial cases, but in later cases it may lead to irreversible alopecia. So again, patients should be advised to keep the hair loose, and topical minoxidil may help. Some rare causes like lipodermatous alopecia, where intralesional steroids have been tried, but with minimal response. So we have a very common condition, that's the pseudopallor of Brock, which where you see a footprint in the snow appearance, where there are no inflammatory changes and very a sort of depression at the areas seen the centrifugal distribution. So it's very difficult to manage with any kind of topical or systemic management. So we need to have some restorative kind of the treatment here, which we'll be discussing. And sometimes most of the skeletal alopecias lead to end-stage non-specific skeletal alopecia, where again none of the medical or systemic medical managements are effective. Secondary skeletal alopecia also depends depending on the cause. We should elicit the cause in them so that we can give them a proper treatment. Like here, this is following the morphia. This is like following the burns and tinea. So there are various surgical options for such patients, especially secondary skeletal alopecia and stage this primary skeletal alopecia. So we can do the excision of the affected area, we can use a flap rotations, scar reduction, the tissue expansion, autologous hair transplantation, as was just discussed by Dr. Savita. And both strip method as well as follicular unit extraction can be tried, and autologous wire transfer has also helped in these patients. So scalp reduction, we can do the serial excision of the scarred area, so that at the end we can just do the approximation of the retained hair. This is like following nevus sebaceous, which can be excised, and then the scar left with the cauterization can be excised and done the approximation. So here transplantation is a very tricky in case of patients with skeletal alopecia, because you should not have active disease. You should rather go for a test area to see whether it responds or not, or sometimes the scar area has to be remodeled first with the help of lasers or injection if you see any activity, and then here transplantation should be followed by the PRP and other things so that it gives a better result. So recently nanofat transfer has been used in the scarred area, so that there are certain growth factors which help in the growth of the hair, as well as it helps like after we do this the hair transplantation in this area, it is a very good response. Then adjuvant therapies like lasers, low-level light therapy, and platelet plasma, which were just discussed, they have played a very important role in regrowth of these hair in case of skeletal alopecia. Like the ablative laser has a role because we know that the recipient area has a very poor blood supply here. So it leads to neoangiogenesis, growth factor release, and cytokines, which help in the wound healing. So there is the accelerated growth of transplanted hairs. Certain non-ablative lasers like long pulsed Nd:YAG laser has been seen to be helpful in Frontal fibrozine alopecia, again because of the increased blood flow, release of cytokines and growth factors. So low-level laser therapy mainly helps in lichen planopilaris by increasing the proximal proliferator activity receptor gamma expression, and it decreases the activity index in LPP patients. Also, low-dose 308 nanometer excimer laser has been shown to reduce the inflammation. And platelet-rich plasma has been specifically seen to help in patients of lichen planopilaris, centrifugal skeletal alopecia, and frontal fibrozine alopecia. So growth factors released arrest the development with regression of itching and other inflammatory signs. Cosmetic concealment, as was just discussed by Dr. Savita, they can be offered to those patients where we cannot expect any results. So there is no need for patients to be so disappointed. So there is definitely some help to offer to these patients. And in some other cases, resistant cases where there is no other option or no other treatment works, we have the hair prosthesis in the form of wigs, hair pieces, and hair extensions, which we can offer to these patients. So to conclude, skeletal alopecias are an enigmatic group of the hair disorders, which can be frustrating both the patient as well as the treating dermatologist. It's very important to recognize them as early as possible so that we can manage the patients on the time. And the best possible treatment plan can be implemented, whether it's medical, surgical, or adjuvant, and counseling forms an important factor in the management of these patients. Thank you all for a patient hearing.
Thank you, Dr. Yasmin. It was very well done justice to a very arduous topic of cicatricial alopecia in women. Congratulations. Now we have questions from the audience, but as we have a panel discussion, most of these questions will be dealt in the panel discussion section only. The few which are left will be asked separately. So I invite all to please switch on your videos and audios. I'll be sharing my screen. Is my screen visible?
Yeah.
So now we'll be briefly since morning, telogen effluvium. So telogen effluvium, as Dr. Had already described, it can be categorized into two types. Dr. Aman, could you briefly go through what does acute and chronic telogen effluvium indicate?
Yeah, so acute telogen effluvium is hair loss less than 3 months, and chronic is more than 3 months duration. But then it is also very variable as to abrupt, it is rightly over here. It is very abrupt, rapid. Patients usually come with, lumps of hair and loads of hair shedding. But in chronic, it's generally insidious, lasting over months to years, and they've been having overages, and it's not very lumps of hair. It is not very lot of shedding, but it has been insidiously going on.
Yes. So as you've already stated, and it was discussed by Dr. Atotha, so acute will be less than 6 months and chronic will be more than 6 months, and resolution in acute is in 3 to 6 months time, and in chronic it may take months or years to resolve. So how common is telogen effluvium in clinical practice, Dr. Savita?
It's quite common, especially in female patients, and I feel telogen effluvium is most of the time it's combined with female pattern hair loss. After a point, it's very difficult to differentiate that this is only female pattern hair loss and there's no telogen effluvium. Many a times, telogen effluvium will be a forerunner for female pattern hair loss, especially the postpartum patients whom we see. Telogen effluvium continues, and then the female pattern, the proper pattern, emerges with time.
And how would you differentiate it from a physiological hair loss?
Patient will experience this shedding of hair, which is more normally they have the hair shedding and they're used to it, whereas this will be a physiological hair loss. However, when it's telogen, they'll say this presence of hair which is of a recent onset. There's more hair on the pillows, or when they shower, they see much more hair loss than what is happening. And then we have the hair pull test, which can be done, where more hair comes in our hand when we gently just run our hair fingers through the patient with a gentle tug.
All right. How common is TE in men, Dr. Yasmin?
Yeah, definitely it is seen in men as well, not so common as in females. Maybe they're not very much concerned about it, so they report less to us. And most of the times it's in our mind also that males have, whenever they come, we just often look for the male pattern hair loss, but definitely it's going to be there with them also. And in those, we should have the underlying causes. Well, stress forms an important. Recently, we have seen this post-COVID in males as well. It's not only in females. And obviously, they report a bit later because the hair is too short for them to appreciate. But definitely, we have the patients coming in, but not as commonly as in females.
Exactly, rightly said. Dr. Atotha, I would like you to briefly go through the history taking, which is very important in a patient who comes with a symptom of diffuse hair loss.
Yes, we have to ask the duration as to differentiate between acute and chronic. And the initiating triggering factors should be noted, any fevers or any recent illnesses. And as you said, associated symptoms. And nails is also one of the things we should look after, because Bu's lines will be an indication which can be seen along with telogen effluvium. So we have to look after the nails. And any other skin disorders to rule out the other cicatricial alopecias before coming into telogen effluvium. And trichodynia, which is a common symptom seen mostly in few symptoms, and even in senile telogen, then hair loss in senescent women, trichodynia is usually presenting symptom. And drug history is more important than any other things. And recent treatment malignancies or treatment where are undergoing any chemotherapy, their nutritional history, their severe crash dieting, and other things, the family history related to the other any autoimmune disorders or thyroid. And in females, mostly menstrual history and the contraceptive pills if they are contraceptive, and postpartum, which is a common presenting symptom, should be taken care of.
Yes, one more point I would like to add. In my setup, I am seeing lots of patients of B12 deficiency presenting with trichodynia.
Yeah.
So, any points to be added in the history taking? Any panelist can add?
And the styling agents, regarding the hair styling agents, usually after the cosmetic procedures, also telogen effluvium is commonly seen. So that history should be taken.
Exactly. Now coming on to examination, is it only the hair we examine, or we also examine the scalp? And in doing so, what are the points which we have to look for? Dr. Aman?
Yeah, so we routinely do trichoscopy, but even if you don't have a trichoscope with you, so you must look at the hair, you must look at the pattern, you must look at not just the hair, also the scalp. So I do a pluck test. I just catch hold of like around 20-25 hair and try to take them out. And after you pluck it, I put it on a white sheet of paper and examine that under a magnifying lens. So you should look at the plug here, whether there is a white plug at which is very characteristic of telogen hair, or is it an anagen hair. You must look at the shaft. You must look at, is it there breakage? Because you have to differentiate breakage from the hair coming out from the root. So a pluck test is very, very, it can show you whether it is an acute telogen effluvium, what kind of hair loss is happening. And also the pattern of hair loss, very rightly said, redness, inflammation, and all that. But trichoscopy is a must. If you're running a hair practice, you need to have a trichoscope with you. See.
This I was only talking about the visual examination of the hair.
So we should do all the bedside tests, like pool test is very important. Why, if you have the easy you get more than 10% of the hairs, it is that quite evident of telogen effluvium. Then a blood test, as you were saying, the trichogram is very helpful, where we can just rule out that most of the hairs are in the telogen phase. And the other test with Dr. Kavita that I mentioned about the 1 or this 60-minute and the 3 we should tell the patient not to wash his hair for 3 days, and then let her get the hair what she has has been coming out, and then look for the hair roots. So these are all the tests which we should, these are all the clinical tests, the examination we can do those tests. And besides, systemic examination is also very important. We should look for the anemia, we should look for the signs of any other disorder, which where we can, nails as well, where we can get a clue for the telogen effluvium.
How common is the pull test? If pull test vis-a-vis the wash test, what is commonly done in your practice?
Okay, for me, it's usually the pull test. So I do it in most of my patients, the pull test, not only for the telogen effluvium, for other conditions as well, like it's positive in alopecia areata as well, but definitely not in this pattern hair loss, and like in cicatricial alopecia also we do it. So in some, where there's the bogginess and other things, we can easily get the pull test positive. So it forms a very important part. Wash test is a bit messy for the patient, but sometimes you may have to do it as well.
Dr. Atotha would like to add?
As Madam said.
Okay. So dermoscopy, what sites to include, and what are the findings you look for in examining a patient for diffuse hair loss? Dr. Savita?
dermoscopy, I do the frontal area and the temporal area. Mainly helps to differentiate between female pattern hair loss and telogen effluvium. So we have the specific findings. That's where I use it. And in hair transplant patients, the occipital, the donor area also.
Okay. And what are the findings you look for? I think that has been discussed.
Yes.
If you could enumerate few features.
See, I think what Dr. Savita said is okay, but we should never miss, we should do it routinely on the occipital area as well. Like for female pattern hair loss, it's very important to see the hair, not only for the treatment purpose, but we have to compare the occipital area as well, because it depends upon the indigenous density of the hair as well for the patient. So always compare it with the occipital area, then because there are certain criteria now, Racco whiskers and others, so where they have seen that how much should be the density in the frontal area compared to the occipital area. So always compare the frontal portion with the occipital in case of trichoscopy. That gives you a better idea of the hair loss. And obviously there are findings for different conditions, and they are very defined findings. Like you can easily get a diagnosis from that if you are like used to it. And sometimes, you know, it is the criteria are so obvious now that some pathologists even say that go for the histopathological trichoscopic correlation. So because sometimes in histopathology you have certain confusion, but most of the time you don't have so much confusion in case of trichoscopy. So there are set criteria for all the different kinds of
so dermoscopy is a very important integral part of diagnosing
definitely.
The hair disorder.
And we cannot do biopsies in so many areas, but dermoscopy we can see each and every area we can look at.
And then again, taking the biopsy from the hair is tricky.
Yeah.
You need to have the proper site where it can guide you.
So there was a question from the audience also. What is the preferred site of biopsy, and whether you will take a single biopsy or multiple biopsy in case of you want to differentiate between CTE and FPHL? Dr. Aman?
Yeah, so chronic telogen from any biopsy, I take minimum 2 or 3 at least. You have to, you know, look at, and a 4 millimeter punch is my favorite. And we take from at least different sites. And if suppose you're suspecting a lesion, you must take it from the edge of the lesion. The center is usually, like burnt out. So you usually take from the edge of the lesion, like it is the rule with the biopsy. And in female pattern, you know where it is going to be most miniaturized. So you prefer to take those sites, the center and the sides. Whereas in telogen effluvium also, although it is more all over, but still, the front and the sides. But I do take into account the combing pattern of the patient, make sure that it's not very cosmetically visible. And so that the patient doesn't have problems sleeping. And if it's a side partition, don't take it from the side as the scar might show. I mean, she can be uncomfortable later on. Yeah.
Okay. So TE will show no miniaturization of hair follicles on biopsy, and terminal villus ratio of more than 8:1. Anagen telogen ratio of 8:1 will be seen vis-a-vis 14:1 in the normal scalp. These are all technical terminologies. So the crux is that the 4 mm biopsy from the vertex with adjoining areas, 2 to 3 more adjoining areas, is important, and a horizontal section should be taken to diagnose a patient. Now, what are the lab findings, Dr. Atotha? You had already mentioned. So there's a question: what is the significance of serum ferritin in post-COVID hair loss, as it is going to be raised anyhow? So what would you like to do?
Yes, in the COVID, serum ferritin, high ferritin levels are indicated, but once the COVID has subsided, after 1 month or 2 months, the ferritin levels are going to become normal. Even after 14 days after COVID infection, the levels are supposed to be normal. In telogen effluvium, we can see the decrease. We can see the ferritin levels after once they come to us, we can test the ferritin levels. But in that apart from ferritin, there we have to check the vitamin D levels, B12, and also others in the post-COVID.
Yes, Dr.
So you can check for the total iron profile, not just ferritin. So
Yes.
if you check the total iron profile, you'll realize whether it's a fallacy or just the ferritin is low.
Serum transferrin levels are TI.
Yeah, the total iron binding capacity, transferrin, and all. Yeah.
So in the acute, as far as the COVID is active and post 1 or 2 months of COVID, ferritin should not be done because it's not going to give us any information. And post 2 to 3 months, we can check for ferritin. Now, what are the other hormone evaluation you would like to undertake in a patient, not suspecting female pattern hair loss? Apart from thyroid, would you evaluate patient on other hormonal profile? Yes, Dr. Aman?
Yeah, so AMH is one hormone that I do. And I also go for DHEA, testosterone, that is the total testosterone level. But these days I'm finding the more I'm getting prolactin done, there's a lot of prolactin levels which are raised in patients having hair loss. So I don't know about the panel agreeing with me, but if you get a prolactin done in a patient with hair loss, a lot of times it is raised. Female.
Dr. Savita?
Yeah, I agree with Dr. Aman about prolactin. So of late, we are seeing a lot of, especially PCOS patients or any patient with female hair loss investigations. Prolactin has become a routine these days for me because I've seen it to be increased.
Yeah, many patients taking drugs like levosulfide and this domperidone for their gastric problem. Most of them have high prolactin levels, and definitely we should measure that and stop those medications.
So the other hormonal evaluation would be AMH, prolactin, and testosterone.
Yes.
Right? Okay. This has already been discussed that acute and chronic TE can uncover an ongoing female pattern hair loss. And can few patients of chronic telogen effluvium be early female pattern hair loss patients if properly evaluated?
Yes.
Dr. Thota?
Yes, definitely. Most of the cases, they are found to be FPHL later.
So all the DDs have to be virtually kept in mind whenever we are evaluating a patient of diffuse hair loss. Now, management, nutritional supplementation forms an important part. So this has been discussed. What I would like to discuss the ferritin level cutoff. Do you take it 40 or higher?
I 70. Take it 40 nanogram per hour.
This is a debatable cutoff. Dr. Savita?
I take it slightly lower, 30 actually.
Dr. Yasmin?
Same, 30 to 40.
30 to 40. So Dr. Aman would also go with 40.
No, 70. I mean,
70.
for hair, I'd go with 70, but then it's very tough sometimes to reach 70. So ideally, it should be 70, but 40 and anything above. Yeah.
And for convincing the patient that they had something, usually they expect something when they get the investigations done. That also one of the things. They'll be satisfied.
And if it is less than 10, I do advise iron drips. Okay. And we do that. We give iron drips to patients less than 10 ferritin.
Yes, makes sense. Coming on to biotin supplementation. So is it a fad or we have various studies to back up our dose and duration of giving biotin? Your take on it, Dr. Savita?
Personally, from experience, I feel it does work, but studies are very varied. We have studies from 1 milligram per day to 5 to even 10 milligram per day. So if you see the studies, it's very varied. I normally go to the 5 milligram per day. Personally, I feel biotin does work. And along with the nutritional supplements, biotin does have a role.
So and how long would you give it?
3 to 4 months is how much I give it for.
Okay. And vitamin D supplementation, your take on it, Dr. Yasmin? Do you routinely get vitamin D tested?
Not usually for every
test.
Not usually for every patient of telogen effluvium, I do vitamin D unless I found that it is a pathogenic factor. But what I give routinely is iron and zinc. So zinc I usually give to my patients much commonly than biotin. But vitamin D definitely in like premature canities, I always give vitamin D. But telogen effluvium, I don't give it to every patient unless the patient has other signs of vitamin D deficiency.
But the incidence of vitamin D deficiency is very high.
Yes,
if we get at least 10 patients examined, 7 of them will be deficient.
I think 9, it would not be wrong to say even 10 out of 10 are deficient. So there was a discussion in our local group who inadvertently write vitamin supplementation in every patient of hair loss. So that is what has been done. Now, your take on other amino acids, minerals, and protein supplementation. So do you go in for the gym proteins and gym food? All the second teenagers and the health freaks are going, Dr. Aman?
Yeah, so these days I definitely ask in the history any supplementation you're taking, any proteins, because I find patients taking less diet and more of supplements. So I even suspect hypervitaminosis to be cause of the hair loss at times, because they've been taking, those omega-3s over months together, or they've been taking those multivitamins and endless. And even protein supplementation, there is recent documentation that overuse of whey can also lead to hair loss. And we have to be very careful. So there has to be a balance. Although a certain amount of protein is required for hair, but you cannot go away from the fact that it does not have to come from one source only. So I tell the patients to be balanced. I mean, you can use 1 scoop of whey, 25 to 22 grams per day, but then rest of it has to come from various sources. So it could be plant-based proteins, or it could be animal proteins, or sprouts and all those things. I take a very detailed history, and I actually calculate the total amount of protein a patient is taking, because that does affect the hair growth. So, and I do prescribe protein supplementation, something like omega-3 OGM powders or pro DHAs or something like that. But then they have other things, and they have a very low content of protein. In fact, if you look at those powders, if you look at Protein X or other things, they have very low content of protein actually than the gym-based powders. They have very high amount of proteins, which is there.
There are many gym people who are taking raw eggs also. I get patients taking 10 raw eggs in the morning and night. So what is their advice? Any correlation of raw eggs and biotin?
Yeah, it can cause deficiency for sure.
Deficiency.
Yes.
Yeah,
So
it can
raw
cause
eggs also, because people tell that I take 10 eggs in the morning and night. Please inquire if it is raw or cooked. So again, biotin supplementation would be a definite option in those patients. Now the role of cyclical nutritional therapy. So there are two schools of thought again. So what is your take on it, Dr. Yasmin?
I think that makes sense. Nutritional therapy, like I tell my patients to take adequate nutrition, especially I give emphasis on the proteins.
I'm talking about cyclical nutritional therapy.
Okay.
Not the routine ones. Savita or any other panelist?
That's again also important at like in the initial phase when the patient comes, we should try to give it in that way.
So I do choose my patients where I have to give cyclic nutritional therapy. It is not like every patient of hair loss deserves a cyclic nutritional therapy. I mean, patients who live outside their home, students who are in hostels, who are not on a very good diet, who are rarely eating home food, and who are missing out on the most parts of the the essential nutrients. There I prefer to give cyclic nutritional therapy. But in people who are evidently having hormonal hair loss, and where there's just one specific thing which is deficient, maybe vitamin D deficient, maybe iron low, and otherwise the diet is okay, so I don't prefer to give cyclic nutritional therapy to all as a blanket rule. No.
So if there is a short pre-cut deficiency, treat it every day. Or if you want to supplement in a patient who's not so deficient in other vitamins, cyclical nutrition therapy will have its play. Okay.
Better. Yeah.
Okay. Now coming on to the management, what is the role of topical corticosteroids? Would you like to give it to the patient or not in acute telogen effluvium and chronic telogen effluvium? Dr. Savita?
No, I do not practice topical steroid in telogen effluvium.
Any other panelist? Does any other panelist?
If there is trichodynia, I give topical steroid to reduce that.
And what is the, and for how long, ma'am?
Usually till the patient complains, not for a long time, but usually till the symptom subsides.
Also, if there is inflammation, I give steroids like seborrheic
dermatitis.
Yeah, seborrheic dermatitis or something. Yeah,
can be given there, but otherwise not.
No, if there's no associated seborrheic dermatitis, then trichodynia is one of the condition where topical corticosteroids can be given for 2 weeks duration. Now coming on to minoxidil, the type of preparation and the percentage of minoxidil which you commonly use in female patients, Dr. Yasmin?
Yeah, for female patients, we start with, so I usually don't give minoxidil directly to all the patients of telogen.
Not in the acute
Yeah, yeah. But if there is no response for long time with other measures, then I switch over to minoxidil and I start with 2% initially, 2% twice daily. That's safe. But after that, if the patient is again not responding, so I switch over to 5% foam once daily. So that I feel has a very good response in most of the patients. And if there is associated female pattern hair loss, so it treats both the conditions together.
And how long do you continue it?
Yeah, at least 3 months.
Or beyond that?
For chronic, at least 3 months, but it may be extended up to 6 months.
Any other panelists want to add to the duration of minoxidil?
Usually I ask them to continue for minimum of 1 year.
Yes.
1 year is what I give.
Otherwise to continue.
And what are the insights on gradual reduction or stopping it all for sudden? Yes, Dr. Aman.
Yeah. So in chronic telogen effluvium, it's my last bet, minoxidil, because I feel that the dependence on minoxidil and then how they would stop it, because I feel patterned alopecias respond much better to minoxidil rather than CTs, although it would definitely never be the first go. I would prefer to look out for the cause and peptides and other formulations that we give, but minoxidil is not something my go-to drug in CTE. I prefer it as a last resort, because sometimes CTE coexists with female pattern. It is there that it acts best, but I find if it is alone only CTE, I don't give minoxidil.
So you start with the peptide formulation.
Peptide formulations, those Follica, Folirate serums, and we add some peptides like Capexel and all those things. But since we're looking out for a cause, and I do find that use of minoxidil in women is very tricky. If they're using a hair color, they don't want to use it because it washes off the color very frequently. They don't want to put it every night on the scalp and then wash it off in the morning. And my preferred is 5% minoxidil straight away. I don't use 2% if I have to give minoxidil 5% at night. But it is very difficult convincing a woman every day to do a head wash the next day once you've applied minoxidil at night because of cosmetic reasons and other. So I keep minoxidil as the, at the back end, not as a first line drug. Yeah.
All right. Now coming on to peptides. Yes, ma'am. Now coming on to peptides, there's a huge array of available preparations. So kindly one by one tell me which peptide is your favorite and is giving good results in your patient, starting with Dr. Atotha.
Yeah, usually I go for Capexil or Procapil. Both of them I find useful.
Yeah. And for how long, ma'am?
Minimum of 2 to 3 months. Once they come back and tell that my hair fall is better now, it stopped at least by 50 or 60%. Till then I continue. If they are ready to pay for that and ready to get it done, I'll ask them to continue at least for 3 to 4 months minimum.
All right, Dr.
Savita. If they can't afford, I change the drug then.
Procapil
with Procapil, containing Procapil and Aminexil combination. That's my thing. I give for a longer period. First follow-up I call after 3 months actually, and then again prescribe for another 3 months. So at least for 6 months I give them peptides.
Dr. Yasmin?
Yeah, same. The thing is, most important thing about the peptides is most of them are in the serum form. And once the patient is applying that, patients are very happy that way, that their hair texture is very better. With that, they don't have to use conditioners and other things or other shampoos. So I think cosmetically, it is very pleasant for the patients. And at the same time, it's helping in those who don't have other causes. And I also start with the peptides, mainly Aminexil or Procapil. And usually they are a combination of many other peptides and sometimes oral supplements as well, and they do good with it. Minimum of 3 months, sometimes up to 6 months. But after 3 months, if there's no change, I switch over to minoxidil then.
Dr. Aman is your favorite is peptide, as you have already told. Now there was a
question.
But
I like caffeine also. I like a combination with caffeine as well. So caffeine works really well. When you are looking for a peptide, look for something with caffeine and peptides, and those kind of combinations work well.
Okay. There was a question, how frequent should be the follow-up? Like Dr. Atotha said, she calls the patient after 3 months. How frequent should be the follow-up of hair loss patient? There was a question from the audience.
Follow-up usually I ask once in a month.
Once in a month.
The continuation, yeah.
Oh, continuation
3 to 4 weeks.
Yeah. 3 to 4 weeks. All right. Okay. Now, any of you using oral minoxidil in CTE?
Not CTE. But I use oral minoxidil, but not CT.
Not in CT. Okay. And you are using it in FPHL?
Yes, I'm using in female pattern and male pattern both, but not in CT.
There's a question from the audience. What should be the dose of minoxidil and what is the preparation available in India? Dr. Yasmin?
So there are,
yes, Dr. Atota. Any of you can take it.
Personally, I'm not using it because at our place, the preparations are not available in this dosage. We should use 2.5 mg. It's not present. We have the higher dosages. So I have not given to till now to any of the patients because the right preparations. And if we tell them to use other preparations, they may not use a proper dose. So because of that, I'm avoiding.
Okay. What is the preparation available in India?
I think it's 5 mg.
5 mg.
Has to be cut into
Lonitab by Intas.
Intas.
It has,
Yes.
Intas has 5 mg, which I break up and give the patient half, 2.5. There's another one available in 2.5 also. And but the latest recommendations say that you start with 1.25 and then move up to 2.5 if needed, and only at night time. And in men, people are given even 0.25. Australian studies by Rodney Sinclair and those, they're recommending very low dose of minoxidil to start with.
There were sublingual preparations also.
Yes,
We have
we
lesser
are not
chances of
having.
postural hypotension. So it is
Yes,
still to arrive in India.
yeah, we don't have it.
Now, what about your take on melatonin and various prostaglandin analogs in CTE? Dr. Savita?
Sorry, I have not tried. I don't have much experience with it.
Okay.
So
Yes.
can I take that?
Yes, can you
Melatonin is a hormone which is relaxant. So in patients with stress-induced telogen effluvium, or you have a very evident, history of stress, melatonin is a sleep inducer and it calms you down. So melatonin has definitely come up as one of the alternatives, but as a sole, I don't think it should be used or anything, but you can see products with melatonin for relaxation, because stress is a major cause of telogen effluvium.
There was a preparation of topical melatonin also in the pipeline. I don't think it has yet arrived in the market.
Yeah.
And what about prostaglandin analogs? Do you
I
use
think
them
for
in-
eyebrows or eyelashes, we have
Not
these,
for the hair.
not for the
Areata,
scalp.
it's mainly for the areata.
All right. Now, what are the general measures that patients have to be given about hair? They'll ask you 100 questions, what hair color to be used, whether it should be ammonia free, blah, blah free, this free, that free. So what is the general advice about hair colors you give Dr. Atota?
Yeah. If they are not having any contact dermatitis or not hair loss, then I ask them to continue the same. But otherwise, if they are usually ask them to go for this ammonia natural products only, the natural henna, which doesn't color if they need, but only if they ask for the black color, then I'll go for the other option which we have now.
Okay. And what about any specific, they will also ask you what type of oil to be used. So any advice regarding hair oil, the safest hair oil?
I ask to stop them applying the oil.
Yes.
Unless 1 hour, if they insist, 1 hour before they shampoo, not
On
daily
the shaft.
application of oil.
On the shaft.
Yeah.
And what is the best oil? They'll also ask you.
Coconut oil, we tell them to apply. That's the smallest number of this size of the molecules.
Here they ask us about virgin olive oil and many types of olive oils, which I'm clueless. So, Dr. Aman, you wanted to say something?
Yeah, so when you are giving an advice about hair color, always tell them that to apply hair color 1 or 2 shades lighter or darker. I mean, don't go, totally out of the color range. Don't go into blonding and then streaking and all that, especially if you have weak hair. I'm sure a lot of youngsters don't listen to that.
They
want to do that.
Colors.
Rainbow colors, purple, red, and all those kind of colors.
Red. Yes.
Yeah. So yes, that will damage more if you are totally stripping the hair color of your hair. And regarding procedures like keratin treatments, even hair Botox and the later are cysteine and all that, they are hair relaxing, smoothening treatments, but with a lesser amount of damage, so-called. But if you have an existing hair loss happening, you must advise the patient to avoid for a few months. We can't Nobody's going to stay away. If they want to do it, they will do it anyways.
Yes.
So, but at least in a condition where there is more breakage and they're experiencing hair fall, to just defer the procedure. And yes, hair oils, these days, rosemary is very, very popular now. They say it is alternative to minoxidil, and it has come up, and there are studies supporting rosemary as another alternative to minoxidil, which they can apply and stimulates hair growth. So otherwise, coconut is the best. Yeah.
All right. All right. So if there's active hair loss, procedures have to be avoided. That is the take home. Now, PRP, you have already explained, and how long, how many, you have already told there are no specific guidelines. So for a beginner who is hearing this presentation, what would you advise? Whether they should go in for commercial kits available, which are easy to prepare, but they're costly, or they should go in with the routine double spin method? Any of you has found different results using these two methods?
I find, okay, sorry, please.
No, please go on.
Yes, please go ahead, Dr. Yasmin.
Yeah, double spin is routinely done, and I think it gives a better yield than the single spin. But there are some commercial kits which write from there that only single spin is good, but double spin overall makes more sense and it gives a better yield.
All right, Dr. Aman.
Yeah, so I have a little point of contention with the closed systems or the kits that are available, because they have this 10 ml tubes, right? We in our clinics, all our clinics, we have a system of 40 to 60 ml of the blood that is we take out in one go. And we have an open system. We have changed the router of the system. It's a cold centrifuge, and we'd like to have more amount of PRP available. So with these commercial kits, they usually have a smaller set. I see most of the people take just 10 ml and take out like 1 ml of PRP, which I find is not worthwhile. We inject at least 6 to 7 ml of PRP all over the scalp, which should be the rule. Like if you have to inject, you have to inject a good amount. If you are spacing it 1 centimeter apart and 0.1 ml all over, I mean, you need a good amount for sure. So 40 to 60 ml is the rule. Sorry?
At least 20 ml.
Hanji. So yes, so 20, at least 20. But what happens is you get a plug, you try to dilute it. You try to dilute it more with PPP and make it to 10 ml or 20 ml to inject all over the scalp. But if you were to take out from something like 40 to 60 ml, you would definitely get a more higher amount of PRP. So the problem with these commercial kits is like you have to either do it more in rotations or do less. So double spin method.
Double spin.
Yes, I always do double spin. That's what we have been doing. Yeah.
Dr. Atotha, you go in for commercial kits or double spin?
Initially, I used to go
Dr.
for double
Savita?
spin.
Okay.
Yeah. Now I'm using both depending on, but definitely I find few of the commercial kits are very useful.
Okay. All right. And what about you, Dr. Savita?
I'm using commercial kits these days. I think both work well. I've not found much of difference in the two, and also depends on the patient's budget. I also work in a medical college, so there we don't have commercial kits, so we use the normal tubes and do it. It works well.
All right. So we have takers for both the techniques. All right. Now coming on meso, you have already described it, Dr. very well. So again, as I've already told, there are no specific guidelines, no protocols, multiple kits available. Can you give us two commonly used kits which you are using for scalp meso?
Yeah, so Leaderma company has a good one, and I like that. Then Magnificare is another one that I'm using. And advanced Magnificare.
And which is the more economical one? Because starters would like to go in for.
I think Leaderma is very economical, and they have a substantiated kind of a thing, and it's okay. You could even use cocktails rather than individually taking out different things. It would cost you more, and you have limited patients. So we use minimal 2 ml of meso solution while we are doing a mesotherapy. And initially I had meso gun, and then I shifted to, because there was a lot of breakdown with the meso gun. There was a lot of wastage. The fluid used to keep sipping out, and it was not very doable, kind of not very practical. And you invest 1.5, 1 lakh into a meso gun, and then you have all those kind of things coming up. So then we started doing manually. And of late, I'm using electroporation after a derma roller also for the mesotherapy. So all kinds of mix and matches we are doing. My protocol is 7 to 10 days. And I like to combine it with low-level laser therapy. So when the patient comes, so we make the patient sit under, we have a whole system of low-level laser therapy and for around 36 minutes, and then we do a mesotherapy in the same session. So we repeat the same every 7 to 10 days for a total around 10 to 12 sessions. And we are seeing good results, very good results. There's always volume, especially for women who are, blow drying every week, who are just not washing their hair home, and a lot of damage happening. As a simple thing to reverse that, to add volume to the hair, I think meso is a good solution. Yeah.
There was a question: is Mesogun same as Dermojet?
No, it's not. Meso you're injecting, Dermojet you're not injecting.
Okay.
That's how I understand that. Yeah.
Dr. Savita has already spoken about low-level light therapy. Any commercial available devices available which you could quote to start with?
One local company we have here, which has supplied, actually Dr. Asim gave me the link to that. I do not use it very often also.
Okay. Okay. So that link needs to be taken from Asim only then. And scalp micropigmentation, again, you have described it wonderfully. Any available pigment kits available? Any commercial name you could suggest?
I get mine from Pageco. So I use the ones from Pageco.
Right. Hair transplant, again, you have already dealt with ideal candidate, ideal method, and follow-up. So what is the ideal candidate you would like to take up for hair transplant?
Patient who has a very localized, like only reconstruction of temporal recession, or who has a hairline and needs the frontal area to be filled. I would avoid female patients who have extensive and the diffuse type of hair loss. And patients with acute telogen effluvium is a definite no-no.
And what would be the...
Hello?
Ideal method? Can you hear me?
Sorry, I didn't hear the question.
The ideal method of the transplant?
Follicular unit extraction is what I... Yes.
Right. Now, coming on to the last but not the least very important topic, cicatricial alopecia in women. Dr. Yasmin, how frequently do you encounter it in your practice?
Yeah, so we see a lot of patients of cicatricial alopecia around what the books also say, it's about 3 to 7% of the alopecias. So keeping in view how many patients of alopecia we see daily in our hospitals, so compared that, it forms a significant chunk, and most of the times it's underdiagnosed. I would say that it's underdiagnosed because it's most of the time subclinical, where patients doesn't complain initially unless they come with a bald patch to us where it's totally lost. So it forms an appreciable amount of the patients in our OPDs.
And diagnosis is by the dermoscopy and biopsy together.
Yeah, definitely. And we should not miss history and examination as well. So that forms an important, part of the management protocol. But dermoscopy is very important to do. And biopsy, of course, forms an indication for cicatricial alopecia. Like in my practice, I have stopped doing biopsy for most of the female pattern or telogen effluvium, but this is the area where it has to be done just to be sure of the type.
And how successful is the hair transplant in cicatricial alopecias when the active disease has been?
See, I mentioned in my talk also that it's very tricky because most of the times the area is scarred. The graft once we put on the recipient area, it is a very low take because of the less blood supply in the area, and it's very thinned out, so it cannot even retain the graft. So we have definitely to ensure that it's not active. We should not have an active inflammation. Sometimes we have seen in routine hair transplant patients of androgenetic alopecia where they start with the inflammatory process. So we should ensure that. And the other thing is we should do a test area in some parts just to make sure that whether the graft is taken up, otherwise it would be a waste, and we should counsel the patients regarding that as well. And most important is the role of this fractional CO2 laser prior to the once there is no activity in that area of the scatula alopecia. We should do a few sessions of the laser first while the skin becomes a bit thickened. There is neocollagenesis, there is increased blood supply, and then after the take of the graft is very helpful, and we should supplement it with PRP and other adjuvant things.
Dr. Aman, would you like to add the success
Yeah,
of?
so surprisingly, we have seen very good results in cicatricial alopecia. There are a few points when you're doing a hair transplant in cicatricial. Obviously, the disease has to be controlled. You have to take serial biopsies, and over time, you have to prove that okay, there's no activity. Number two thing is that minimal use of adrenaline when you're doing a hair transplant in cicatricial patients, and a test patch is always very nice idea. I haven't done fractional CO2 before to improve the skin quality. Most of the patients, we just do a test patch, do around 100 to 100 grafts, and then call the patient back to see after 3-4 months. If the take-up is good, you can as well go ahead and do it. The only problem is in pseudopelade and other conditions where even the donor seems to be, eaten up, and you don't virtually have any area from where to take the hair. Another poor responder is FFA. Sometimes you confuse female pattern hair loss with frontal fibrosing alopecia. So that could be a very tricky situation, and you might not get very good result if you don't diagnose FFA. I mean, it looks almost like female pattern hair loss. Yeah.
Right. Dr. Atota, you'd like to add some points?
Questions are there in the chat box.
All right. Dr. Savita?
No, that's it about cicatricial.
Thank you so much. I will chat box again to see few questions which we have. Any comments on argan oil?
Yeah. It's a very good moisturizer. You can use argan oil as a hair serum. Most of the hair serums have argan oil, commonly called as Moroccan oil. It's good for dry, frizzy hair. So if somebody asking you for frizziness, you can prescribe argan oil.
And what conditioner or hair serums do you prescribe in patients? The hair serums is the the shaft. Yeah. What conditioner hair serums do you prescribe patients?
So we don't have any medicated conditioners. We all have cosmetic conditioners.
We have few.
I mean, I'm not very happy with those. My kind of hair, I've used those conditioners on my scalp. I find the cosmetic conditioners to be much better. But then, yes, if a patient asks you about hair conditioners, you have to first educate about how to apply a conditioner than a shampoo. It's different. You don't have to apply a conditioner on the scalp. You have to apply on the long hair and then wash it off. Yeah.
Thank you so much. Yeah. With this, I think we have overshot the time, and you all have been wonderful take-home points and very nice discussion we had in the panel discussion. Again, I thank DRL and I thank you all for being part of this Hair Trichology CME. Thank you so much. DRL can take over.
Yeah, thank you, ma'am.
Thank you,
So
Dr.
I would like to thank the course coordinator and the session moderator and all the speaker and panelists for this wonderful session. And thanks to all the audience also for putting on the questions and making this a more interactive panel discussion and interactive session. I request the audience to join back at 3 p.m. for the second session of this meeting. Thank you very much.
Thank you.
See you again.
Thank you.
Thank you.
Thank you, Dr. Sonali. You were great at moderating.
Thank you.
Great moderation. Thank
So
you
many
very
learning
much.
points from all of you.
Yeah. Thank you.
Thank you.
Thank you.
Bye.
Hello, Dr. Rachita.
Hi.
Pleasure to see you.
I can't see your one second. The video. Yes, hi Latika.
Hi, ma'am. How are you?
Good.
So I was just wondering, your name and Rachita's name is so much similar.
Yes.
Calling out. So maybe I will call you Dr. Dhurat. Or it might be confusing to whom I'm pointing.
Yes.
Hello, ma'am.
Your name is been mentioned wrongly.
Hi, Sonali.
Hi, ma'am.
Admin, just correct her name.
She has to do from her settings, I think.
Okay.
What is it being displayed?
Radhya Bhatt.
Oh, she's my daughter.
Oh.
So I've entered through her Zoom, it seems. Thank you, ma'am. Thank you. Looking forward, eagerly looking forward for the FPHL session.
Yeah, I hope it will be I'm sure it will be an enlightening session. We have such great, trichologists with us. So looking forward to it.
Yeah, technical team, can we start?
Yes, sir.
Dr. Monil, ready?
Yes, good. A very good afternoon, everyone. I am Dr. Monil Gala from the medical team of Dr. Reddy's. And on behalf of the entire Dr. Reddy's team and the Indian Women's Dermatologic Association, I welcome each and every one of you to the second CME that we have planned for today for the special International Women's Day Trichology CME series. So with this, I would like to introduce the IWDA based International Women's Day Trichology CME, the moderator for today, Dr. Latika Arya ma'am. Ma'am is currently consultant dermatologist, cosmetologist at Dr. Latika Arya Skin and Aesthetic Clinic. Ma'am is also the founder, member, and the secretary of the Indian Women's Dermatologic Association. She's also a speaker and conducted workshops at various national and international conferences. Ma'am is also an Allegan faculty and has 6 publications and book chapters in books titled Cosmeceuticals, Pigmentary Disorders, Melasma Monograph, Moisturizers, Cosmetic Injectables. And area of interest include aesthetic dermatology, lasers, pigmentary disorders, dermatoendocrinology, and integrative dermatology. We are privileged to have you, ma'am, Dr. Latika, ma'am, with as a session moderator for the second part of the CME. And with this, I hand over the welcome dais to you and welcome you.
Thank you, Dr. Monil Gala, for the kind introduction. So I welcome you all to the post-lunch session of the Women's Day Trichological Summit. And thank you, Dr. Reddy, for taking care of all the deliverables. And you have been really helpful in getting this program organized. So we will be having 4 talks and then followed by a panel discussion. So the first talk is by Dr. Rachita Dhurat. She needs no introduction. She
Next slide.
is a professor and head Department of Dermatology, LTM Medical College and LTMG Hospital, Sion, Mumbai. Next slide. She has over 30 years experience in dermatology as a teacher. She has won the Cystopic Oration at International Congress of Dermatology in 2013 for microneedling for hair stimulation. She got the Dr. Marcus Oration at Cuticon, November 2018. She has done pioneering work in microneedling, PRP, and dutasteroid for hair stimulation. She is the fellow of Philippine Academy of Dermatology and Cosmetic Beauty, and she is the scientific advisor to Folic Bio USA. And she has been an invited faculty at various international conferences And she's the organizing chairperson for National Conference on Trichology since starting from 2015. She has over 100 articles and written chapters for 6 textbooks. And we are really fortunate to have her starting the program today on female pattern hair loss. So from the maestro herself. So over to you, Dr. Rachita Dhurat, eagerly waiting for your talk. Thank you.
Thank you, Latika, for nice introduction. Good afternoon, all attendees, and I am very much thankful to Indian Women's Dermatologic Association for having invited me to talk on clinical aspect of female pattern hair loss. Let me share my PPT. Yes. Yeah. So I'll be just covering on history and clinical examination. We know that since we are celebrating Women's Day week, women are strong. However, they are most vulnerable for mental stress when they notice hair fall. I must admit that. So when you take history, you have to listen empathetically to the patient concern, because it's a considerable psychological distress is seen especially in women with hair loss. And for that, you have to give more time during your consultation. Now, let's understand what could be the complaint of a female having hair loss. Either it could be progressive thinning of hair or excessive shedding of hair, or usually report a decrease in hair coverage to the level that they can't hide their scalp, what you see in these images like this. Or there could be a significant change in the size of their ponytails. Or they can complain of slow rate of hair growth. Sometimes they say that my length was up to lower back and now it is only up to shoulder. That shows that their hair growth is reduced. Or sometimes they complain of draining of hair in the sink. And many times shading in female pattern hair loss is an episodic shading. So if they complain of the shading now, probably there may not be shading after a few months. So just remember, it is not telogen effluvium, and episodic shading is common in female pattern hair loss. Now, let's understand what are the significance of these complaints. If progressive thinning, that means it is miniaturization. Excessive shading means there are more number of follicles in telogen phase, and hence there is a telogen shading. Don't think that telogen effluvium. Telogen shading is very common in female pattern hair loss. Slow rate of hair growth means shortening of anagen phase. And of course, I told earlier that episodic shading is very common in female pattern hair loss. These are, in short, the common complaints of a female patient with female pattern hair loss or any hair loss. So let's move from C to H, that is history. And here, a doctor's skill is important in history taking. So let's talk about some history, which will give you some idea about the hair loss and its comorbid conditions and differentials also. So we ask for duration, age of onset, progression of the hair loss. Now, duration tells us whether it is acute or chronic. Like more than 6 months, certainly it is chronic. Now, age of onset. Now, female pattern hair loss or childhood AGA have been reported. Many times can associated with an endocrine abnormality. And important is that since if the disease has started in early age, the counseling about the disease and long duration of treatment are paramount important. And the significance of progression, if you know that this disease has progressed over 2 years very fast, think of some comorbid condition or conditions, or you can think of the diagnosis may not be a PHL, something else. Next in history is, of course, family history, because it has been noted that 40 to 50% of female patients have positive family history, which is more for an early onset of female pattern hair loss. Coming to organ history, you ask for precipitating factors like illness, drugs, stress, smoking, sleep, and diet. And history continues with history of malabsorption, malnutrition, excessive vitamin supplementation, which are the other drugs, menstrual cycle. Just remember that if the patient of PCOD need not have irregular menstrual cycle, PCOD patients can have regular cycle too. Marital status, pregnancy, lactation, menopause history, hair care and cosmetics are important in modern era, and psychological history also is important. So we'll talk about little bit about the malabsorption. Celiac sprue or celiac disease, chronic intestinal inflammation, inflammatory bowel diseases are also common. Amongst that, celiac disease is common in Indian population. So therefore, you need to ask some history related to these conditions like diarrhea, false smelling stool, indigestion, abdominal cramps, weight loss, or fatigue. Next is excessive vitamin supplement. This picture is from my own patient. That patient was not female, but he was taking so many supplements because his gym trainer told him. So, and if you look at this Amway, nutraceutical, they are so popular amongst our patients. They keep on popping all multivitamins. So you need to ask them history about this, because excessive vitamin supplementation can cause hair loss. Now, hair care cosmetics. There are various physical and chemical factors, chemical relaxer, permanent waves, bleaching. They are so commonly done in metropolitan cities and second-tier cities. That can damage hair shaft. And you know that central centrifugal scarring alopecia has been linked to the overuse of chemical relaxers. Now, if you talk about history about lactation and menopause, everyone thinks of postmenopausal hair loss is telogen effluvium. You need to think beyond the box, because postmenopausal telogen effluvium can trigger female pattern hair loss. And after menopause, female pattern hair loss, the hair loss can worsen after post-menopause also. So these are the history you need to ask about that. Then consumption of other medications for other diseases. Either it could be NSAID or proton pump inhibitors. I have seen in my practice, most of the people are on proton pump inhibitors because of gastritis, acidity, and so many complaints. That can lead to a chlorhydria and could be the cause for iron deficiency. Also, these drugs cause telogen effluvium. So a patient of classical case of female pattern hair loss and not responding to your treatment of which you have given very good treatment, but not responding, I realized that these patients, they don't give the history of they are taking proton pump inhibitors, which could be cause for chronic telogen hair loss. Second is longer and menstrual history, which is longer, heavier, can result in iron deficiency anemia. Apart from these history, then local history of what changes in hair texture. There could be frizzier, curlier, which is not uncommon even in female pattern hair loss. And history of itching, pain, burning, because scalp trichodynia, a scalp paresthesia, is common in scarring alopecia, seborrheic dermatitis, scalp psoriasis, and rarely in female pattern hair loss. I don't know whether you have noticed, many times a female say that when I comb hair, I get pain. So that is trichodynia. So these are the history I thought of and I shared with you. So from history, from H, we'll move to E. That is examination. Now, examination should be done in 360 degree, including back, front, top, sides. Look for quality of hair, caliber, fragility, length, and always look for on the occipital area too. When you see this visible scar, that indicates that hair density is been decreased by at least by 50%. Next step is look for pattern and the distribution of hair loss, because certain alopecic patterns are commonly associated with certain diseases. However, it is not always true. We know that this is not female pattern hair loss. It is a band-like hair loss, which is a frontal fibrozine alopecia. However, sometimes some disease can present in a pattern distribution, like frontal fibrozine alopecia has been described as a pattern distribution also. So the important is to recognize the pattern distribution of hair loss in female pattern hair loss. So there could be typical pattern, atypical pattern, and Dupont pattern. And I'm going to show all the patterns which I have seen over 30 years. So first is your diffuse central thinning with preservation of frontal margin. And we know that there is always preservation of frontal margin in women. There could be frontal accentuation like Christmas tree pattern, and there are 3 types of Christmas tree pattern, type 1, type 2, and type 3. There could be diffuse thinning on the entire mid-skull, often noticeable on occipital area also. Or there could be only diffuse thinning on the parietal region. Or it could be male pattern type. Or there could be no thinning, no recession frontal margin, only you see fine shorter hair, which is the most commonest, which is the early stage of female pattern hair loss. This is you must have seen in your OPD, which is diffuse thinning. When you make mid part, you can see the mid part widening, which is the clue to diagnose female pattern hair loss. This is grade 4. This is also typical pattern, grade 4 female pattern hair loss. If you the grading system is according to Sinclair grading. This is grade 5 or Sinclair grade. And this is what I told you, that this is a Christmas pattern. This is also a Christmas pattern. Now let's move on to atypical patterns. Now this patient had mid-skull thinning, but also had occipital thinning too. Again, atypical pattern, mid-skull widening, but more widening you can see in the parietal area. This is the typical pattern. Again, the parietal thinning is more prominent. Another patient, mid-skull thinning, but it is a vertex thinning as well as an occipital thinning in this area. And this patient had only vertex thinning. Nowhere thinning was seen. And this patient had male pattern type of hair loss. Now coming to this type of the hair loss, where you see thinning all over the skull, on the occipital area, everywhere, it is like a Dupont pattern, or it is Dupont pattern. Not like, it is Dupont pattern, diffuse unpatterned alopecia. Another patient with mid-skull thinning, thinning on the vertex, parietal, occipital, all over the skull, it is also Dupont pattern. Now, once you have recognized all the patterns, you should know what are the mimickers of FPHL. Your Telogen Effluvium, diffuse alopecia areata, diffuse tinea capitis. Yes, tinea capitis is seen in adults. We have reported cases of tinea capitis. Trichotillomania and cicatricial alopecia too can confuse as a female pattern hair loss. So I'm going to share with a few mimickers. This patient had mid-scalp widening. You can see that thinning here on mid-scalp. And look at her back. You can see alopecia areata patches. So that was a case, was alopecia areata. This another case had mid-scalp part widening, similar to female pattern hair loss grade 2, but trichoscopy showed V sign, coiled hair, and there was a history of pulling. So that was and the biopsy has proven as biopsy showed trichomalacia. So diagnosis was TTM was established in this patient. Now, having said about some mimickers of female pattern hair loss, what you do next is your bedside test. I'm not going to talk about blood, biochemical investigation, because someone will be talking on that part. Bedside, we do pull test. Now, what this has been shown, it is absolutely incorrect method of pulling hair. You can't pull so many hair. She must have more than 400, 500 hair were plucked. So you should know how to interpret, how to hold, how many hair you have to hold, and how much pull you have to give when you do pull test. Now, if you see pull test positive from occipital area, you should know what is its significance. Now, I'll show you how much this much hair must be is 50 to 60 hair. You can't hold more than that hair. Let's see. So this pull test was strongly positive. So let's understand interpretation. Positive pull test seen in telogen effluvium, androgen alopecia, scarring alopecia, loose anagen syndrome. However, negative results can't exclude any condition. So if positive, that means the patient has active shading. That means patient has more number of follicles are in telogen phase. That's why the pull test is positive. The second is a card test. It helps to determine length and caliber of hair shaft. Thin hair at the frontal margin points towards miniaturization process. It is helpful in detecting regrowth of hair also. Of course, without trichoscopy, your examination cannot be complete in any of the hair conditions. You can have various types of trichoscope, but you should know what is the correct method of looking at under a trichoscope. But this is a V sign, which I have designed, that you make a parting, secure the hair, the side, both the sides of this parting, and then you put your dermoscope here and examine. So how do you diagnose female pattern hair loss in early stages? On trichoscopy, if hair diameter diversity is more than 10%, or if you see more than 6 villus hair in your given field, these are the criteria. These are the trichoscopic criteria to diagnose female pattern hair loss. Generally, absent of hair diameter diversity rules out female pattern hair loss, and you need to consider it could be chronic telogen effluvium, which could be primary, that is idiopathic, or secondary, and you need to find out secondary causes for CTE. Now let me show you hair diameter diversity. If you have seen this image, and if you consider this is more than 10%, it is actually is more than 40%. So you should have visual image in your mind that how much more than 10% or 20% or 30% looks. Because if you keep this image in your mind, you are going to miss so many cases which are having hair diameter diversity between 10 and less than 40%. Now, if you see this image, what it strikes, can you see this? These are peripilar. This is peripilar sign. So that is characteristically seen in female pattern hair loss. If you see this image, I don't know whether you can able to notice these are some areas of bald patches. These are not alopecia areata patches. They are eraser-like area, which is characteristically seen in female pattern hair loss. So what lesson learned so far on clinical and examination? The diagnosis of female pattern hair loss is not always easy, especially in early stages. One should know what are the mimickers of female pattern hair loss. In fact, I have seen so many cases where they were misdiagnosed as telogen effluvium while they were cases of female pattern hair loss. Also, diffuse alopecia areata is the closest mimicker of female pattern hair loss and poses a diagnostic challenge. And with this, I thank you once again for patient listening. And I welcome you for practice management and trichology. If those who are interested in learning more on trichology, please do write to us. Thank you.
Thank you, Dr. Rachita. That was a wonderful presentation, very lucid and very elaborately. You have covered the topic and in very simple terms. So I'm sure it has been very useful for all the audience. So thank you very much.
Yes, bye.
So now we move on to the next speaker, Dr. Richa Ojha Sharma. She's a dear friend and very popular consultant dermatologist in Delhi at Twacha Skin Clinic. May I have her resume, please? Yeah. So she is been given a lot of honors, awards, and achievements. She's a reviewer with the IJDVL and JOCD. She's a member of SIG Aesthetics and treasurer of the IWDA and EC member of Pigmentary Disorder Society. She's a member and convener in various committees in IADVL, and she has delivered a number of presentations and has a number of publications. Her areas of interest are hair disorders and aesthetic dermatology. So it's a pleasure to have you today, Richa. So you are invited for the next talk, and her topic is management of FPHL.
Thank you very much, Dr. Latika ma'am, and thank you, Dr. Rachita, for such an illuminating talk. And I have a really tall task to match up. No way I can, but I'll try my best by discussing management of female pattern hair loss. I'll just reduce this. Yeah. I hope my screen is visible to everybody.
Yes, it's visible.
Now, management of FPHL is very difficult to cover in just 20 minutes. And actually, it's a good thing that it is difficult, because that means we have so many treatment options for our patients. But before we even begin, we should know what is it that we are setting out to treat, because the etiopathogenesis of female pattern hair loss is not that easy. The role of androgens is not very clearly defined as it is in male pattern hair loss. In fact, only 1/3 of women with FAGA show abnormal androgen levels. It's also not clear if it is definitely involving androgen receptors or not, because FAGA or female pattern hair loss has also been described in patients that lack androgen receptors. Similarly, we are not very clear about definitive family inheritance. It has not been identified so far. We do know that estrogen has a protective role, as is evidenced by the fact that there's an increased prevalence of female patterned hair loss in women following menopause, and also that there is prolongation of anagen during pregnancy. So yes, estrogen should be targeted for sure. And of late now, there is even more evidence coming in of the importance of inflammation in female pattern hair loss. We can see that there is an increase in lymphocytic infiltrate in the periinfundibular region on histopathology of female pattern hair loss. And so we know that chronic inflammation in the scalp may promote hair loss. When we talk of management, we should begin with investigations. I'll rush through it. The bedside investigations have been covered very well in the previous talk. I will touch upon a few tests that are not always conducted, but may be conducted. If, for instance, you see signs of hyperandrogenism in a woman, and you're looking at probably ovarian hyperandrogenism, how do you go about trying to prove it? You look for the free androgen index, which means total testosterone into 100 divided by sex hormone binding globulin. If it is more than 5, it denotes PCOS. Also get your prolactin levels investigated. Dehydroepiandrosterone sulfate or DHEAS and 17-hydroxyprogesterone being elevated point towards androgen-producing tumors and adrenal congenital hyperplasia. Often we see that there's a complicating element of chronic telogen effluvium, and to rule that out, you need to get your complete blood count done, your iron studies, thyroid profile, and some basic investigations like vitamin D and B12 levels. Zinc may be added sometimes to this list. Now remember that the testing of androgen levels should be done during the follicular phase of the cycle, that is between the 4th and 7th day of the cycle. And OCs, if the patient is on OCs, must be discontinued for at least 2 months prior to this kind of testing. Scalp biopsy is not usually warranted, but cicatricial alopecia and patent distribution has also been described, and sometimes it may be essential to even distinguish between FPHL and diffuse alopecia areata, and that is when you should opt to go for a scalp biopsy. It should be definitely dermoscopy guided with a 4 mm punch, and you'll find that the ratio of terminal to vellus-like hair follicles is less than 3:1 in female patent hair loss, as against the normal of more than 7:1. Now, the goals of therapy, because it is a naturally progressive disease, therapy can have 2 required outcomes. One is to stop the hair loss, and definitely the other is to induce hair regrowth. Counseling before we begin any of this is very important, because you're looking at a long-term disease, and therefore the patient needs lifelong treatment. And so the patient counseling as well as the family counseling, especially of spouses, is very important. The current treatment options are several. Because it is a multifactorial disorder, there are multifactorial, there are agents that can cover all the factors. And if you were to look at this list carefully, you'll find that our star, our hero, or the heroine, or the main star is minoxidil. So let's begin with minoxidil. Now, it remains the first line of treatment for FAGA. It has been approved by the US FDA. It is a potassium channel blocker, but then it has got so many other actions like vasodilation, proliferative action, anti-androgen, anti-inflammatory, and so it prolongs the anagen, and it causes enlargement in the miniaturized follicles, and it helps in the conversion to terminal hair follicles. Topical minoxidil is available in 2 and 5% solutions and as a 5% foam. Twice daily minoxidil solution 2% in concentration of 2% is almost in similar efficacy to once daily 5% solution or foam. The directions when you're talking about minoxidil to the patient is very important. It should be applied with a pipette directly on the dry scalp. I always prefer it to the spray. Do not massage it. Apply it at least 2 hours before bed so that it dries up well, does not spread on the face and cause hypertrichosis. There will be a transitory increase in telogen hair shedding during the first few months of treatment. The patient should be told about that. Assess after 6 to 12 months of treatment, and if successful, it should be continued indefinitely. The withdrawal, if it is done, will lead to a telogen effluvium. The side effect, of course, is hypertrichosis, especially if it has not been applied properly, and there can be irritant or allergic contact dermatitis, which is very often related to the solution vehicle and can be obviated by the use of foam. Oral minoxidil is again the talk of the town, and it should be considered if the hair loss does not respond to topical minoxidil or if the patient is unable to tolerate it. Now, it is used at much lower doses than that used to treat high blood pressure. It can cause a significant reduction in blood pressure if it is given with other antihypertensive treatments. So please take a proper medical history before beginning this. Other side effects are fluid retention and hypertrichosis, and sublingual minoxidil is also available. I found this RCT with 52 participants as a letter by Dr. Ramos and Sinclair. And what I found very interesting in this study was 52 participants had been subjected to low dose oral minoxidil versus 5% topical minoxidil. And they mentioned that hypertrichosis was seen in 27% of patients on oral minoxidil as compared to 4% on topical minoxidil. Now, they call it mild and well tolerated, but I'm not sure my patients are going to like it very much if more than 1/4 of them are going to suffer from hypertrichosis. So it's a call that we all have to take eventually. Other topical treatments. Topical finasteride these days definitely a favorite amongst all of us, and not for any there's a good reason behind it, because we know it's a 5-alpha reductase inhibitor type 2, and recent studies have shown that the efficacy of topical finasteride for AGA is substantial. For example, the study 1 compared 3% minoxidil versus 3% plus 0.1% finasteride. Let's call it MNX versus MFX. And it was found that MFX showed statistically significant higher efficacy than MNX alone. It was a study in 40 men. Similarly, there's another study this study is in female patent hair loss with 30 postmenopausal women given chosen for it. And again, the combination was found to be superior. Study 3 mentions that it is an excellent choice for hair density maintenance after initial improvement with oral finasteride in male patients. This was demonstrated in male patients. Now, coming to prostaglandin analogs, latanoprost and bimatoprost, they are anti-glaucoma drugs, and we know that they cause the eyelash growth by stimulating the anagen phase. Topical latanoprost in a concentration of 0.1% has been shown to give good effect in 16 male patients, but bimatoprost as an injection was not shown to give any improvement in FAGA. So the jury is still out, but yes, it's going to come in any soon. Ketoconazole is a very simple to use good drug with good anti-inflammatory property and androgen receptor antagonists, and ketoconazole shampoos can be used to have can be used for a very long time in female pattern hair loss, especially with those with hyperandrogenism. Melatonin is another agent that is being talked about. The pilosebaceous unit is best recognized as a neuroendocrine organ because of the number of mediators in that area. And so melatonin modulates this hair growth by meddling with the neuroendocrine system. Now, the topical application of melatonin 0.1% solution was shown to significantly increase anagen hair growth in both male and female patterned hair loss with a good compliance. Coming to one very important aspect of the treatment, which is the hormone modulating treatments. Now, these can be either androgen receptor antagonists, that is those that prevent testosterone and DHT from binding to their receptor, or they can be real anti-androgens, that means those that alter the androgen levels at the hair follicle. They are certainly contraindicated in pregnant women because of the risk of feminization of male fetus, and strict contraception should be used during and for at least 30 days after discontinuation of these drugs. The first one of which is finasteride. It is quite clear that finasteride has got benefit, but not certainly in the doses that we use in males. Higher doses of 2.5 to 5 mg are necessary to treat FPHL effectively. Besides the teratogenic effect, it has been shown that finasteride, it has been associated with estrogen-mediated malignancies because it can generate estrogen excess. So again here, family history of breast cancer is important, and it should not be prescribed in patients who have this sort of a history. Dutasteride, it inhibits both type 1 and type 2 5-alpha reductase, and it has got more efficacy than finasteride in male patients. But one thing that we need to know when we are trying to treat women with dutasteride is that it is well tolerated, but it has a longer half-life, and therefore women of childbearing potential should have effective contraception for at least 6 months post discontinuation of this drug. Spironolactone has a direct antagonist of aldosterone or androgen receptors. It's got a number of anti-androgen effects, and it can be used as an alternative to finasteride in those patients that have concomitant hirsutism and acne. And you start with 50 mg per day for a month, and then you hike it up to 100 to 200 mg per day. Can be used for 6 to 9 months. But some of the side effects like headaches and libido reduction, menstrual irregularities can be quite bothersome. It has been shown that hyperkalemia is not such a big problem with spironolactone. Cyproterone acetate, again, it is approved in Europe and Canada for hirsutism, acne, and female alopecia. It's given in a dose of 100 mg per day on day 5 to 15 alongside ethinyl estradiol, and postmenopausal women can receive 50 mg on a daily basis. Flutamide is again a very good drug, but it does have a problem of hepatotoxicity. It has got better efficacy than both finasteride and spironolactone. But if you can rule out any underlying hepatic abnormality, or if you are able to monitor serum transaminase at baseline and then monthly for the first 4 months and periodically thereafter, then you may consider flutamide in a dose starting from 125 mg, and then you can probably go to 250. I like to stick to 125 mg a day. Now coming to the very, very important aspect of procedural management of female pattern hair loss, and PRP, everybody is doing it, and for good reason. Again, PRP is a platelet concentrate that is extracted from the patient's peripheral blood, and therefore there is a release of, after activation of the platelets, there is release of growth factors of all sorts. A recent meta-analysis studied the result of 7 RCTs, and it showed that it has got a fantastic improvement in female patterned hair loss specifically, but there is no consensus regarding how to prepare it, what is the exact concentration, what is the utility of activators, what are the dosing parameters. So there's no real consensus. I can tell you what I do: extracting 9 to 10 cc from the antecubital vein. Then I use a premix, a gel containing tube that is used as a separator. Then centrifuge at 1000 RPM for 10 minutes. Discard the RBCs in the upper 1 ml of the platelet poor plasma. Take the platelet-rich plasma. I do not activate it and inject it using the Napaj technique, and I repeat it after every 4 weeks. Microneedling is good because it is basically creating space for your, other substances to penetrate. It's basically making, microneedling alone. I'm talking about microneedling alone. Again, we've got a lot of evidence in and against, for and against the use of microneedling in literature. The only thing that you should remember is that it has got a few side effects, but then the consensus is not about its excellent use. It's just a concomitant therapy. Mesotherapy is something that is going to help intradermal infusion of a blend of components, and a number of things can be used: minoxidil, finasteride, dutasteride, growth factors, biotin, steroids even, and panthenol. Some studies show good results with mesotherapy for treatment of both men and women, female patterned hair loss. But the drawback again is lack of standardization. But more important than that is the fact that side effects can be very, very bothersome. Non-tuberculous mycobacterial infection has been described. Multifocal scalp abscesses with subcutaneous fat necrosis and scarring alopecia has also been reported following mesotherapy. And recently there was a report of frontal edema following 5% minoxidil solution applied after mesotherapy. Carboxytherapy is insufflation of medical grade carbon dioxide, and there has been a study that reports 40 patients having improvement after carboxytherapy, but obviously more studies are needed. The new thing would be novel approaches for delivery of topical medication. This is very important because there will be many such modalities coming in. For example, professional tattoo machines are being considered. Ablative and non-ablative laser devices will help in penetration of your growth factors, etc. Radio frequency, low frequency ultrasound and iontophoresis also help achieve the penetration of growth factors and other actives. Light therapy is FDA approved, and it was shown that when performed at home using a laser comb, wearing of helmet, the effect of laser light therapy for between 16 and 26 weeks using different protocols did show an increase in the hair count. Based on the review, it appears to be effective and it's got excellent safety profile. The only caution is that while these studies have had a relationship with industry, so you need to be cautious about this. Scalp micropigmentation is basically medical tattooing so that there is a reduction in the contrast between the scalp and the hair by simply concealing it. And it can be used as an adjunct to hair transplant and can be used to treating scalp scars also. But the drawback is pigment bleeding and graying of the surrounding hair and sometimes also infection. Lastly, I'll come to the hair transplant. Although we had a fantastic talk by Dr. Savita in the morning, and there was a very, very good lecture on it. So basically the techniques used are FUE and FUT. The only challenge of using hair transplant in women is basically insufficient hair donor area. That is important. The need for magnification in order to insert the grafts between the existing hair follicles in the recipient area. And there is temporary worsening of the global aspect after the transplant. And therefore, correct selection of ideal candidates is very, very important. To summarize, it's a combination of careful exclusion of hyperandrogenic state so that you know what to treat and how, appropriate topical medication, systemic therapies, and prudent use of procedures that is needed to give your patient the maximum benefit. Thank you for your patient hearing.
Thank you, Dr. Richa. That was a wonderful lecture. Indeed, you have covered all the existing therapies, the classical and the adjuvants, and not only that, you have also covered the futuristic therapies. So all in all, a comprehensive lecture. Thank you so much.
Thank you, ma'am.
Okay, and the next speaker is Dr. Rajita Dameshetty. She will be speaking on role of nutritional supplements in FPHL. So we have all heard Rajita several times speaking on her favorite topic, hair. And she is an additional medical director, Oliva chain of 23 hair and skin clinics in Hyderabad, Bangalore, Chennai, Kochi, Kolkata, Pune, and Vizag. She is the chairperson at IWDA Task Force Against Topical Steroid Abuse, ITATSA. She is the former chairperson of Telangana IWDA Task Force Against Quackery and the former national convener and Allergan Medical Institute faculty. She prepares protocols and handles training of 85 dermatologists and paramedical staff for Oliva Chain's 23 clinics. She is the alumnus of JIPMER MMC Chennai, and she has special interest in pigmentary and hair disorders, anti-aging treatments, optimizing use of lasers on colored skin, and the interplay of endocrine milieu and skin. She has delivered over 200 invited lectures in various national and international conferences. So I welcome you, Rajita, and eagerly waiting to listen to you.
Thank you, Dr. Latika. And thank you, Dr. Reddy Labs and IWDA. It's an honor and a pleasure to be on this platform of very erudite speakers, and that too on this very special occasion of the Women's Day week. So over the next 18 to 20 minutes, I'm going to cover my perspective of minoxidil. And I'm sure there'll be a few things that would be interesting for many of you. I was hugely fascinated when I was preparing for this talk, because there's so much happening in this age-old drug. And before that, one disclaimer: the CV projected was last year's. I'm no longer the chairperson of ITATSA. I am now the convener of the ethics committee. So no offense to the current chairperson and convener. So I'm going to begin with a glimpse of history and give you a glimpse of the evidence of usage of minoxidil in female pattern hair loss. I'll talk about why some people don't seem to respond to topical minoxidil, enumerate the various challenges we face in our day-to-day practice in getting our female patients to use minoxidil properly, and how we could possibly overcome the challenges in topical minoxidil usage, and talk about how we could optimize the outcomes of topical minoxidil in female pattern hair loss. And finally, I will end with some information and some thoughts on oral minoxidil in the context of FPHL. So this is a drug that was introduced more than 30 years ago. And this happens to be the only approved treatment. Approval given by the US FDA is what I'm referring to. And 2% minoxidil solution is the only FDA approved treatment for female pattern hair loss. 5% solution was launched the year I joined MBBS, which is ages ago. And the 5% foam was later on introduced. In India, we are fortunate to have 7.5%, 10%, and even 12.5%. And I have on occasion used 10% also in women. And though I don't really do that any longer, I have something better, which is the oral minoxidil option. And we also have minoxidil preparations available in India in combination with 0.1% finasteride, which is unfortunate. And I hope Dr. Reddy's team is taking notes, because 0.25% finasteride is what we are looking for, particularly when we use it in men who are not keen on taking it orally. We have combinations with various peptides, the Procapil, the Capixil, and I'm sure Ridensil is going to be added to topical minoxidil very soon. We also have a melatonin containing variant, and this is something that we've been using for ages. And this is a recent paper, and I happen to be one of the co-authors, and this is a position paper of a few Indian hair experts on the usage of topical minoxidil in female pattern hair loss. So that would be a good brushing up for most of you. So we understand that basically this is an arterial vasodilator, and we know that minoxidil prolongs the anagen phase. It increases hair follicle size, and it increases the hair follicle volume, so that there is an appearance of increased hair density. But whether it can actually convert the completely miniaturized follicles, vellus hair follicles, into terminal hairs is a bit doubtful. There is some evidence actually that this also can happen. So do not discount the effect of just plain topical minoxidil if you are not able to do anything else in female pattern hair loss. Now, these are host of indications where you could use topical minoxidil in various hair disorders. And this gives you a glimpse of the various studies that were done using topical minoxidil in female pattern hair loss. So you will find that pruritus, headache, and hypertrichosis are not unusual, but most of the time they are not important enough for the patient to stop the usage. Between the two strengths that are commonly used in women, my vote is very, very clear. I do not use the 2% minoxidil. I have not used it ever since I finished my MD, which was in 2003. And it is clear from various studies that 5% minoxidil is superior in efficacy, and it is also extremely safe. So it's been found ages ago that 5% minoxidil foam used once daily has efficacy equivalent to 2% minoxidil used twice daily. And if we have to, if I have to give you an approximate efficacy of the topicals, they say that only 1 in 5 women actually respond to 2% minoxidil. And if you hike up the strength to 5%, the response rate actually doubles, and you can actually go to 40% of response in women, which is again not so great, and which is why we need to look beyond minoxidil alone when we treat women. So these are a few studies where oral anti-androgens were combined with topical minoxidil. Now, I personally use spironolactone when there is the hyperandrogenic variant of female pattern hair loss, and for the normoandrogenic female pattern hair loss, I like to use 5 milligrams of finasteride. And big disclaimer being that both these drugs can feminize the male fetus, so I would use them either in people who have attained their menopause, who have had their hysterectomy or a tubectomy, or are on a good oral contraceptive and are taking it reliably, because what we don't want to get into is this whole MTP business with all the medical, legal, and the ethical ramifications. So topical finasteride also has been used in female pattern hair loss and has shown some additional benefit, but unfortunately the formulations that we have in India are not 0.25%, they are all 0.1%. So I'm not sure if we will get a similar kind of result if we use this combination. Now, evidence of a synergistic effect when topical minoxidil was combined with PRP exists, and we have our own Dr. Rachita Durat's paper which has shown that combination with microneedling, this was again not exclusively in female pattern hair loss, if I remember the paper right, and she showed that the outcomes were hugely improved by adding microneedling. Though I'm going to ask her if she still believes in microneedling the way she used to. So now that we've seen the evidences of the efficacy of topical minoxidil and also the safety of topical minoxidil, ignoring a little bit of facial hypertrichosis, we'll come to understanding why some people do not respond to topical minoxidil. One of the most common reasons would be poor adherence to therapy. Now, if you ask your patients how long it takes for them to use up one bottle, 160 ml bottle of minoxidil, you'll be surprised by the various answers that you would get. And of course, many of us who do not yet use the dermoscopes on a regular basis would miss out on the microinflammation. And if you do not treat that, then you are not going to get a great response in to topical minoxidil. And of course, unless you are familiar with what a normal hair diameter diversity is and what occipital involvement and a temporal involvement would look like, and unless you are ready to advise your patient to use 2 ml of minoxidil on the entire scalp when you see a diffuse unpatterned alopecia, then you would not get optimal response to topical minoxidil. So I see a lot of people who give a trichoscopy report where they clearly mention that the HDD is more than 20% in the occiput, but yet if you look at their prescription, they still give the patients 1 ml minoxidil, which would obviously be enough only from the frontal and the vertex area. Then uncorrected androgen excess, of course, and androgen excess could be at the cellular level or could be at the level of the serum, in which case you would diagnose. And there's still too many people who are asking for a free testosterone assay, and I hope none of you are going to do it after listening to Dr. Richa's talk and this discussion. So uncorrected insulin excess is something we don't tend to think of, and you will be surprised to see how many of your female pattern hair loss patients, particularly the ones with occipital involvement, have an ongoing, maybe a subtle, maybe a pronounced acanthosis nigricans. And if you look at their HOMA IR from a good lab, you will find that oral metformin therapy is warranted. So please do keep that in mind. But the most important point I want to stress on today is the lack of conversion of the prodrug minoxidil to its active form, minoxidil sulfate, because a lot of people are actually deficient in the sulfotransferase enzyme. And this was the first time we had heard of this in mainstream literature, this very beautiful paper by Dr. Andy Goren, where they showed that hair follicle stem cell assay of sulfotransferase can predict the response to topical minoxidil. And the initial study was done in males, but then very quickly it was replicated in females, and they found that this assay can give you a 93% sensitivity and a 93% sensitivity and a 83% specificity. Why is this important? This is important because if you want to do the same thing by trial and error, you'll have to put your patient on almost 4 to 6 months of topical therapy, and then you realize that it is not really working. And when it is not working, you are wondering whether it is because of poor adherence or something else, or because the prodrug is not getting converted into the active drug. So if we have access to this kind of an assay, wouldn't it be great? But the problem is it's a niche assay. It is done only by researchers. It's very expensive as of now. So I'm going to give you a glimmer of hope, and there is an option that probably we could all be doing just a few years down the line. So what are the challenges in minoxidil usage? A lot of people don't like minoxidil, the way it smells, the way it feels, and the way it makes your hair feel. And being women with relatively long hair, we are not able to wash daily. I actually advise most of my pale patients to wash daily or at least every other day, and they're happy to. But how many of us, especially women with long hair, can wash even alternate days? And especially if you want to style your hair, it becomes very tedious. Now, minoxidil phobia, a lot of people think that, once you start using it, you get addicted to it. And somehow many of us are not very effective in conveying this message. But this is something like brushing your teeth. If it's working for you, and if you want to hang on to the hair on your scalp and you happen to have a female pattern hair loss, then you better start using minoxidil and do it for as long as you want the hair. So somewhere this phobia is strong, and then a true allergy to minoxidil is quite rare, but an allergy to the vehicle, particularly propylene glycol, which happened to be named the contact allergen of the year 2019, if I remember right, is quite common. So what do I do when I'm suspecting a true allergy? One thing is I try and shift the formulation to one of these newer alcohol-free formulations. And if I'm still wondering if minoxidil is actually the allergen, I do a ROAT, a repeated open application test, somewhere here, 2-3 drops of the solution to be applied every evening, washed off the next morning. And at the end of 5 to 7 days, I look for erythema. And if that is there, I know that this person has true minoxidil allergy, and none of the formulations I can give is going to help them. And this is something I would suspect when they complain of severe itching as soon as or within a few hours of the application. And this is not just the itching because of the greasiness or because of the worsening of the seborrheic dermatitis, which of course under our watch would not happen. Now, may I request Dr. Latika to let me know when I have 2-3 minutes left. So how do we optimize the outcomes of topical minoxidil? One of this the exciting things that I learned is topical application which has sulfotransferase enzyme. And this was applied around 10 minutes prior to minoxidil usage in this study. And they found that the regrowth was seen in almost 75% of those who used this adjuvant versus just 33% who did not use the adjuvant and used the placebo instead. So this is something that is exciting for those people who lack the sulfotransferase in the outer root sheath cells. And this is another hugely exciting thing that I just came across thanks to this opportunity by IWDA. So instead of waiting for this very expensive sulfotransferase enzyme assay to come to our our cities and our patients, this Doppler laser imaging, which was done around 1 hour after application of minoxidil. And if the velocity did not increase 1 hour after topical minoxidil, that means this person probably is deficient in sulfotransferase, and there was a near perfect correlation with the sulfotransferase enzyme activity. So this is something that I am hugely excited about, the fact that I will be able to tell my patients whether or not they're going to respond to topical minoxidil, and I would not be wasting their time and money, and also withering away their hope. Because one of the important things about women with patterned hair loss is the emotional turmoil that many of them go through. So how do we optimize the outcomes? By giving better formulations, and I congratulate DRL for coming out with so many innovative formulations over the past few decades. So propylene,
Adita, you have 2 minutes.
Sure, thank you. I'll finish off. So propylene glycol-free formulations, alcohol-free formulations. Again, there's a bit of a debate there whether the bioavailability is the same, but at least these are cosmetically more acceptable, improving the scalp health, improving adherence. And this was something that was very innovative, something called an after minoxidil spray, which has aluminum starch so that it absorbs all that greasiness. So this is something that we could suggest to our female patients, though this is not available in India as of now. And of course, by aiming for a hormonal and a nutritional balance. And when I say hormonal, I'm talking about both androgens and insulin, and of course, adding PRP. I am strongly against mesotherapy. The very first debate I did was when I called mesotherapy a dirty word, and my opponent was none other than Dr. Rachita Durat, one of the fondest memories I have about Air India 2012, if I remember right. And then, of course, we have out-of-the-box thinking, which includes oral minoxidil and using a sulfotransferase adjuvant. Again, I hope DRL is taking notes, and possibly looking at doing the Doppler so that initially itself, we can decide on when we should start off with oral minoxidil. Now, if you remember, actually, minoxidil was an antihypertensive, and when it was given in therapeutic doses of 20 to 40 milligrams, people had unacceptable hypertrichosis. And then the oral formulation was shelved, and it came back, topical avatar. And now again, we've come a full circle, and we are going back to a low dose oral minoxidil because it is convenient, it is cosmetically elegant, it actually happens to be cheaper. Even the 5 milligram tablet would come to something like 350 rupees for a month supply, and we are not even going to be using a 5 milligram dosage in these women. Even a 1.25 to a 2.5 milligram dose per day would be excellent. A 0.625 mg also actually works well. So if you look at the cost, and of course you can use it as a co-therapy oral minoxidil along with 5 mg of finasteride or 100 to 200 mg of spironolactone would be a wonderful addition. And of course, adherence to therapy would be quite easy. So for these 5 C's reasons, oral minoxidil, I think, is a great choice. And you have multiple papers which have been published. This was actually a meta-analysis of almost 17 studies where it was found that it is effective and also well tolerated and safe. You do want to make sure that this person you're giving this to does not have heart failure, and the doses we use are too less to cause a hypotensive effect, even if they are combined with other antihypertensives. And this was something that Dr. Richa had mentioned, and they found that the oral minoxidil 1 mg was as good as the 5% solution, but was proved superior in terms of reducing the shedding. And of course, the 5 C's, cosmesis, cost saving, and compliance are going to be better. And side effects like hypertrichosis are quite common. And I am personally taking 1.25 milligrams of oral minoxidil for since before lockdown. And where I thought the laser hair reduction sessions were done, the hair has come back, but I'm able to manage quite comfortably because I would rather have this hair. And a lot of my female patients, I have given it to at least 75 female patients of mine, and all of them have yet to say that I do not want this hypertrichosis, so I want to quit. we are all happy with it. And this was a study where both men and women were included, and only 1.7% of patients had actually discontinued treatment due to the adverse effects. And this is a landmark paper by Dr. Rodney Sinclair, where only a 0.25 milligrams of minoxidil along with 25 milligrams of spironolactone led to these kind of stunning results. So to all those people who are yet to start off prescribing oral minoxidil, do not hesitate. So to sum up, 5% minoxidil should be the first line of therapy. I believe 2% should be shelved. Once a day usage is practical. Combination treatment with anti-androgens, with 5-alpha reductase inhibitors, and with metformin and other insulin sensitizers, as the case may be, should be done for everyone with a Sinclair grade of beyond 2. And treatment should be holistic, and we need to talk about diet, exercise, waist circumference, if possible, a visceral fat, a percentage body fat, all these things. And of course, do not hesitate to use oral minoxidil because it's safe, effective, and convenient. And lastly, to all those women who are self-deprecating, who forget their strength, please don't. The cape is there. It's right. You just need to look within and you will find the strength. So I hope we get to know all those strong women out there. Maybe be them. And if you are lucky to have daughters, may you raise them. All the best to IWDA and all the viewers, and to all the men who are viewing as well. Thank you so much.
Thank you, Rajita. And that was a very comprehensive update on minoxidil, both topical and oral. And I can say that definitely you are one of the strong women whom everybody can look up to. Thank you very much. And over to our next speaker. So this is the last but not the least, Dr. Pallavi Ailavadi. So she is going to be talking on the role of nutritional supplements in female pattern hair loss. Dr. Pallavi is an assistant professor at AFSMS and RC Hospital, Faridabad. And she has a clinic by the name of Skinesia Clinic in Faridabad as well. She has 6 publications and 10 chapters to her credit. She has around 14 presentations, and she has been awarded International Observership in Dermatopathology, University of San Francisco, USA. She has an international fellowship in dermatology and cosmetology at Seoul National University. And she is also the IWDA observer in lasers and aesthetic medicine in 2018. She completed the Dermasource, she received the Dermasource Promising Star Award in 2016, and also the IADVL DSP Appreciation Award in 2015. And she also received the EADV Young Fellowship Award in 2015. So Pallavi's areas of interest are pigmentary disorders and pediatric dermatology. So with these words, I would like to call Pallavi to start her talk.
Ma'am, thank you for the introduction. I will now have to present on a topic which was very difficult to prepare, the role of nutritional supplements in FPHL. I hope my screen is being shared.
Yeah, go ahead, it's visible.
Such a difficult topic to prepare. You know, we give these nutritional supplements left, right and center to our patients, and when you actually, go through the scientific data behind that, you wonder what is happening in this world. So coming to nutrition and hair, as we know, the hair follicles are amongst the most metabolically active in the body. They require a balance of macro as well as micronutrients in order to maintain the normal hair structure and growth. Now, these micronutrients, which includes vitamins, trace minerals, are major elements in the hair follicle cycle and are absolutely necessary for the normal cellular turnover. Their deficiency may contribute to hair loss. Yes, when they are deficient, they may contribute to hair loss. Now, the deficiency of these macro and micronutrients is well established in acute telogen effluvium, which may happen due to sudden weight loss or decreased protein or calorie intake. Then diffuse alopecias are related to certain vitamin deficiencies as well as zinc deficiencies. potential associations of these have been seen with other types of hair fall, including chronic telogen effluvium, then male pattern and female pattern hair loss, as well as alopecia areata. Our interest today is in female pattern hair loss. Well, there are multiple micronutrients, which includes vitamins and a lot of trace minerals, amino acids, and multiple other molecules which are associated with hair loss. But surprisingly, when you look specifically at their association with female pattern hair loss, you do not actually find as much data as you would want to warrant their such widespread use. Now, talking about iron, as there are multiple studies which are assessing the ferritin levels, the transferrin saturation levels, as well as even anemia, like simple association of hair loss with anemia. So across all these studies, yes, there is a definite association with chronic telogen effluvium, but very few studies have actually found it to be associated with the female pattern hair loss. See, so with female pattern hair loss, very few studies have actually found data to support the deficiency of iron in FPHL and to subsequently recommend iron supplementation in these patients in the deficiency of anemia. So even if they may be having lower levels of ferritin, but in the absence of anemia, you supplement iron, it may not actually give you the results that you're wanting. So even though we keep a cutoff level of 30 for ferritin to maybe even 40 to start the supplementation, but we don't actually see the results as often if the patient's hemoglobin levels are normal. Now, excessive supplementation may also cause toxicity. Then coming to zinc. With zinc, there is a big study of 312 patients where the association of lower serum zinc levels has been found to be associated with FPHL, but oral supplementation in the absence of deficiency again has not really been found to be effective. On the other hand, excessive supplementation can cause acute side effects, especially gastric side effects, which may not be very acceptable to our patients. Then coming to vitamin D.
Vitamin D, here only one study is mentioned, but there are multiple studies which have found lower levels of vitamin D in patients with chronic telogen effluvium, female pattern hair loss, and the proportion of the severity of hair loss has matched with the deficiency. So patients with excessive hair fall have been found to have significantly lower levels of vitamin D. And in such patients, supplementation has been found to be effective. But again, with vitamin D, we really cannot rely much on studies, even when they are matched with controls. To have significant levels would be difficult in a country like India, where 70 to 80% patients anyway are deficient in vitamin D. So, we actually supplement vitamin D in most of our patients who come to the clinic without even measuring the levels, because when you have a 70 to 80% of the population deficient in the levels, how can you actually correlate that with the hair fall? Even though all of these are case control studies, but still corroborating that data to your clinical efficacy is difficult. Then there are multiple other molecules like vitamin A, vitamin E, and selenium. Again, no known link to hair loss, and supplementation doesn't yield much benefit. On the other hand, overeating, over supplementation results in toxicity. So the only data which is of use to us is the association of iron, zinc, and vitamin D out of all these major elements, I would say. Then I come to vitamin B. Vitamin B3 niacin we know that alopecia is well known in pellagra, so I will leave it to patients with pellagra to be definitely supplemented with niacin. Another group of patients where we see B3 deficiency is alcoholics or patients who are taking isoniazid for ATT. In those patients also, you may need to supplement with niacin if they report with hair fall. Then we come to a very commonly used molecule, which is biotin. See, every patient who comes to us in the clinic with hair fall, I mean, not every, I would say 70% of the patients who come to a clinic have already had biotin supplements on their own, either ordered from the internet or taken on the recommendation of a friend, but most of them have already had biotin. And a lot of the supplements that we as doctors also prescribe do contain biotin. But biotin as a vitamin is quite commonly found if you take a balanced diet. So maintaining a RDA of 30 microgram per day is not difficult if the diet is balanced. So does supplementation really help here? No, it doesn't if you have a balanced diet. And over supplementation, thankfully, is not harmful because it's a water soluble molecule and there are no upper limits to the levels in the blood, so not much in terms of toxicity risk. But even with biotin, unless there is a genetic or an acquired cause of deficiency, supplementation does not really help. And the studies also support this data. With B12, higher chances of deficiency happening in the vegetarians. So if you actually find other features suggestive of vitamin B12 deficiency, yes, you can supplement B12, but not routinely effective if it is not deficient. Then this is a study in the Indian population. So I've actually put the study here because this tells us how our Indian patients with hair fall are presenting to us on the deficiency levels. So you look at this first picture of the first table here, you see that serum folate and B12 levels were deficient in quite a lot of patients of female pattern hair loss, and even half of the patients were deficient in iron also, as measured by their serum ferritin levels and transferrin saturation. So B12 folate, again, majority of Indian people are vegetarian. Then chances of B12 deficiency being on the higher side. Iron deficiency very prevalent in India. So, higher chances of having our Indian patients with any type of hair fall for that matter to be more prevalent in the iron deficiency. Then coming to the amino acids, histidine, isoleucine, lysine, all these essential amino acids were also more deficient in patients with FPHL with significant P values. Okay, so these were all deficiencies which were found in Indian participants. But if I actually show the other data in the chart, you see that the deficiencies are not just in female pattern hair loss. Even though I've circled that, the deficiencies will be seen in patients suffering from MPHL as well as telogen effluvium. So these deficiencies are not particular to any type of hair loss, and they actually give us more data on the underlying nutritional status of our patients, irrespective of the type of hair loss. So patients presenting with hair loss, most of them are having some deficiency or the other, and this could actually be a population problem and not specifically associated with the hair loss. So supplementation, again, will that improve the overall health status of the patient and lead to a overall good hair health, or specifically it will target the pathogenesis and improve the hair fall? This is all a very, very, very open area for debate here. But these deficiencies were specifically found, so we are not dealing with something that is not there. These are there, but how important they are, that is yet to be seen. Now there is this thing that I wanted to focus on, the complex dietary supplements. If we actually look at all the multivitamin concoctions that are marketed by various companies for hair fall patients, there are so many ingredients listed on the back of them. And what are these? These are all some complex dietary supplements that include the green tea extract, the beta carotene, zinc, selenium, chromium borage, like multiple shark cartilage, fish oil, omega fatty acids. So all of these complex supplements, they are marketed very widespread in the doctor clinics. Then even if you just type on Google for dietary supplements in hair loss, there would be so many supplements that are available for the patients to choose from, especially Amway, Modi Care, etc. So even on Amazon, even on simply ordering from your neighborhood chemist or your neighborhood distributors. So the gym supplements that the boys and the girls take. So all of these contain these complex dietary supplements. Now, despite the fact that we don't really like them supplementing on their own in the absence of a doctor supervision, a lot of these studies, the first few ones in the females, so all of these on this page being in the females, actually show that there has been a reduction in hair loss and an increase in the anagen hair count, increase in the total hair compared to a placebo. And these are all longer treatments over 6 months. So despite the fact that we would not want self-supplementation, but a lot of these patients do that because they may also somewhere be seeing this benefit, as can be seen even in the studies conducted by the doctors. So in stage 1 hair loss according to Ludwig scale, which is actually the FPHL, here also a combination of fish oil, blackcurrant seed oil, vitamin E, C, and lycopene has led to a significant increase in anagen hair. So even though the pathophysiology of the hair fall may be different, it may be CTE, it may be FPHL, or just a self-perceived thinning of hair, these have been shown to cause a reduction in hair fall. Again, in this table, in the women, as well as the studies 6th onwards, which are in the men, these studies everywhere, they do seem to show a significant reduction in shedding. In some studies, not as much, but yes, some benefit may be achieved by using them. Now, what actually are the ingredients of these dietary supplements? They are all anti-inflammatory, antioxidant molecules. So all of these anti-inflammatory, antioxidant molecules, they may work on the inflammatory cascades. The role of microinflammation is well known in FPHL also. So maybe it is through these antioxidant and anti-inflammatory actions that they actually bring about the benefit in our patients with FPHL. Now, despite the fact that we have some data to support the treatment, the problem is that there are many of these nutrition supplements which are marketed as hair loss treatments, which the patients self-medicate, but these supplements are not without risk, and over-supplementation may actually prove harmful for the hair. As Dr. Rachita also mentioned in her talk, there were patients who were over-supplemented with their vitamin combinations, were actually presenting with further hair loss, and to a physician, they may go with other side effects also. So this over-supplementation has to be advised against, and a proper awareness is required, which we as doctors can bring about. Now, as doctors, what are our queries? Is it necessary to test for nutrient deficiency in a patient presenting with hair loss? Or should we look for any risk factors that should prompt testing? Now, in the absence of these risk factors, is there any evidence to support testing or support the use of supplementation? And if at all we decide to do the supplementation, what type and in what concentration should be used? So these are certain queries that we routinely face in our clinic, and the answer to these is challenging because the data that exists on it is so conflicting. There are some studies which show you benefit, while there'll be many others which do not show you benefit. So how do we actually arrive at a decision? So first of all, in the clinic, you evaluate for deficiency. Take a proper history, do a good examination, and order some lab test if you're actually suspecting a nutrient deficiency. Now, in the history, what can be taken? For the women, if we want to rule out iron deficiency, first of all, take history of blood loss. We anyway take menstrual history in a patient with FPHL when she is coming. So not just for the regularity of cycles, we can also ask for the amount of blood loss, which would give us a hint that the patient may be suffering from iron deficiency. Then if there is any malabsorption disorders, or we could assess the amount of alcohol intake. Then certain medicines like antacids, which are quite commonly used, they may lead to iron deficiency. Prolonged use of antibiotics may lead to multiple vitamin deficiencies, and so does the use of multiple other medicines. Now, certain people suffering from, certain people having some special diets, including those who are vegans, may again have deficiency of iron, zinc, and B12. So if you take a proper history in the clinic, you may be able to, actually decide on those group of patients who may be suffering from these nutritional deficiencies, and on those patients, it would be more beneficial to conduct the test as well as do the supplementation. In the clinical examination, again, corresponding to the deficiencies that we are suspecting, we can look for clinical signs, like we can check for pallor if we are suspecting iron deficiency. Then if we are suspecting vitamin B12, we can look for pigmentation on the knuckles and on the palm. So all for vitamin C deficiency, we can ask for history of easy bleeding from the gums. So for all of these deficiencies that we are suspecting, we can do a corresponding clinical examination to be sure. Ultimately, what are the lab tests that we order? So the lab test that we can order can be number one, iron studies, then B12 and vitamin D levels, and very rarely, if we are actually suspecting, then even zinc levels can be ordered in patients where we are suspecting a deficiency. So screening as such is not recommended unless you are suspecting a particular deficiency. Now, these dietary supplements can indeed halt the excessive hair loss and restore the hair to its beauty. However, it is essential to acknowledge that they are only helpful if nutrition is the only cause behind the hair loss. So they just act as an adjuvant to our treatment. They cannot replace the basic minoxidil-based treatment or other anti-androgen treatments if the patient is suffering from androgen excess. So it does not replace those treatments. It only acts as an adjuvant, that too only when a deficiency is the cause behind the hair loss. And until new therapeutics are developed, we can consider adding these supplements empirically as well. I know there'll be a lot of debate on this, but we can add. Then monitoring the use is essential, giving the risk that the toxicity can develop from certain vitamins without supervision, and more research is needed for the guidelines to be developed, for the parameters of supplementation to be well defined. So we do need more research, we need more data to help us decide better. Now, these are data from male pattern hair loss. So this was a study in AGA, but given the factors, yes, ma'am, just the last slide.
Minutes, yeah.
Last slide. So some other changes which have been found to be beneficial in male patients with AGA can also be suggested in female patients with FPHL, including a low cholesterol diet, a low glycemic index diet, improved glucose control, and a fortification with magnesium, because magnesium also tends to improve the insulin resistance in the body. So these are certain other changes that can be suggested in the diet to our patients with FPHL. And with this, I conclude my talk, and I hand over the control to Dr. Latika. I hope I finished in time, ma'am.
Yeah, it was perfectly in time, and you did justice to a complex topic of nutritional supplementation in FPHL. So we all use it left, right, and center, as you said, but then now we understand the logic much better. All right, so now I'm pleased to invite all the speakers for a panel discussion on how I treat female pattern hair loss. So we have, I hope Dr. Rachita has joined back. I cannot see her. And then Dr. Rajita, Dr. Richa, and Dr. Pallavi. So please have your videos on, and please keep yourself unmuted. So I'm going to share my screen. So most of the points have already been covered in the talks, very well covered. I would say that, each one of you has been, wonderful. So we will not waste much time on the things which we have covered, but we will talk on the practical aspects more, so that our audience can be benefited. All right, so just to introduce again, female pattern hair loss, we know it's the most common form of alopecia in women. So it results from a progressive reduction of successive hair cycle, leading to miniaturization of hair follicles with a transformation of terminal hair follicles into vellus-like follicles. So there is a lot of psychological distress leading to impaired social functioning. So our role as physicians is an early diagnosis and initiation of treatment desirable, because treatments are more effective to avoid the progression of hair loss rather than stimulating regrowth. So now I would like to first begin by asking my panelists, like, what is the incidence of female pattern hair loss that you are noticing in your practice? Dr. Pallavi?
Ma'am, quite common these days, especially in the girls in the age group of 25 to 35. So these are girls who are quite often presenting with hair loss in the clinic, and when evaluated, turns out to be female pattern hair loss more often than telogen effluvium.
Dr. Rajita, what percentage do you see, and are you noticing any peaks of ages at which these patients present, or it's distributed all across the ages?
It's difficult to give a percentage, but I would say one clear peak is the perimenopausal age, and the other one is somewhere in the late 20s, I would say. Again, we have begun diagnosing female pattern hair loss much more effectively ever since we started using our dermatoscopes on the scalp. So earlier, all these people would have probably been clubbed as psychological or just a telogen effluvium, and thankfully we are not doing that any longer. The youngest patient that I have diagnosed with female pattern hair loss was a peripubertal age group child with late onset congenital adrenal hyperplasia.
Right. So at an early age, we have to suspect these hyperplasias or tumors, and we have to investigate accordingly. So when a patient with suspected female pattern hair loss presents to you, what clinical evaluation is mandatory? Dr. Richa, if you can take this question.
Clinically, first, the pattern of the distribution is important, but the pattern of the hair thinning. So you want to look at whether the temples, the crown area, and you have to compare it with the occiput. That's most important. Clinically, I would not forget to look very carefully at the face, look for signs such as acne, hirsutism, seborrhea in general, seborrheic dermatitis in particular, and also for other signs of, hyperandrogenism, such as a heavy voice or, male kind of facies or a male look. That would give a general idea of the status of hyperandrogenism Among the bedside tests, of course, trichoscopy is mandatory for each test. But before we come to that, can do a small hair pull test. It's always nice to involve the patient. Also, I don't see too much help coming from it. But overall, yeah, that's what I do.
Anybody else would like to add anything? Dr. Rajita?
No, I think that's good.
Right.
I also do a body mass index calculation, which takes like a few seconds. And I am privileged to have a body composition analyzer. So at baseline, we do get that so that we know not just the BMI, but also how much of excess visceral fat and percentage body fat is there.
Right, that's a very important aspect of knowing the etiology, and then that helps in the management. So whenever like you see a patient with diffuse crown thinning, so do you do everything out of the things which are mentioned, or how do you choose, like which is the basic minimum that you have to do in every patient, and then as per the further parameters we can go ahead with any specialized tests?
Dr. Latika, if I may, excluding scalp biopsy, I think everything. And actually, none of these things take a lot of time.
Yeah, that's what I wanted to highlight, that many a times in a busy OPD, we see the patient, from a distance, we see that they have a widening of the female pattern hair loss, and we just start prescribing. So that has to be avoided, because as we know that, there are so many differential diagnoses which can mimic FPHL. And since the treatment is long, and we don't want to be on the wrong pathway and then regret, after a few months that if we are not leading anywhere. Because I have many times seen that patients were not diagnosed correctly. They were patients of cicatricial alopecia, frontal fibrozing alopecia, and being treated for as simple FPHL and not responding. So now moving on, this is like the clinical pattern that we see, which we all are very familiar with. So what is the most common pattern seen in your clinical practice? What kind of pattern do you see in female pattern hair loss? Anybody can answer this?
I see that there is diffuse thinning with a frontal accentuation. That is the most common pattern that I see.
So do you see a preservation of the anterior?
Yes, absolutely.
Yeah,
Now,
so the Ludwig side.
Only when there is extreme hyperandrogenism with amenorrhea for many months together, you actually see a temporal recession. But temporal thinning is a different story.
Right. So it depends on the age at which the patient is presenting. In most cases, with advancing age, we see much more crown thinning, and but as Dr. Rajita pointed out, it's very rare to have a Hamilton kind of a recession unless there's a substantial hyperandrogenism. So more or less, it's widening of the crown area, the partition.
So which grading pattern do you follow in your clinical practice? If you are seeing the patients, would you grade them with the Ludwig pattern, or would you grade them with the Sinclair scale for practical purposes?
I use the Sinclair.
Sinclair, right. Yeah, that is actually one of the most common use and clinically useful scale to assess the prognosis and the improvement. So what are the features that you look for while doing trichoscopy to clinch the diagnosis of female pattern hair loss? Dr. Pallavi?
And trichoscopy here is mostly to one, look for criteria, and two, to differentiate from the telogen effluvium so that, we can actually make a proper diagnosis. And yes, the single hair pilosebaceous units is the most common feature that, brings our attention to this female pattern hair loss. And comparing the frontal area to the occipital area, the lower levels of thickness in the frontal area, again, are a very important criteria towards bringing our diagnosis towards FPHL. Then the perifollicular discoloration, I don't see that commonly in the Indian skin, but the other two criteria are what I look for in order to come to the diagnosis.
Right. So the hair diameter diversity is the single most important criteria if we are looking at, and then of course frontal more affected than the occipital, and then more number of villous hairs are seen. And other factors are definitely adding to the diagnosis, but we have to differentiate from the other differential diagnoses like alopecia areata or frontal fibrozine, alopecia, and trichotillomania, as we have heard the talks in the morning. And you have very well covered the investigations. So I think I will just skip this slide. And we all know that there are some basic investigations, and then based on the clinical examination, we may do a hormonal profile. So we're coming to some clinical cases so that we can apply these concepts to like practically how we would address such patients in our clinic. So maybe Dr. Richa, you can start with this case 1. So she's a 25-year-old unmarried girl. She complained of hair thinning as well as hair fall for the last 2 years. Her periods were regular, and on examination, her frontal parting was a little wider than the occipital parting. She had associated acne, some dandruff. She did have axillary acanthosis nigricans. So how would you proceed in such a case?
The fact that she is giving, showing signs of acne, dandruff, and acanthosis nigricans, I'd like to get her investigated for a baseline. I'll at least do a HOMA-IR ratio, and again check for her menstrual history. Although it says here it's regular, I'll start her on ketoconazole shampoo for sure, and I'll ask her to continue it for a long time. I'll begin by knowing why there is also concomitant hair fall in this case, because she is describing hair fall for 2 years. So perhaps an investigation involving her complete blood count and ferritin levels also, I'd like to have a look at it, B12 included. And of course, we'll do a trichoscopy and look for all the features that are suggestive. If suggestive of female pattern hair loss, then I'll start her on 5% minoxidil, I think.
Right. And so these are the investigations, she got done, and it was found that she had a high AMH and high serum prolactin, as well as a high PP insulin. And she was deficient in vitamin D and ferritin and slightly raised IgE levels. So she was diagnosed to be PCOS with insulin resistance. So this actually I see very commonly, and I'm sure like Rajita also mentioned this, that PCOS and insulin resistance is one of the most common reasons for female pattern hair loss, and which is presenting at a very early age, especially nowadays, with the disturbed lifestyles. So would you like to do anything about the PCOS or insulin resistance?
Yes, I think she warrants metformin also, although she's she's the lean PCOS, and also cycles are normal. But I think lifestyle management is important in this case again, along with metformin. I would, because you are saying her total insulin, postprandial insulin is raised.
Yeah, postprandial insulin was raised. So, any role of anti-androgens in this patient?
I'm not sure I'm going to start her on spironolactone. No, I would stick with metformin.
Right. So this is how I had treated her. Any other approach, Dr. Rajita? Would you like to?
Yes, please. So I would assess her total testosterone from a good lab. If it is hyperandrogenic, I would certainly give a spironolactone, and I generally prefer a 100 mg morning dose unless somebody is complaining of postural hypertension or weakness, which very rarely in this age group that happens. And I like to give spironolactone along with a combined oral contraceptive unless there is a very strong contraindication or unless the person is perimenopausal. So if she has normoandrogenic female pattern hair loss, I would give her finasteride 5 mg along with metformin and lifestyle counseling. But if it were hyperandrogenic, then I would put her on a drospirenone ethinyl estradiol combination like Yasmin or Casanta, and then add spironolactone 100 mg. You could certainly do 550B.
Okay, now we move on to the next case. This is another young female, 34 years, married, and she is not planning for further pregnancy. She already has 2 children. Her periods were irregular. She had a high BMI with a very poor lifestyle, a lot of stress, late sleeping, unhealthy diet, no exercise. And moreover, she had COVID. So it resulted in a marked accentuation of her female pattern hair loss. And she suffered from dyslipidemia, hyperuricemia, so classic metabolic syndrome. And So how would you manage such a patient? Dr. Pallavi?
Yes, ma'am, this patient could have been suffering from FPHL for a longer time, but I would examine and take history, like you mentioned, COVID 4 months ago. So it could be unmasking of the FPHL by the ATE. So she could be suffering from both these disorders at the same time, the acute telogen effluvium due to COVID, as well as a background FPHL. So evaluation for the FPHL would be more important here, because that is what we are going to treat. And since you've mentioned that she suffers from hypothyroidism, I would see her levels of TSH, assess the thyroid function test to see if that is controlled. Secondly, she has a high BMI, and high levels of serum insulin. So that tell us that there is a level of insulin, component of insulin resistance here. Again, doing testosterone levels in a 34-year-old married lady may not be the best approach. So I may not go for hormonal evaluation here. I will straight away start her on metformin and topical minoxidil with nutrient supplementation, as well as vitamin D supplementation, because that is quite commonly associated with these patients suffering from metabolic syndrome. And that would be it. Spironolactone and combination COCs would happen if her family is complete. So taking history of her reproductive, like taking history of her conception and plans for baby, that would decide whether I would start the COCs. Otherwise, manage only with metformin, vitamin D, minoxidil. And I also start them on Tracnil sachets, no conflict of interest here, but supplementing with myoinositol. So that also takes care of the hormonal milieu to an extent, and evaluate after 3 months.
Right. I think if her obstetric history is clear, I mean, if she's completed her family, then she's a good candidate for finasteride also.
Yes, yes.
Latika, she has menstrual irregularity, you said, no?
Yes, she has menstrual irregularity.
So whatever the anti-androgens you are going to give, except CPA, her cycle will not become regular. So you need to regularize cycle with CPA, and CPA works best when the patient has irregular cycle with underlying dyslipidemia.
Yes, I agree.
Dr. Latika, why not a COC in this lady?
Yeah, see, this is just a sample treatment, but I would like to hear all of the views of the panelists. COC is a good option. Again, I think the one with the drospirenone combination, because she is already obese.
Yes.
So would not like to give her cyproterone acetate.
That will, see, drospirenone is not that well effective in female pattern hair loss, which will regularize the cycle, but not for female pattern hair loss. So you can add metformin along with CPA.
Ma'am, more than drospirenone, 3 mg and 2 mg of cyproterone are equivalent. But the issue is that in combination with drospirenone, you get only 30 micrograms of estradiol. But with CPA, you get 35. So obviously 35 micrograms is going to be superior.
Yeah, but then here your cyproterone acetate is better for your female pattern hair loss than your drospirenone.
Ma'am, in a dose of only 2 mg, right?
Yeah, 2 mg, if you give it for a long period of time, the studies have shown 2 milligram versus your 50 or 100 milligram of cyproterone acetate is equivalent in efficacy at 1 year. So you have to think that you have to give for at least for 1 year to improve her female pattern hair loss.
Right, and we can also combine other anti-androgens like spironolactone.
Yeah, you can combine.
Yeah.
This hypothetically, though, if she's a 34-year-old female with no, I mean, if she's hasn't conceived so far, then we also have to consider other options in her case. I think topicals and PRP, for example, would be a good option in her, apart from metformin.
Yes. So we have to consider, at what point we want to consider these procedures. So, but suppose like she has completed a family and these medicines are working well for her. So because this is a long-term disease, and patient needs to be on some maintenance. And then after 1 year again, we have to see that oral contraceptives also, for how long can we continue. And whenever we continue stop, then there will be again firstly there will be a telogen release, and again the patient has to be kept on some other anti-androgen so that we do not have this relapse. So along with this lifestyle approach, weight loss, all that also we do counsel our patients. So, and then we move on to the next case. This is a 47-year-old postmenopausal woman. She had hair fall for 2 years and complained of thinning of the frontal scalp with the frizziness and roughness of the hair. And she did not have any COVID. And her examination revealed a frontal part widening more than the occipital part, and there was frontotemporal thinning as well. She too was diabetic and hypothyroid. HbA1c was 6.1. TSH was barely controlled at 5. So she was a borderline, controlled diabetes. So how would we manage such a case? She's postmenopausal. So do we have more therapies in our armamentarium once the woman is postmenopausal, and what is the role of procedures in such a case? Dr. Rajita?
So again, I would want to look at her total testosterone and evidence of things like hyperhirsutism. So if none of them are there, then I would love to give her dutasteride. Dutasteride is something that I would not give to a lady who may ever conceive, because it's got a very long half-life. Whereas finasteride, after 1 month of washout, we are happy to let the lady conceive. So this is something that her postmenopausal status adds to her armamentarium. And in addition, I would be quite happy to offer her PRP treatment. And in case she wants something more, then even a low-level laser therapy, adjuvant therapy is something I would not hesitate to advise. And I would want her to do better in terms of her daily sugar control, though the HbA1c isn't bad. So would recheck her dietary compliance and compliance with metformin, which I presume she is on.
Would you start with dutasteride as a first-line therapy, or would you first start with finasteride, and if it doesn't work, then move to dutasteride? What is your...
So for postmenopausal women, I generally like to start with dutasteride. I was inspired to start thinking like this after I read Rachita Bharat's ma'am's paper on this.
Latika, I would differ here.
Yes,
in the terms that this patient doesn't have very advanced grade of female pattern hair loss. Correct. It is just type grade 2, okay, which can be easily managed with your minimum treatment like topical minoxidil and nutritional therapy. You may not require any anti-androgens when the grades are very early. So instead of bombarding with anti-androgens, I will manage only with topical minoxidil and nutritional therapy. If patient doesn't show the improvement or there is persistent hair loss continuously, then I will think over of anti-androgens.
And would you like to also add oral minoxidil in such a case without giving any anti-androgens?
That depends upon how is the miniaturization process when I see under trichoscope. Looking at this clinical picture, it is a type 2 Sinclair pattern, which can be easily managed with the minimum medications. Yeah, our aim should be to have the minimum medication, and when to start the minimum medication, when to start you require cocktail of therapy. We have to decide on the base on hair loss pattern.
And how do you handle patients who, refuse to take these therapies like dutasteride or finasteride because they read and then they will come that this is meant for prostate cancer and, such and such because these indications are off-label and they are not mentioned, on wherever the patients are reading. And many of my patients, they just refuse, and then we have to treat them with very, very, level line 1 therapies. So
no, when you decide that this patient needs either dutasteride or finasteride, you can show them the papers and before and after photos from the studies and let them take the decision. Now, moment they know that their response is not getting better with a given existing treatment, they will come back to you and then they will say that, yes, you can, I'm willing to take this medication.
Yes, so that's where the
exactly
role of
my
counseling.
approach.
Yes,
Exactly.
Dr.
This age group people, especially if they have advanced FPHL, are quite happy to. It is the younger people who are yet to get married, yet to get.
Yeah, they will not take.
Here, the resistance is much higher, and the resistance is the highest to combined oral contraceptive more than to anything else.
Yeah, but that they have the valid resistance, I feel. Now, if you are me and in the same position, we would behave same way.
Yeah, exactly. Practicing restraint while, the idea, what I always do to the patient is give them the entire information, but also give them a month's time. I tell them, if you're not showing much improvement in a month, which anyway is not going to happen, then we'll put you on these. So that's one trick up my
sleeve. It's not necessary that your dutasteride or 5-alpha reductase would help. Your low-level light therapy, simple microneedling would help.
Okay, so we move on to the next case. Now, this is a lady most menopausal with the grade almost 5, grade 4 to 5 Sinclair pattern. She had pre-existing female pattern hair loss, which worsened significantly due to post-COVID telogen effluvium. And again, she was diabetic, hypertensive, and she was controlled on medication. And so how would you now, like, this is an advanced case, Dr. Rachita, what are your views on managing this case?
See, this patient requires some anti-androgen. A choice of the anti-androgen depends upon patient's history, medical examination, trichoscopic examination. Now, she is 51 years. Probably I would go for dutasteride.
What dose of dutasteride would you like
I generally start with 0.5 milligram 3 times a week, not a once a week.
Right. So since like she had worsening of the female pattern hair loss due to COVID, would you like to wait for the hair fall to recover with some non-anti-androgen therapies because she does have acute telogen effluvium? Or
no, I will treat acute telogen effluvium with the help of non-minoxidil preparation. Okay, and I will still add dutasteride and nutrition supplement.
Right. So this patient, I had put on topical minoxidil with nutritional therapy, and I had started her on a low dose of oral minoxidil. And so I don't have the later follow-up, but within like 2 months, she did recover her pre-COVID baseline at least, but like she still has female pattern hair loss. So I think dutasteride or any other anti-androgens would help to maintain her hair density. So then just, talking a little bit more about minoxidil, Rajita has covered it very well, but, this minoxidil is the first line therapy, which even without any investigation or even without, any other comorbidity examination and everything, we can straight away start. So Rajita is a very firm believer of 5% minoxidil. So do all the panelists, agree with her, or do you have a different take on the preparation, the strength? And generally, like, what is your attitude when you are prescribing minoxidil? So do you counsel the patient beforehand? What all do you tell, and what all do you tell her to anticipate? Anybody?
I'm not so against using 2% minoxidil. I do start with 2% minoxidil solution also, especially in more patients that I find have looking a little bit more sensitive to me, and then I hike it up gradually to 5%. And of course, I counsel them to apply it a couple of hours before bedtime. I do counsel them about the potential of irritation and the fact that this is a practice that they'll have to follow lifelong, so they better get used to it. I prefer the alcohol containing solutions because I feel they have got a better efficacy. But yeah, if there is a problem with them, then I go for other aqueous preparations as well.
Dr. Pallavi, any views on minoxidil?
Ma'am, I only use the 5% ones. I haven't used the 2%
and
myself.
Do you prefer combinations or do you prefer plain minoxidil?
Minoxidil with procapil is the one that I go for. And yes, as Dr. Rachita also mentioned, I ask the patients to use 1.5 to 2 ml. 1 ml not to be used by the women for me. So it's about 1.5 to 2 ml. And to be used 30 minutes before they lie down on the bed, then to avoid having the solution drip to the forehead. That's a very important instruction, especially for our, the female patients. So not to bend forward or let it drip to the forehead. I ask them to tilt their head back and lie down after 30 minutes. And in the first 1 month, they may notice excessive hair fall. So that is completely okay with minoxidil, not to get scared with that, because that is a very important side effect, not side effect for us, but for them, that they notice that the first 1 month follow-up that they come with, they say that the hair fall has increased. So if you've already counseled beforehand, so that is one task less for us. So these are certain, counselings that I do with minoxidil.
There is a question from the audience. Dr. Seema Nair wants to know, if 2 ml of minoxidil is used at a time, does it lead to higher chances of lightheadedness? Dr. Rajita, did you ever hear that complaint from anybody?
No, it doesn't. Even with 10 milligrams of oral minoxidil, lightheadedness does not happen. And when you're applying this, it is not like everything is going into the bloodstream. But yes, there may be a psychological effect, that because once you read the product insert, then all kinds of things start happening.
Okay, I'll answer to that. Lightheadedness is due to the absorption of minoxidil into the circulation, which can happen rarely in some individuals. It has been shown that in circulation, if the minoxidil concentration is more than 20 nanogram per ml, then you can have all systemic side effects. And one of them is your lightheadedness. That could be possible. Even blurring of vision is also possible with your minoxidil. So various individuals have different type of absorption of minoxidil, and their minoxidil concentration in circulation would be different. But however, majority, the studies have shown that majority of them have lesser than 20 nanogram of minoxidil in circulation, and hence they do not get any systemic side effects.
Okay. So Pallavi has covered the role of nutritional supplements. So I don't want to go into too much detail, but there is a question. What is the advice on cyclical nutritional therapy? So Pallavi, would you like to take that question? What in the morning it was discussed in the morning session. So would you like to comment on cyclical nutritional therapy?
Definitely, yes. It is
in which cases would you give a combination, fixed combination, or in which cases would you give a cyclical nutritional therapy?
Ma'am, where multiple deficiencies are there in a patient, there a cyclical supplementation would be more effective, because giving them so many pills to take in one day is difficult. That's what I feel. So in such patients, having the weekly cyclical therapy is much more beneficial. Rest of the members as they also suggest.
Thank you. Moving on to the next topic. So these are, we have already discussed these oral anti-androgens. So we have the choice of using spironolactone, cyproterone acetate, finasteride, dutasteride. We have flutamide, and we also have bicalutamide. So are you using it as like this is the first line for mild to moderate, and then for severe, do you have a different choice, or do you try one therapy for some time and then for how long do you wait and see the effect and then move on? Dr. Rachita Durat ma'am?
See, the choice flutamide and bicalutamide, amongst these two, bicalutamide is better. The person who's not having obesity, not having acne, I would prefer to go for bicalutamide. Person with acne and menstrual irregularities, my choice would be spironolactone and CPA, cyproterone acetate. Now, finasteride and dutasteride would be for those patients not having these problems, menopausal, postmenopausal, even premenopausal, but I should be very careful in premenopausal unless they complete their family, because the half-life of dutasteride is very long, and it can be detected in the tissue for 4 to 5 months. So I can't tell you that which would be my first choice. That depends upon the person to person. I need to individualize.
Right. So there is an audience question. Dr. Vrinda wants to know if menstrual irregularities happen with spironolactone, do we have to add OC pills or do we have to stop it? So
there are two options. There are two options. One, spironolactone induced irregular menstrual irregularity happens only in 22%. If it happens, you have to see what dose it happens. Now, if the dose is 25 milligram, then you need to stop it. You can't cut down below 25 milligram. If it is 100 milligram, you try to reduce to 50 milligram. Observe the patient is getting menstrual irregularity even at 50 milligram. Then probably you need to add OCPs.
Okay.
Dr. Latika,
yes,
I totally agree with Rachita ma'am, but what I do is just the opposite. If it is a lady who has who's yet to reach menopause or who is still in her 30s, I would start a COC and give her spironolactone and or finasteride. Finasteride would be a drug that is safer in terms of menstrual irregularities, but it will feminize the male fetus. So please always put that seal on every prescription. Whether it is any of these drugs, you need to give them the pregnancy warning, because we don't want to get into legal trouble. And one strong thought about flutamide I have is flutamide should not be used by a dermatologist ever, because it's not only been linked to a dose-dependent hepatotoxicity, it's been linked to a idiosyncratic hepatic reaction.
No, Rachita, I disagree. There are two papers which have it is not idiosyncratic hepatotoxicity. It's only dose-dependent hepatotoxicity.
Ma'am, there are enough papers on this.
No, there are enough long studies done. I'll send you that paper.
I have an update on that. So we will all look up this thing and clear this controversy.
One thing. And flutamide, in the best case, is equivalent to spironolactone if you can match the dose. And we have something safer like bicalutamide.
We have bicalutamide, yeah.
When we're forced to go stronger on anti-androgenic treatment, it is in hirsutism. It is very rarely in female pattern hair loss, because in terms of how strong you have to go on anti-androgens, you hardly ever have to go beyond 100 mg spironolactone in female pattern hair loss. Whereas even with 200 mg spironolactone, sometimes with a good COC, you are at your wit's end in hirsutism, and then you bring in bicalutamide.
So Dr. G.R. Ravindan wants to know how long a patient on anti-androgen is advised to abstain from unprotected sex. So basically, how long before she should not conceive?
For as long as she's on the therapy, and for 1 month of washout.
For dutasteride, it is for a few months, 4 to 5 months.
5 months. Which anyways, we don't like to give to a woman of
who may ever conceive. Better to avoid dutasteride.
Okay, moving on. Now coming to the hottest topic, hottest molecule, the oral minoxidil. So out of our panelists, are all of us using it or yet to start using it? And
I'm not using it.
I am also not using oral minoxidil, ma'am.
Right.
I hope you change your...
I'm using
just
every
so
day.
scared of them coming to me with another problem. You want to sell your laser treatments, you're prescribing me the oral minoxidil. That's one thing that's keeping me on.
Latika, I use oral minoxidil because we have done studies on sulfur transferase enzyme. They are published 4 studies based on that. And I realized that 40% of the individuals, Indian individuals, having a lesser expression of sulfotransferase enzyme. So thereby their response would be lesser in our Indian population. And believe me, I've been giving oral minoxidil when we had last trichology update in 2017, when Dr. Sinclair had come, and he shared that he started with a low dose oral minoxidil along with 25 milligram of spironolactone to reduce the weight gain. And since that time, I started using oral minoxidil. However, that time the oral minoxidil was available as a 5 milligram. And I used to instruct my patient break the 5 milligram tablet into 2.5 and take it on alternate days basis. And yes, I have not seen the cardiac toxicity. I have not seen systemic side effects. But however, hirsutism I have seen. If the patient is okay with a mild hirsutism, where you have many options to treat hirsutism, then patient continues with oral minoxidil. If patient is not okay, then I stop it. That is my approach.
Hypertrichosis.
Hypertrichosis.
Correct.
Hypertrichosis.
Dr. Arpita wants to know for how long can we give oral minoxidil safely, and should we taper it before stopping?
It's same like what you give for the topical minoxidil. The response would be better with the oral minoxidil. And there's nothing like you have to taper it or nothing like that. You have to substitute. See, the point is that moment you stop anything, it's going to bounce back.
Yeah.
So you can stop oral minoxidil, you can start topical minoxidil.
Yeah. So this table just summarizes all the, anti-androgens, and with the addition of ketoconazole, which Dr. Richa has already covered, which has the effect of decreasing the DHT levels at the hair follicle. So whoever was asking for the doses can take a quick screenshot. And bicalutamide, we use 50 milligram per day. Somebody was asking. So bicalutamide dose is 50 milligram once a day.
Or you can go for the lower dosage also.
Go for the lower dosage also. Yeah. Now, a very important aspect of moving away from androgens, because we know that female pattern hair loss is not just caused by hyperandrogens, but it is a very important association of metabolic syndrome and insulin resistance. So what is the role of treating insulin resistance, and whether you would like to treat it yourself or would you like to refer it to a physician? Any panelists can take this up.
Referring to endocrinologist depends upon what type and symptoms a patient has. If a patient has a multiple metabolic syndromes, then it is better to take endocrinal opinion also. But patient has only acne and insulin, high levels of insulin, so you can treat. If the menstrual cycle is irregular, then I feel that we are capable of treating such patients.
Yes, especially if insulin resistance is there and HbA1c is normal, and most of the endocrinologists will discourage them to use metformin, and then we have to really take it on ourselves and convince the patient. And I think Rajita has might be having something to talk on it, because I know it's a favorite topic.
Yeah, so a lot of endocrinologists have this attitude, sadly, that they tell the patients, when you're diabetic, you come back. It's very sad.
They are just waiting for them to get diabetic, and we tell them that we're trying to prevent your diabetes.
In addition to what Rajita ma'am had said, if a lady has to conceive, I generally send them, because if you and I start metformin, then the gynecologist is going to get involved in the infertility therapy, and then all this happens. But in spite of all our efforts, metformin phobia is high. So there I resort to usually N-acetylcysteine, or sometimes even a myoinositol. Pioglitazone is something that I don't like to give. It's been banned and then again brought back, and again banned, again brought back. And it causes weight gain. So I don't like glitazones actually, except for LP pylorus.
Yeah, we have to see as per the patient comfort and our assessment of the patient is willing to take or not willing to take, what is the understanding of the patient. So many factors, which determine. And now coming to the procedural intervention, time is very short, so we will be just, because everything has been talked about. So I just would like to know that we have these procedures with us. So which is the type of patient in which you will consider? Would you start it straight away? In which grades? And then which is the procedure you would like to choose? Dr. Pallavi?
My go-to procedure here is platelet-rich plasma. So PRP therapy combined with microneedling is what would be the first intervention apart from the medical management. And yes, low-level laser therapy can be added depending upon the need, but first would be PRP with microneedling.
Dr. Richa?
Above grade 2. Yeah, I agree with her. In patients above grade 2, this is my approach as well.
But would you like to start the procedures simultaneously, or would you like to wait for some time?
No, I would like to start the procedure simultaneously. If I'm seeing an advanced grade, I would certainly start it simultaneously.
In my case, I would actually wait for the second consultation, which is about 2 months before I, ask them to take the procedure, because that is when they're more convinced to go for an additional procedure. Like first 2 months would be medical and then add on the procedure.
I do something similar, because typically it takes you a month to get the investigations and then correct and a month and a half to 2 months to correct the nutritional and the endocrine issues. So 2 to 3 months is when I start with PRP. I do not do microneedling, and I offer PRP therapy to everyone who's beyond grade 2. From grade 3 Sinclair is when I typically start. But sometimes even grade 2 Sinclair, if they're very, very concerned about it, I don't know.
Dr. Rachita, are you doing autologous micrograph therapy?
No, I don't do.
Okay, and which is your favorite procedure? Is it platelet-rich plasma?
That depends upon patient budget. If the patient budget is not very good, then I can offer only microneedling or PRP along with microneedling I do. But however, I see to that I don't deliver growth factors by way of microneedling. I inject PRP and then I do microneedling. In the patient with the Christmas tree pattern, I would go for hair transplantation, counseling on hair transplantation rather than wasting patients' money on PRP or microneedling, because this is a very resistant area. The patient has a Christmas tree pattern, then only option is only hair transplantation. That also depends upon what grade of Olsen stage.
All right. Dr. Uputari from the audience wants to know what is the ideal microneedling depth for the scalp?
You are not going to go deep like what you go like in the stamping method. Here the aim is stimulation of creating inflammation on the skin surface. Thereby that inflammation will stimulate the bulge area. Whenever there is an injury on the surface, the bulge area of the hair follicles gets stimulated.
It's about 1.5 to 2 mm. I'm not wrong.
No, even if it is 1 point, it's not going to penetrate that deep.
Yeah. So around 1 mm is enough, right? 1 to 1.5 mm.
That is enough, but the idea is that the longer while you require, because then your hair do not get tangled into the needles. Rolling become easier.
Easier. And so when we are offering the procedures to the patients, so what should we tell them? Whether the result, what is the added advantage of the procedures? Is it going to improve the percentage density? Is it going to fasten the regrowth? And then what about the maintenance? Do we tell them, what do we tell them about this? Because, it's an expensive procedures and patients do ask these questions.
maintenance is not required unless the patient gets hair fall again. Now, that is not called as a maintenance. That is a retherapy again. So once, see, basically you are enhancing the your hair growth. So once the enhancement of the hair growth is achieved over a period of 4 to 5 months, you try and maintain with medical line therapy. Most of the time, hair response can be maintained on a medical line therapy thereafter, but the 90% of the patients stop medications once the treatment is over, and during their maintenance treatment, not maintenance, during their medical line therapy, they do not continue the treatment. And they come back to us with a hair fall.
Anybody is prescribing this low pulse laser light therapy either in the clinic or
yes,
nowadays?
I do. Those who are not willing for any kind of the procedures, or those who have got the response, but still sometimes, I'll tell you, sometimes you get a response, that new hair growth, but simultaneously there is hair fall also continues. I don't know whether you have seen that.
Yes.
Hair fall continues, but response is also there.
Yes.
So that time you can add low level therapy.
Right. So it has shown to be effective increasing the hair density. So whenever we are doing the follow-up, at what interval do you call the patients initially, and then once they have got the result, how often do you call them for follow-up, and do you do the photographs at every visit? Do you do trichoscopy at every visit? And how long do you wait before judging if a particular therapy is working or not, before changing on to a new molecule or increasing the dose?
The first two consultations are a month apart. And after that, at least 3 months apart. And yes, there is photography and trichoscopy at every visit.
Right. How long would you wait? Would you give any therapy 3 months or 6 months?
6 months. 6 to 9 months, in fact. 6 months, actually.
Right. Do all panelists agree on that?
Yes.
Yeah.
Okay. So this is just for the audience. This just summarizes. This is one of the algorithms from a paper from International Journal of Trichology from Dr. Jerry Shapiro's team. So it just summarizes that if the scalp involvement is less than 20%, then topical therapy with 5% minoxidil may suffice. And if the scalp involvement is moderate, then we have to combine minoxidil with an anti-androgen. And, again, after 6 months, we review either we increase the dose of the medication or we move on to the next line of therapy. And if there is a 50% more involvement, more than 50% involvement, then we have to straight away consider the surgical procedure like hair transplantation and along with the medical therapies. So hair transplantation has already been covered. So like Dr. Rachita mentioned that we do not, waste time and money for the patient if we find that, patient is a good candidate for hair transplantation. So, and the patient should have a good density in the donor site over the occipital scalp. So with that, we come to the end of the panel, but there are just a few questions, some interesting questions remaining, just 2-3. And with that, we will wind up. So Dr. Arpita has asked that wouldn't microneedling cause fibrosis? So I think Dr. Rachita has already answered that it causes inflammation, which is necessary for the stimulation.
By the way, it doesn't cause fibrosis. To cause fibrosis, you require particular TGF beta family. TGF, I don't remember, there are TGF beta 1, 2, and 3. Out of 3 is more for fibrosis, and microneedling does not cause enhancement of this TGF beta 3.
All right. How to treat microinflammation on the scalp? So I think Dr. Pallavi has covered with the use of antioxidants.
And also if we add the ketoconazole shampoos, if there is associated seborrheic dermatitis, which also contributes to the microinflammation, the Malassezia fungi. So adding the ketoconazole shampoo also reduces the
microinflammation, and so does the dietary supplements, which include the antioxidants and anti-inflammatory agents.
Okay.
And there is not that we use it now, but initially there was also some role of topical steroid applications, lotions for the first 1 to 2 months to reduce the inflammation. So these take care of the inflammatory cascade.
Dr. Shivani has asked, could you please give a list of ingredients to look out in sunscreens and leave-ons that may trigger FPHL or FFA? So,
oxybenzone.
Oxybenzone. Right. So, in fact, I remember, Dr. Rachita in the Trichology update, Dr. Shapiro had once mentioned that, you should avoid applying sunscreens right near the hairline.
Yes.
So that is something which we can follow and advise our patients.
It might be a good idea to just stick with a physical sunscreen for such people.
Yeah, that makes sense. Will minoxidil cause nasal congestion? Has anybody heard of this adverse effect, nasal congestion with minoxidil? I don't think.
Not in my practice.
Yeah, it's not a reported side effect. Maybe, sometimes patients, they attribute to many of these, incidental findings with whatever drug you are starting for them. So nothing has been mentioned in the literature. Yeah, and just to end, counseling, which is a very, very important part of management. So we can address, what is the prognosis, what some education about the disease, and then about the lifestyle. So I think the first consultation, a lot of time goes in counseling. Do all of the panelists agree on this? And
yes. Counseling about the stress also. They get stress of hair fall.
Yeah. So can you all
nights.
Yeah, can you all share one by one, what is the magic words that you use for your patients? Because, like this is female pattern hair loss and the disease is, it's a long-term disease. So do you have some,
Most importantly,
yeah, maybe, Dr. Pallavi, you can start.
Ma'am, most importantly, it is the timeline of the treatment that has to be counseled to them, that this is the amount of time that is going to take for us to bring about the benefit, and stopping or maybe reducing the hair fall, making it stable is more important. The second thing that we will go for is regrowth. So their first concern is, when will all my hair come back? So that part of counseling is very important. Then the timeline and the stress part. Apart from that, if PCOS is associated, then weight loss and other, like as case-to-case basis, but mostly stress and timeline of management are the most important in the first session to counsel the patients.
Right, Dr. Richa?
So I'd like to explain to them the pathogenesis with a little PowerPoint presentation I've made with some animations so that they understand where we are going with this. So once we are on the same page, then we can prognosticate better.
Yeah,
for a lot of other diseases.
To them that it takes 3 months and all that.
Yeah, the hair cycle. Yes.
Yeah. Yeah, Dr. Rajita?
Most important.
Difficult. When patient has so much psychological distress, I have seen patients are crying in front of me. I just hug them and I tell them that I am with them. Don't worry, you'll be okay. If you make more stress, all stress will come to your hair rather than going into your vital organs.
Very nice.
So I do something similar. I give them hope. So sometimes we tend to be very defensive, we tend to tell them all the negatives. We give them disclaimers that don't expect too much, so much hair won't come back. All this I reserve. So initially I tell them, we're going to get through this. We are going to control your hair shedding. I also use one picture of a drain test. I have so many of those pictures lying, not pictures actually, the actual ones lying around. I show them, very casually I tell them, I want you to bring me one of these drain tests. Like this particular lady came with this much of hair shedding, and when she came to this point, I told her to stop collecting the hair. So I want you to come back with something like this. So I think it's important to give them hope. Hugging is great. I'm not very physically, comfortable, I guess. So, but thank you, ma'am. I think that's a great lesson for all of us, including the panelists.
Yeah, I think our patients, they need that hope from us, especially, when hair means so much to women, not only women, but men also, but especially for women, it's their crowning glory. So, so we, with all our drugs and with all our procedures, and then with empathy, and then, kind of motivating them to follow the lifestyle, and then, showing them the pictures. And so all this, goes a long way for treating this frustrating and challenging condition. But so I thank all my panelists for contributing to this panel discussion and enriching it. And I'm sure the audience enjoyed the discussion as much as I did. And there were wonderful takeaway points. And hope to, see you all again. And thank you, Dr. Reddy's, and thank you from IWDA. And it was a wonderful experience hosting and moderating this session. Thank you, everybody.
Thank you.
Thank you. It was a wonderful session. Being with all
Thank
of
you. Thank you, Dr. Latika ma'am, and Dr. Rachita ma'am, Dr. Richa ma'am, Dr. Rajita ma'am, Dr. Pallavi ma'am, for being a part of the faculty for the second session of the International Women's Day's Trichology CME that we had today post-lunch. So before we conclude, I would like to thank Dr. Latika Arya ma'am for beautifully moderating the second session as well, and ensuring that the comprehensive outlook towards FPHL is, discussed, and it is in a very engaging session. I would like to thank Dr. Rachita ma'am for taking us through the history and the clinical examination of female pattern hair loss. Dr. Richa ma'am for going through the management for the female pattern hair loss. Dr. Rajita ma'am for taking us through where do we stand with terms of minoxidil today. And Dr. Pallavi ma'am for taking us through the role of the nutritional supplements in female pattern hair loss. So it's a comprehensive view, a bird's eye view on the female pattern hair loss, and I'm sure the audience have loved it. And again, a lot of new insights and new pointers for them. So with this, I would like to conclude today's session. I'm sure we are 30 minutes over the time that we had allotted for this meeting, but it's an engaging session, and I'm sure the audience must have loved it. So thank you once again for being a part of this initiative by Dr. Reddy's, which was on behalf of Indian Women's Dermatological Association. Thank you once again.
Thank you.
Bye.
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 Can I end the session? Hello?
Hello?
Can I end the session, sir?
Yes, yes, yes.
Thank you.